Welcome to the 2025 Know Your Net's Virtual Patient Education Conference. I'm Elise Gellerman, CEO of NETRF, and we're honored that you have joined us today. This is the sixth Know Your Net's program, and we're so proud that the conference has grown every year. Today, you are among 1,000 fellow neuroendocrine cancer community members. Know Your Nets is made by and for you. By responding to our surveys, you have helped to shape this year's conference. You told us what you'd like to learn from the program, and we listened, so we thank you for that. Today, you will hear from researchers and experts on new treatments and trials and the importance of research, and you'll gain wisdom on living fully from neuroendocrine cancer thrivers. I want to take a moment to recognize the incredible community that has gathered for this event. We have participants from every state in the United States, and we're joined by people from 43 different countries around the world. 77% of you are patients, and another 15% are caregivers. That means this space is full of insight, strength, and compassion. For 2/3, this is your very first neuroendocrine cancer education program, so we especially want to welcome you. About 1/3 of you have been diagnosed within the past 1 to 2 years. Whether you're newly navigating this disease or further along, you belong here. This year, NETRF is celebrating a milestone. It's our 20th year of funding research and educating people with neuroendocrine cancer. For 2 decades, we've been at the forefront of advancing neuroendocrine cancer research, and we're incredibly proud of what we've achieved together. NETRF is now the largest global funder of neuroendocrine cancer research. When we began, there were 2 approved treatments for NETs. Since then, thanks to years of research, collaboration, and sustained investment, 7 new therapies have been approved. Later on, you'll hear about NETRF's research priorities and our commitment to funding breakthroughs today to develop cures tomorrow. Just as we have been driving research, we also educate and empower patients and caregivers. We are committed to helping you understand neuroendocrine cancer, make informed decisions about treatment, and know that you are not alone. In addition to Know Your Nets, we offer a number of invaluable patient resources, including the Net Knowledge Center, a patient guide, the NetWise podcast, and our video library. Visit netrf.org for more. Some quick notes about our program. Please check out the conference booklet for more on our speakers and sponsors. If you have questions for our live Q&A panel, you can submit them through Slido on the conference page. Know Your Nets is a team effort. We are grateful for the many NET and NEC experts who will be speaking today. Special thanks to our co-sponsor, University of Chicago Medicine. This program would also not be possible without all our sponsors, Exelixis, Curium, Crinetics, ITM, and RaiseBio. We start today with several presentations about breakthroughs in research and innovation. It is my pleasure now to introduce my co-chair, Dr. Xavier Koitkin. He is the director of the University of Chicago Neuroendocrine Tumor Center. Dr. Koitkin is a surgical oncologist with expertise in neuroendocrine, thyroid, parathyroid, and adrenal tumors.
Welcome all to the 2025 NETRF Know Your Nets Patient Conference. We're really excited to have you here today. It's been my 7th year as the co-chair of this event, and I've been privileged to work with NETRF for such a long period of time. I think we have achieved a lot over the last 7 years, and I believe that this year will be one of our best programs yet. We have a fantastic crew of speakers from all over the country, and we're really excited to share their presentations with you today. I hope that you will enjoy the day, and we will see you for a question and answer session at the end of this event. Thank you. And as we continue our exploration to the advancement of immune therapy, it is my pleasure to introduce Dr. Jennifer Eads, who's professor of clinical medicine at the University of Pennsylvania. She's the physician lead for gastrointestinal clinical research and a director of the UPenn Neuroendocrine Tumor Program. Please join me in welcoming Dr. Eads as she presents on expanding possibilities with recent developments.
Hi, my name is Dr. Jennifer Eads. I'm a GI medical oncologist at the University of Pennsylvania Abramson Cancer Center. And I'd like to thank the Neuroendocrine Tumor Research Foundation for asking me to present to you today on some very exciting new developments and things that are coming along down the pike for patients with neuroendocrine neoplasms. So the title of the talk today is Expanding Possibilities and Recent Developments. So the objectives of our talk today are going to first be to review the importance of the somatostatin receptor and opportunities for targeting it. It is one of the things that we've capitalized on the most over the last several years, and we'll just have some sort of brief discussion on this. But then we'll spend the majority of the talk really on immunotherapy, and we'll start by defining immunotherapy and how the immune system may be manipulated to treat cancer. And then we'll discuss the various immune-mediated approaches being evaluated in patients with neuroendocrine tumors and neuroendocrine carcinomas. So first, as I mentioned, targeting the somatostatin receptor, something that's been really critical to us over the last several years and is the foundation for peptide receptor radionuclide therapy, or PRRT. Many neuroendocrine tumors express the somatostatin receptor, and we can really capitalize on this for both diagnostic and therapeutic purposes. Many of you are probably familiar with dotatate PET imaging, which is a much more refined imaging modality that we have for visualizing neuroendocrine tumors. You can see in the picture on the left that as compared to the CT scan at the top of the picture, that the dotatate PET imaging gives us a much more refined look at the degree of tumor involvement in a given patient. And then on the right, this is a depiction of how PRRT works. So essentially what PRRT involves is that you have a radiopeptide that is injected into the blood. That radiopeptide then binds to a receptor on the cell surface, so in this case, the somatostatin receptor. It's then internalized into the cell, and we get release of the radiopeptide within the cancer cell. So PRRT allows for essentially targeted radiation therapy to be delivered to the neuroendocrine tumors. It's relatively sophisticated. So that's been one of our major developments over the last several years. And the way that we're currently trying to enhance that is largely through alpha emitters. So currently, the PRRT that most people are receiving and are familiar with involves a beta emitter, which you can see in the picture on the right here. A beta emitter kind of generates its energy that wanders a bit and is not specifically targeted towards something very close to it, but rather travels throughout the cell and is of lower impact. Whereas an alpha emitter, which you can see in the top panel, is more of a very direct focus of energy and a large hit. So we essentially get a higher linear energy transfer with alpha particles as compared to the beta particles. And what this results in is a greater degree of double-strand DNA breaks, and that allows for there to be a greater degree of cancer cell death. So this is an area that's still being actively investigated. There was a trial that was recently presented, the AlphaMedix 2 trial, that utilized a lead-based alpha emitter therapy, and they assessed for safety, tolerability, and efficacy. And we see in that trial that the response rate of neuroendocrine tumors to this type of therapy was over 55%, which is, I think, better than anything we have in any other type of treatment that we have for neuroendocrine tumors. And in comparison to NETR1, which was the trial that PRRT is based off of in this country, we saw a response rate of only 18%. So alpha therapy is looking promising, but this is largely an area of ongoing investigation, and there are a number of trials available throughout the United States and beyond that are ongoing at this time. So as I mentioned, we're really going to be focusing primarily during this talk on immunotherapy. So I wanted to make sure that everybody has a good understanding of what immunotherapy really is. So this is essentially an approach to treating cancer that attempts to capitalize on the patient's own immune system, where the immune system identifies a cancer as foreign and therefore attacks it. So there are multiple ways for us to manipulate this system. One is to lift any blocks on the immune system in the cancer. So some cancers, they have a resistance mechanism that allows them to sort of not allow the immune system to attack them. And this approach is largely through the use of immune checkpoint inhibitor therapy, which we'll talk about. And then the other way is that we can really try to force an enhanced engagement between the immune system and the cancer cells. And there are a number of ways to do this, all of which we will go through, but that includes antibody drug conjugates, bispecific T-cell engagers, chimeric antigen receptor T-cell therapy or CAR-T therapy, and the use of tumor-infiltrating lymphocytes. So the immune checkpoint inhibitors are the ones that are probably the most well known to everyone. There are multiple commercials on television talking about their use in the treatment of many types of cancers. And the way that these work is that there are signals that are present between the immune T cells and a tumor or other types of cells that can control if the tumor might be attacked by the immune system. And that's really depicted in these images on the right, where you can see in that panels that say without immunotherapy that there's this engagement between the T cell and another cell that sort of says, nope, you're not going to be allowed to attack. The immune checkpoint inhibitors act on these blockages and allow for these signals to be lifted so that the immune system can then attack the cancer. And you can see that as depicted on the right side of each of these images, where you have either an anti-CTLA4 antibody or an anti-PD-L1 or anti-PD-1 antibody, disrupting that connection between the T cell and the tumor cell or some other type of cell. And that release of the blockade on the immune system allows for the immune system to then go ahead and attack the cancer. Unfortunately, in neuroendocrine tumors, we don't really have much of an immune-mediated element to this disease process. So in order for immunotherapy, like I just referred to work most effectively, there oftentimes has to be a high level of mutations present in the tumor. And different tumor types can have different mutational burdens. And you can see this in the figure on the right. So cancers such as melanoma or lung cancer have a very high frequency of mutations in their tumors, whereas neuroendocrine tumors, where you can see depicted here on the figure by carcinoid, have a much lower mutational burden. And as a result, the immune checkpoint inhibitors don't really work very well on this particular type of cancer. And we've done multiple trials of immunotherapy with the immune checkpoint inhibitors in patients with well-differentiated neuroendocrine tumors, and they've largely been unsuccessful, with response rates being only 0 to up to 9%. We have had a little bit more success in the more aggressive high-grade neuroendocrine carcinomas, which behave more like some of these other more aggressive cancers. But generally speaking, we haven't really been able to make a lot of progress with the immune checkpoint inhibitors in the neuroendocrine neoplasm space. So that brings me to talking about those other 4 mechanisms that I mentioned, where we're essentially trying to force the immune system to engage with the tumor. So one way of doing this is by utilizing that somatostatin receptor that I referred to previously. So essentially bringing the immune-mediated therapy to the somatostatin receptor. So we can engineer some of these treatments to bring the immune system in closer contact with the cancer. You can see in the figure on the right here at the top that in a normal immune system and its interaction with a cancer cell, that there really is this connection between the two that does not necessarily allow for immune activation. With a medicine that can be engineered, such as a bispecific T-cell engager, this is a molecule that essentially allows for there to be a connection to the T-cell, and then also some kind of receptor present on the tumor cell. So in the case of neuroendocrine tumors, oftentimes this is the somatostatin receptor. And by the medication having this ability to connect to both cells at the same time, it allows for this T cell to be brought into close communication with the cancer cell, and then you get sort of engagement of the immune system. So we have simultaneous targeting of the somatostatin receptor, for example, on the neuroendocrine tumor cell, and CD3, which is a molecule present on the surface of T cells that results in an enhanced activation of the immune system in close proximity to the neuroendocrine tumor cell. So this specific example of a neuroendocrine tumor cell interacting with a T cell through a somatostatin receptor is something that is currently in development. However, there is an agent that has been approved that is looking promising in neuroendocrine carcinoma, so the higher grade, more aggressive neuroendocrine carcinomas, but is not yet sort of broken through in that area. And that is an agent called tarlatamab. So this is a bispecific T cell engager that targets DLL3, which is a molecule that's present on the surface of many high-grade neuroendocrine carcinoma tumor cells, and then also targets CD3 on the T cell. So this agent has been studied and subsequently approved for patients with small cell lung cancer, which is important for us because there are actually a lot of things that we believe are in common between small cell lung cancer and high-grade neuroendocrine carcinoma. So when we see a treatment that is promising in small cell lung cancer, we often wonder, would it have a place in high-grade neuroendocrine carcinoma? So fortunately, DLL3, which is the target of this medication, is also seen on the surface of a very high percentage of high-grade neuroendocrine carcinomas. And so now tarlatamab is being investigated in the high-grade neuroendocrine patient population. To just kind of give you a preview of what this may look like, hopefully, our hope would be that we could do as well as in small cell lung cancer. But in the trials of small cell lung cancer, we saw that there were responses in about 35% of patients. This figure here depicts kind of what the onset and duration of response looked like in that 35% of patients. These figures are reflective of two different doses that were administered in the trial. And the green triangles reflect when in the course of treatment the response was seen. So usually after 6 to 8 weeks, we see that there is a response. And then you can see from the blue lines how long each of those patients responded to the treatment in terms of the number of weeks on therapy. And some of these patients are on for over a year, and we get pretty favorable results. So again, this is only a diagram reflecting the patients who responded to the therapy. Only 35% of patients responded, but it does show what the trajectory of those patients' disease course looked like, and that looks pretty promising. When we look at the survival for patients receiving tarlatamab. So this now includes patients who both responded and who did not respond. But we see that on average, patients go without having disease progression, so no meaningful growth in their tumor, for somewhere around 4 to 5 months. And people survive for a little over a year on this medication. And you have to keep in mind that this is a medication that is given after standard therapies for small cell lung cancer had been administered. So that's not including the time that they had been on those treatments. And so compared to the other things that we have available for patients with high-grade neuroendocrine carcinomas, if we were able to achieve something similar to this in high-grade neuroendocrine carcinomas, that would be one of the most promising things that we've found in that disease entity ever. Again, with caution, this is data that resulted in an approval for tarlatamab in patients with small cell lung cancer. However, we're optimistic and hopeful that we'll see some promise of this agent in high-grade neuroendocrine carcinomas. And as I mentioned, those trials are ongoing. An alternative approach to targeting surface molecules present on a neuroendocrine tumor is through a mechanism called antibody-drug conjugation. So these drugs basically have 3 elements. There's an antibody that binds to a target on the surface of the cell. So this could be the somatostatin receptor, it could be DLL3, it could be something else. There is then a linker that is attached to the antibody that binds to it a payload that is going to ultimately be released within the target cell. And then there is the payload, which is oftentimes a chemotherapeutic agent, And when it's delivered in this mechanism, it can oftentimes be more potent than when we give chemotherapy just by the standard way through the blood system. So basically what this overall mechanism allows for is targeted binding by the antibody of some kind of payload that is toxic to the cancer cell and localized delivery of that payload to the cancer cell. So extensive research is needed in all of these elements of the antibody drug conjugate, both the antibody, the linker, and the payload. There's a lot of very sophisticated chemistry that goes on with developing these agents, but we have currently many investigators, including several through the Neuroendocrine Tumor Research Foundation, who are looking at novel targets and payloads that may ultimately be incorporated into an antibody drug conjugate and used for the treatment of either a neuroendocrine tumor or a neuroendocrine carcinoma. Moving on then to some of the cellular therapies. So there's a couple of cellular therapies. One is CAR T therapy, which again stands for chimeric antigen receptor T cell therapy. And the way that this works is that the immune system can be modified via genetic mechanisms to modify the T cells in such a way that they will be more inclined to recognize a cancer cell. So one such target on neuroendocrine tumor cells has been a molecule called CDH17. It's a target present on the surface of a large number of neuroendocrine tumor cells. So over 90% of neuroendocrine tumors express this. And this construct has been engineered such that the T cell is modified to incorporate this construct so that the T cell will recognize CDH17 on a T cell. And this has been looked at first in mice. We did some mouse experiments where a mouse was injected with cancer cells and generated a tumor. It then received 2 doses of this CAR T therapy, and then the tissue was analyzed. So if we look over at this panel on the right, in the graph, the black line is an untreated neuroendocrine tumor. And you can see that over the days that pass, there's an increase in the tumor volume over time, like the cancer just continues to grow. However, in the tumors that were treated with 2 different versions of this CAR T therapy, both reflected by the red line and the green line, you can see that the tumor volume shrinks after that therapy. And especially with the green line in the graph, we essentially get down to a point where no tumor is detected. If you look at the slides on the right-hand side, the green dye is CDH17, which is reflective of the tumor cells. And you can see on the bottom, the green cells are completely gone. So after treatment with the CAR T therapy, it was essentially able to eradicate the neuroendocrine tumor. So now this is a mouse study, which is a lot different than in humans, but that led to the development of a clinical trial that is looking at the same CDH17 directed CAR T therapy in patients with neuroendocrine tumors. So this is a trial that is actively ongoing. It's open at 4 sites within the United States. So it has 2 elements. First, we're looking at a variety of different doses of the CAR T therapy to understand what is safe and tolerable for a patient. Once we understand the optimal dose to be administered, there is an expansion cohort where we'll then treat a larger number of patients at the ideal dose level to see if this is truly an effective therapy. In addition to this study being done in patients with neuroendocrine tumors, it is also a trial for patients with colorectal cancer and gastric cancer. But right now we're really focusing on patients with neuroendocrine tumors and colorectal cancers. So the way that this treatment works is that if a patient is eligible for the trial, they come in, they get an IV put in that removes T cells from their body. So we basically collect the patient's own T cells from their body. We then send those off to be engineered so that they now express that construct that recognizes CDH17. We then grow those in culture so that we generate a lot of T cells and we have a large dose to be able to give back to the patient. The patient then receives some chemotherapy that kind of knocks out their immune system to make space for the T cells that we're going to give back to them. And then we give back those T cells. And the hope is that those T cells, now with that engineered construct, are going to hone in on the cancer cells and allow for destruction of the tumor. So this trial is currently going on, as I mentioned, and I imagine that over the course of time, as further research identifies other targets on the cells, that there will be other types of CAR T therapies also investigated in neuroendocrine tumors. Similar to CAR T therapy is something called TIL therapy, or tumor infiltrating lymphocyte therapy. In patients with a cancer, normally the immune system will try to identify that tumor as foreign, and lymphocytes will infiltrate the tumor and start to work on trying to identify them as foreign and work to attack them. In the figure on the left, you can see the tumor cells shown in the brownish color, and then you can see that there are a variety of different immune cells that are infiltrating the tumor. And those are ones that obviously have identified the cancer as foreign and think that it should not be there. So what we can do is we can obtain a biopsy of this tumor, and we can extract the lymphocytes that are there, thinking that those are the ones that are most likely to recognize the tumor as foreign. We can then, on the outside of the patient's body, grow those lymphocytes to make more of them. We can also modify them to make them more active. And then similarly to what we do with CAR T therapy, we then give the patient some chemotherapy to knock out their immune system and then infuse these cells back into the patient in the hope that these are refined lymphocytes that are more likely to attack the patient's cancer cells. And there are trials currently underway investigating this form of therapy as well. And so the results are still to be determined. Neither of these cell therapies are available for patients with neuroendocrine tumors at this time outside of a clinical trial, but we are hopeful that they will ultimately lead to some success. So in summary, PRRT is something that we've known about for a while now, and it is evolving with extensive investigation in alpha therapy. And our hope is that we'll have even better outcomes than we already do with the current version of PRRT. And then from the immune standpoint, we know that initial attempts using immunotherapy through immune checkpoint inhibitor therapy to treat neuroendocrine tumors has been unsuccessful for the most part, but we do have hope in the sense that we are investigating bispecific T cell engagers, antibody drug conjugates, CAR T therapy, and tumor infiltrating lymphocyte therapy. And trials are ongoing in all of these areas. And so stay tuned, and hopefully some of these will lead to a new standard of care at some point in the future. Thank you so much for your attention.
Thank you, Dr. Eads. We are excited by this progress in immunotherapy. Our next speakers are going to talk about recent advances that have gone from bench to bedside. Doctors Andy Liao and Abdul Khan are from University of Chicago Medicine. Dr. Liao is co-director of the Neuroendocrine Tumor Program and an associate professor of medicine. He leads many clinical trials. Dr. Khan is an interventional radiologist and assistant professor of radiology.
Hi, I'm Andy Liao, and I'm a medical oncologist from the University of Chicago. Today, I'll be talking about recent advances in systemic therapy for neuroendocrine tumor patients. So in our brief talk, we'll talk about cabozantinib, which is the newest FDA-approved treatment, and alpha particle PRRT, a novel PRRT strategy. Let's start by reviewing the systemic therapy landscape for well-differentiated neuroendocrine tumors. For first-line therapy, we typically use somatostatin analogs such as octreotide or lanreotide. When patients progress on this, then for second-line and beyond therapy, we have PRRT. The FDA-approved one is lutetium dotatate or Lutathera. This drug also has efficacy in the first-line setting, and we'll talk about some of the newer PRRT approaches such as alpha particle PRRT. We also have targeted therapies, including everolimus, sunitinib, and cabozantinib, which we'll talk about, which is the newest FDA-approved treatment option. And we also use conventional chemotherapy, such as capecitabine and temozolomide, for pancreatic neuroendocrine tumor patients. So let's start by talking about cabozantinib. Before we go into the data for cabozantinib, this is a summary of the currently FDA-approved targeted therapies for well-differentiated neuroendocrine tumors, which includes everolimus and sunitinib for pancreatic neuroendocrine tumors, and also everolimus for GI and lung neuroendocrine tumors. All of these agents are approved based on phase 3 clinical trials showing a progression-free survival benefit, with a progression-free survival around 11 months versus 4 to 5 months in the placebo group. These agents tend to keep the tumor stable rather than really cause significant shrinkage, response rate of only 2 to 9%. So cabozantinib is a new targeted therapy that targets many pathways, including the VEGF receptor, MET, and AXL. And what it does is it stops the tumors from making new blood vessels, stops them from hiding from the immune system, stops them from growing, but also invading. Cabozantinib was studied in a phase 3 clinical trial called the CABINET trial. This study enrolled 298 patients with advanced neuroendocrine tumors, randomized in 2 to 1 to getting cabozantinib 60 milligrams daily versus placebo. Those patients in the placebo group can cross over to get real cabozantinib at the time of disease progression. So let's start by focusing on the cohort of pancreatic neuroendocrine tumor patients. There were 64 patients treated with cabozantinib in this cohort. So the median time from diagnosis is 71 months, so this is later on in the treatment journey. Patients have had 1 to 9 prior lines of systemic therapy, so heavily pretreated population. Prior lines of therapy included PRRT, everolimus, sunitinib, or capecitabine and temozolomide. And these patients had grade 1, grade 2, or grade 3 tumors, 22% grade 1, 61% grade 2, and 13% grade 3. For pancreatic neuroendocrine tumor patients, cabozantinib quadrupled the median progression-free survival compared to placebo, with a median PFS of 13.8 months versus 4.4 months, and a 77% reduction in the risk of progression or death. The response rate of cabozantinib was 19%, which compares favorably to everolimus' sunitinib, as I showed you in the previous slide of the currently approved targeted therapy agents. The overall survival wasn't significantly different, but keep in mind that this is premature data, and the trial also allowed for crossover, which always dilutes the overall survival benefit, so we need longer-term follow-up for this data point. In terms of subgroup analysis, you can see that cabozantinib benefited regardless of the tumor grade, prior everolimus, prior sunitinib, prior PRT, or whether the patients were concurrently on a somatostatin analog. Now let's focus on a cohort of patients with extrapancreatic neuroendocrine tumors. So this included 134 patients treated with cabozantinib. Again, this is later on in the treatment journey. Median time from diagnosis was 65 months. These were also heavily pretreated patients, a range of 1 to 6 prior lines of systemic therapy agents, including PRRT, everolimus, and chemotherapy. And again, this cohort of patients had grade 1, grade 2, and grade 3 tumors, 28% grade 1, 64% grade 2, and 6% grade 3. If you look at the site of origin, most of these patients had GI origin tumors, but also lung primary, thymic primary, unknown primary, and other primaries. For extrapancreatic neuroendocrine tumor patients, cabozantinib doubled the median progression-free survival with a median PFS of 8.4 months compared to 3.9 months in placebo, translating into a 62% reduction in the risk for progression or death. The response rate was only 5%, keeping in line with the other approved targeted therapy options for this patient population. Their survival was again similar, keeping in mind that this is premature data and the study allowed for crossover. If you look at subgroup analysis again, so it seems that cabozantinib benefited these patients regardless of the site of origin of the tumors, regardless of whether it's GI or lung or thymic or other primary or unknown primary, regardless of tumor grade, and then regardless of whether they were concurrently on a somatostatin analog, and regardless of whether they had prior everolimus or PRT. What are some of the adverse events that we see with cabozantinib therapy? Well, the most common ones include fatigue, diarrhea, and hand-foot syndrome. Otherwise, there's no really any new safety signals other than what we already knew about cabozantinib in its other approved indication. The one thing that caught my eye was the increase of blood clots in the patients with pancreatic neuroendocrine tumors, so something to keep in mind. If you look at the median average daily dose, so keep in mind that everyone in the CABINET trial started at 60 milligrams of cabozantinib, but they invariably needed to have dose interruptions or reductions based on side effects. So the median average daily dose in the extrapancreatic NET cohort was 38.4 milligrams, and for the pancreatic NET cohort was 37.9 milligrams. So to summarize, cabozantinib significantly improved progression-free survival in well-differentiated neuroendocrine tumor patients and became the newest FDA-approved systemic therapy options approved for patients who have progressed on one line of prior therapy. We see the benefit of cabozantinib regardless of the site of origin, regardless of tumor grade, and regardless of which previous therapies these patients got. It's active even in patients who have been heavily pretreated and have received many prior lines of systemic therapies. The side effects are consistent with what we already knew about cabozantinib, no surprises there. And what do we do? Where do we sequence cabozantinib in our treatment? Well, in our practice at an academic center, we tend to give it after PRT. But technically, this is approved for second and beyond therapy. So in the community practice where patients may not have access to PRT, they may give it after first line and rheotide or octreotide. Now we're going to move on to talk about novel PRT strategies. So we all know that lutetium dotatate PRT is the cornerstone of systemic therapy for neuroendocrine tumors. This is another one study showing that lutetium dotatate significantly improved progression-free survival versus high-dose octreotide, and also improved the response rate, and there was also a numeric trend towards improvement in overall survival. There's also other data showing the benefit of lutetium dotatate in lung and pancreatic neuroendocrine tumors, and therefore, when the FDA approved lutetium dotatate, they approve it for second and beyond therapy for somatostatin receptor expressing GI and pancreatic neuroendocrine tumors. There's also data for using lutetium dotatate in first-line therapy, as shown here, the NETRF study showing that it improved progression-free survival and response rate. But how do we do better with PRT? So one new strategy, what's called alpha particle PRT. Alpha particle PRT uses alpha particles such as lead and actinium, which compares to lutetium, which is a beta emitter used in conventional Lutathera. And the theoretical advantage of alpha particles is it has a short range that allows for selective targeting of the tumor cells while sparing the surrounding healthy tissue, and there's higher energy transfer compared to beta emitters. So alpha particles can cause more double-stranded DNA breaks, increased generation of reactive oxygen species, increased bystander effect, and increased immune activation, all of which should cause for more effective tumor cell killing. So how does this translate into clinical data? Shown here is results from the phase 1 and 2 Alpha Medic 01 and 02 clinical trial. This is the largest presented data for alpha PRT. This is lead dotamtate in a cohort of patients who have GI and pancreatic neuroendocrine tumor patients who had never received PRT. And there were 44 patients in this cohort. The response rate was 57%. The 24-month progression-free survival was 74%, and the 24-month overall survival rate was 91%. You can see here in the right-hand side of the slide a patient who responded remarkably well to this alpha PRT drug. In terms of side effects, there's no substantial hematologic toxicity. We saw grade 3 and grade 4 lymphopenia that was largely reversible. There was also mild to moderate hair loss that was transient. And then there's dysphagia from achalasia. So these patients, for unknown reasons, had difficulty with swallowing. There's also a different cohort of this same clinical trial looking at patients who have already gotten PRT in the past. So shown here is a patient who was treated with alpha PRT with lead dotamtate after previously progressing on lutetium dotatate. You can see that this patient had a great response to alpha PRT following previous beta PRT. So we need to wait until the cohort enrolls to see what the data looks like, to see how active is alpha PRT following beta PRT to tell us how to sequence these two treatment options. A different alpha PRT drug is called lead VMT alpha NET. So shown here is the first reported outcomes in the phase 1 clinical trial with this drug for PRT naive neuroendocrine tumor patients. So in these 9 patients that we have data on, the response rate was 44%, so 4 out of 9 patients, and the 12-month progression-free survival rate was 78%, so 7 out of 9 patients. You can see here on the right-hand side of the slide, a patient who responded very well with significant shrinkage of the liver tumor 48 weeks into treatment. In terms of side effects, this tends to be very well tolerated. There were no dose-limiting toxicities or grade 4 or grade 5 toxicities. There was no dysphagia or any serious kidney complications. The most common side effects are diarrhea, decreased lymphocyte count, and increased creatinine. So where does alpha PRT fit in our practice? Well, when we talk about novel PRT strategies, we talk about different types of radioisotopes, alpha versus beta. We talk about individualized dosimetry, so using the tumor burden and tumor uptake to guide the dose that the patient actually gets. We talk about PRT retreatment and combination strategies. Expanding the current indications of PRT, so beyond the low-grade GI and pancreatic neuroendocrine tumors to other indications and also to patients with grade 3 tumors. And finally, we talk about treatment sequencing. So is alpha PRT better than beta PRT? Should we use it first or should we reserve it for patients who progress on beta PRT? And how do we fit PRT in amongst the other new systemic therapies that are coming on board, such as cabozantinib? So the final verdict for alpha PRT, where it fits in our practice, is that it's too early to tell. We need to wait for further clinical trial results to give us more information on how we use alpha PRT. And to that end, here's a list of ongoing PRT trials looking at alpha PRT, but also looking at retreatment, combinations, individualized dosimetry, and etc. And for all our neuroendocrine tumor patients, I highly encourage you to seek out and participate in clinical trials because this is how we make progress in our field. You could help yourself, but also other neuroendocrine tumor patients like you. Thank you for joining us today.
Hi, I'm Abdul Khan. I'm a relatively new faculty member at the University of Chicago within the Interventional Radiology Department. I just started last August, and I'll be presenting about neuroendocrine and tumor and the use of histotripsy. I have no relevant disclosures. So what is histotripsy? Histotripsy is a non-invasive, non-thermal ionizing form of energy that allows us to produce mechanical disruption in tissues. The way we do this is we administer pulse sound waves to create microbubbles, utilizing those sound waves. And these microbubbles ultimately destroy the tissue. They liquefy the tissue. The nice thing about it is that they perform a uniform treatment, and they also spare some of the collagen-containing structures in the liver, including blood vessels and bile ducts. Here we can see a video of those microbubbles circling the tumor and liquefying the tumor as those microbubbles go throughout the entire tumor. The potential of histotripsy can be curative or definitive in its treatment. Usually liver lesions that are 3 centimeters or less can be treated completely in one single session. But past trials evaluating histotripsy, including Hope for Liver, did include 2 neuroendocrine tumor patients that were treated. It can also be utilized in combination therapy in a sense of downstaging or debulking liver lesions, further treatment, including surgical resection. The other potential is immunostimulation. Histotripsy alters tumor biology to sensitize tumors to immunotherapy by releasing tumor antigens, and this may help generate an immune response. The procedure itself is performed under general anesthesia. Typically, paralysis is required to minimize any movement during the ablation. There's a water bath that's centered over the patient, and that allows sound waves to travel through the ultrasound machine, through the skin, and to the target tissue. The machine itself is then positioned with the treatment arm over the water bath to target the tissue. Most of the procedure time occurs during the planning of the treatment. Once everything is planned, the actual treatment itself takes around 20 minutes. For larger lesions, it may take a little bit longer, 40 minutes. We typically perform this outpatient. After the patient wakes up from anesthesia, they're observed for a couple hours before being sent home. Post-procedure, usually minimal amount of pain or soreness, maybe some mild nausea lasting about 24 to 48 hours. Otherwise, the procedure itself is very well tolerated. Limitations: it is necessary to visualize lesions or target tissue under ultrasound. And so lesions that are covered up by air-filled structures such as lung or intestines may not be amenable to histotripsy. There are also some depth requirements. And then there may be some obstruction from overlying bone or cartilage. Performing histotripsy to tissues beneath these may require higher voltage. There's possibility that the energy sent to the target tissue has reduced energy. And then there's potential for some thermal injury to those bone or cartilage structures. So here we go through a couple case examples of histotripsy. First patient is a patient with small bowel neuroendocrine tumor on lanreotide. and had progression of liver disease. Here we see a pre-treatment MRI of our lesion. Immediately post-procedure, CTA was performed in this patient, and we see sort of swelling of that tumor and some surrounding rim hyperenhancement indicating hyperemia, the inflammatory response going to that tumor. And 6 to 7 months post-treatment, we have a PET-CT showing no activity in the area that was treated, and a 9-month post-MRI scan showing significantly interval decreased size of that lesion. Here we have another example of histotripsy in a patient with a pancreatic neuroendocrine tumor, once again on a somatostatin analog with MRI showing progression of liver disease. This patient had a lesion in their liver that was adjacent to their kidney. We took a look of that lesion under ultrasound in our clinic to make sure that we would be able to perform histotripsy on this patient. And so here are some intraoperative images of the actual histotripsy ultrasound evaluating that lesion. Here we can see a sort of a well-encapsulated round structure corresponding with our tumor. When we do histotripsy, we are able to pull MRI or CT scans of the patient and actually fuse them on top of the histotripsy images to ensure that everything is aligned correctly and that we're able to ablate all of the tumor in its capacity. Here we have an action shot of the microbubbles in the center of that area. You can see there's some white coloring that it refers to the gas or microbubbles being formed in the target tissue. After this procedure, we did a post-ablation angiogram, and you can see multiple hypervascular tumors here. But notice that in the area that we performed histotripsy, there's almost a burned out appearance or cleared out appearance of that tumor. We still see blood vessels going to that area, but the tumor itself has been obliterated. Our post-treatment MRI obtained 6 weeks later shows interval decrease in size of that tumor as well as decrease enhancement. Over the course of time, this will continue to decrease in size and involute. Histotripsy is a great option. Certainly, all patients are screened very carefully, as not everyone is a candidate for histotripsy. And with it being a new technology, something that we are still actively studying, but we're happy to offer it here at the University of Chicago.
Thank you to Doctors Liao and Khan. Our knowledge of tumor biology has exploded in the past 20 years, starting in the laboratory. Understanding what happens at the cellular level has unlocked new discoveries and led to new treatments. Our next speaker, Dr. Thor Hafdanarsson of the Mayo Clinic, will tell us more about tumor biology. He is a professor of oncology at the Mayo Clinic College of Medicine and Science. He serves as the Associate Medical Director of the Cancer Clinical Trials Office and is the co-chair of the Pancreatic Neuroendocrine Tumor Board.
Hello, it's a great pleasure to be able to present to you today, and thanks for the invitation to do that. My topic today is biology of neuroendocrine tumor, neuroendocrine tumors or neoplasms. So let's just dive right into it. So this is the overview of my presentation. So I'm going to cover a few topics, as you can see there. So we'll take one by one. And let's start with the naming of neuroendocrine neoplasms. So these things have changed over time a little bit, and I can understand why this could be a little confusing. So we've heard about NETs and NENs and NECs. So what really is the difference between those three? And as you can see there, NENs are neuroendocrine neoplasms, NETs are neuroendocrine tumors, and NECs are neuroendocrine carcinomas. So strictly, the definition of a neoplasm is an abnormal mass of tissue that results when the cells are dividing more than they should and they're not dying when they should die. So a tumor is essentially the same definition, but for neuroendocrine tumors, it actually is reserved for well-differentiated and relatively slow-growing tumors. Carcinoma, on the other hand, is a malignant neoplasm with the ability to invade and spread to other organs. Well, neuroendocrine tumors can do that as well. So the NECs or neuroendocrine carcinomas tend to be much more aggressive than the neuroendocrine tumors, and we'll talk about that when we talk about the differentiation of tumors. But this is the complex sort of nomenclature. So we're increasingly moving towards NENs, or neuroendocrine neoplasm, because it is the most inclusive term. It captures both the well-differentiated neuroendocrine tumors and the poorly differentiated neuroendocrine carcinomas. So I'll refer to NENs most of the time in this talk. So what are NENs? So NENs are cancers or malignancies. They can arise almost anywhere in the human body, mostly in the small bowel, lungs, pancreas, stomach, and rectum, but we can see them in other organs too. And they are incredibly heterogeneous in the sense that they can look very, very different from one person to the next, and even different within the same person. So it's not like there is a cookie cutter approach to all patients. You have to be really looking at the individual characteristics of each patient when you decide on how to approach, diagnose, and treat. And the NENs arise from neuroendocrine cells, which we all have in our bodies and are widespread through our bodies, but some of them just go rogue and become aggressive and malignant. So I just wanted to touch on a couple of terms that you may see in the literature, or your providers may mention this. One is called a carcinoid tumor. This is an old term we used for small bowel neuroendocrine tumors in the past, and is currently only used for NETs in the lungs and chest. Well, people use it for tumors in the abdomen, but in terms of a diagnostic term, it's really only for lung neuroendocrine tumors. So we used to have the carcinoid tumor term as a thing for the abdominal tumors, but now we have just moved to calling them neuroendocrine tumors or neuroendocrine carcinomas plus the organ they started in. So if it's a small bowel neuroendocrine tumor, we essentially just call it that, a small bowel neuroendocrine tumor. But we still keep the word carcinoid for what's called the carcinoid syndrome, and we'll talk some more about that here in a little bit. And that's when the tumors produce chemicals that can cause all sorts of problems, symptoms, and complications. And I just briefly want to mention the islet cell tumors. This is also an outdated term for pancreatic neuroendocrine tumors, but you may still see this in your chart because sometimes the classification system of tumors uses this, but it's essentially an outdated term and we shouldn't be using that much. So let's talk about tumor grade and differentiation and how those differ. So what is a tumor grade? So a tumor grade is really a system to predict how fast cancer will grow and spread. And there are several different ways of doing this, but we use a tissue stain that's called Ki67, also sometimes called MIB1. And we apply this, or we stain a slide or a section of the tumor, and we look at how many cells stain positive. So how many cells does the stain actually stick to? So as it only stains cells that are dividing, the more cells that are stained positive, the more aggressive the tumor is. And this tumor grade really predicts the behavior of the neuroendocrine tumors, and is really the most powerful predictor of long-term outcomes. If we want to sort of know how long a person might have a stable disease or stable tumor, and how quickly things might progress or grow, then the tumor grade or the Ki67 is really important. And this is the job for the pathologist, though the pathologists actually determine the grade. So how does this look to the pathologists? Well, here we can see that on the left-hand side, you can see a grade 1 tumor. You see all of those little blue dots. These are neuroendocrine tumor cells that essentially are resting. They're not growing. So this would be grade 1 and less aggressive. In the middle, you see more red, the blue dots. So these are the tumors that are positive for Ki67 and sort of more actively growing. And then on the right-hand side, you see the grade 3, where there's a lot of brown dots, not a whole lot of blue dots, and these are the more aggressive tumors. So neuroendocrine neoplasms can be among the slowest growing tumors we see in humans, and also among the fastest growing. And that's where we use the tumor grade. So grade 1, I think of as something really slow moving, grade 3 as something that's really fast moving. But here is a little problem. So the grade 3 tumors are not all super aggressive. So some of them can be, but others are not. But the grade 1 tumors are almost always very, very slow growing. So that brings us to the differentiation. So what is tumor differentiation? Poorly differentiated or well differentiated? You heard this a lot. So this is really a way to tell how much the cancer resembles the normal cells it actually originated from. So does it look quiet and well-behaved and all the cells are the same shape and size? That's called a well-differentiated tumor. Or does it look aggressive, like angry, and cells of different sizes and shapes? And then we call it a poorly differentiated tumor. And that also determines how the tumors will behave. So on the left-hand side, we see something that's really slow, and so on the right-hand side, something that's really aggressive. So all poorly differentiated tumors are grade 3, but not all grade 3 tumors are poorly differentiated. And that is incredibly important to keep in mind. And we have a couple of rules of thumbs here. So NETs tend to be less aggressive, slower growing. NECs or neuroendocrine carcinomas are almost always very aggressive, fast growing, and need therapy urgently. So how do we use this in the clinic? So the differentiation status dictates the treatment choices. And if we have someone with a well-differentiated neuroendocrine tumor, be it of grade 1, grade 2, or even grade 3, we consider surgery for localized and even some advanced neuroendocrine tumors. We do liver-directed therapy like embolization and ablation when that's appropriate. We use somatostatin analogs. We sometimes even just watch them and don't do anything, even if it's a metastatic disease. We use peptide receptor radioligand therapy, such as PRT, targeted therapy, and for some of them, even chemotherapy. But we tend to use a little bit less aggressive chemotherapy for these. On the other hand, if we have a poorly differentiated neuroendocrine carcinoma, we rarely do surgery because most of them present with more aggressive, advanced cancer metastatic to other organs. We rarely do liver-directed therapy like embolization, and we rely much more on aggressive IV chemotherapy and sometimes even the addition of immunotherapy. And here we do some targeted therapy based on genetic abnormalities, and I'll talk about that a little bit. So what works for neuroendocrine tumors generally does not work for neuroendocrine carcinomas. So moving on to the somatostatin receptor, I'm going to spend a little bit of time on this because this is really important for the biology of neuroendocrine tumors. So what is the somatostatin receptor and why do we care? So the somatostatin receptor is something that sits on the surface of most well-differentiated neuroendocrine tumors and some poorly differentiated neuroendocrine tumors. In the middle there, you can see a cell and those little things that project out from the cells, almost like little flags on the surface. So those are the somatostatin receptors. And we can use them as targets for both imaging with what's called a PET study, and I'll show you some of that, and also for therapy. So how do we know the somatostatin receptor is there? Well, we can stain for it, but we don't do a whole lot of that. But we can also take a picture of it. Something called a somatostatin receptor PET-CT. You may recognize it as a gallium or a copper PET-CT, or even like a DetectNet or NetSpot. It has a lot of different names. So you have to have the somatostatin receptor on the surface of the tumor cells. And if that receptor is there, that's that little blue dot there, you have to have something that actually sticks to the receptor, that binds to the receptor, like two pieces of Velcro. Then you have to have something that glows in the dark and something that keeps this all together. So you have this somatostatin analog, what's called the peptide, and then you have the diagnostic radionuclide, gallium-68 or copper-64, and the glue that keeps it all together. And then you give this IV, and it floats around in the body. It sticks to the tumor cells and latches onto them. So now you've tagged the tumor cells wherever they are in the body, and then we can take a picture of the body. And like I said, it goes under multiple different names, and this is what it looks like. So this is a patient of mine who had a lot of bone metastases. You can see how all of the bones light up there. This is still a very, very slow growing tumor. This has been going on for a long time. And I know it looks very alarming, but this patient actually is doing very well. As for the PET imaging, I just tend to call it the somatostatin receptor PET imaging instead of all of these other different names we have for it. So we can also use the somatostatin receptor to target it with therapy, something like PRT. So I'll just walk you through how that works. So you have to have the target, the somatostatin receptor. You have to have something that binds to the target. So that would be this peptide similar to octreotide or lanreotide that sticks to the tumor cell. And then you have to have something that kills tumors, like a therapeutic radionuclide. And the only one we have right now is lutetium-177. And again, we have to have the glue that keeps it all together. And then we give this IV. It sticks to the tumor cells like two pieces of Velcro or two magnets and delivers radiation treatment into the tumor and kills it that way. And we do have lutetium-177 approved in the US. That's the only one we have approved. And we have some others in clinical trials like the alpha particles, actinium-225 and lead-212. So you can expect that this is going to change a lot in the next several years as we get more of the alpha particles. But this is just another way to use the tumor biology to treat the tumor. And this is how this works. So we deliver the radiation treatment right to the doorstep. It delivers lethal radiation to the tumor cells and kills it that way. As many of you know, this can be incredibly effective. Okay, let's move on to functional neuroendocrine tumors. So what are functional neuroendocrine tumors? You may hear this quite a bit. So a functional neuroendocrine tumor is a neuroendocrine tumor that produces certain hormones or chemicals that can cause a characteristic constellation of symptoms, or what we call a functional syndrome. And the most typical one is the carcinoid syndrome. So up to 50% of patients with metastatic small bowel neuroendocrine tumors produce serotonin and other chemicals that can cause a lot of symptoms. And we'll talk some more about that. You can have the pancreatic neuroendocrine tumor syndromes, or the PNET syndrome. So these are pancreatic neuroendocrine tumors that can produce all sorts of hormones, like insulinoma that drops your blood sugars, like gastrinoma that causes severe reflux and diarrhea, and even can cause some ulcerations and perforations of the stomach and the duodenum. And then we have the really uncommon one. I just mentioned two of them, the glucagonoma that causes a characteristic skin rash, and the vipoma that causes a lot of diarrhea. But there's a whole host of other functional pancreatic NETs, or tumors. So let's talk a little bit about the serotonin production. It's a very important part of the biology of neuroendocrine tumors. Again, we're going to revisit our neuroendocrine tumor cell there. And this cell, or at least a lot of them, maybe 50% of those that have the patients who have metastatic disease, produce a lot of serotonin. So there's this machinery that's constantly just making serotonin and pumping it out into the bloodstream. And this can cause a lot of problems. We can actually measure this in blood as serotonin, or more commonly 5-HT, and can cause diarrhea and tissue damage or tissue scarring, and even damage the heart valves. This actually is probably not the cause of the carcinoid flush. So there's a whole host of other chemicals that can do that. And we cannot measure all of them, but some of them we can measure. So we can target the somatostatin receptor and make the cells reduce the production of serotonin. It doesn't work forever, but can work incredibly well. So here are some of the symptoms of the carcinoid syndrome. This is typical carcinoid flushing, and then a lot of patients will have a lot of diarrhea, which can be extremely debilitating. And then we can have wheezing, which is not very common, but does happen. And then what we call the carcinoid heart disease, but in the interest of time, we won't cover that. So what can we do about the serotonin production? So if you look at the tumor cells, it's pumping out serotonin. It's putting you at increased risk of tissue damage, and we need to make it stop doing this. So we have a few options. So we can use the somatostatin analogs, octreotide and lanreotide, or PRRT, or even telotristat, also known as Ermelo, to reduce the production of the serotonin. And they all do this in different ways, but essentially what we do is that we just throw a wrench in the gears of the production, and we reduce the serotonin production that way, and hopefully reduce the risk of tissue damage. Let's switch gears and talk about genetics and the role of genetic testing. So up to 10% of pancreatic neuroendocrine tumors are associated with hereditary syndromes, something that runs in your family. By far the most common is MEN1. And there are other syndromes as well, like von Hippel-Lindau and neurofibromatosis and tuberous sclerosis. So neurofibromatosis and tuberous sclerosis are extremely rare. Von Hippel-Lindau is fairly rare as well, but MEN1 is by far the most common. And the patients who have a hereditary pancreatic neuroendocrine tumor tend to be much younger at diagnosis, and often with multiple tumors. When we look at the small bowel neuroendocrine tumors, they usually not associated with any hereditary syndromes, but we've known for decades that if you have a small bowel neuroendocrine tumor, the risk of what we call your first-degree relatives, so children or siblings, is probably 5 to 10 times that in the general population. But just because these tumors are so rare, the risk is not really high for you. Lung neuroendocrine tumors are rarely associated with hereditary syndromes, and if they are, it's typically through MEN1. And then we have the poorly differentiated neuroendocrine carcinomas, which generally are not associated with any syndromes. So when do we order genetic testing? So when we suspect there's a hereditary syndrome, it's very important to do that. And we can consider it in patients with multifocal pancreatic NETs, with any patients who are young at the diagnosis of pancreatic or duodenal NETs. And when I say young, younger than 50 to 60 years, but we can actually test older patients than that. And then if there's a strong family history of neuroendocrine tumors and other malignancies. And what we do there is what's called germline testing. We look for mutations you were born with. And these are mutations that cause the syndrome. And this is best done after consulting with a genetic counselor, because there can be all sorts of ramifications of doing genetic testing like this. So I like to do it after having patients visit with a genetics counselor. Then we can also test tumor tissue. So, and we've seen that this is really changing cancer medicine. So we can look for what we call genetic alterations like mutations and gene fusions that we can target with some of our newer drugs. And we call that actionable alteration. So it's a mutation or something we can target with a drug. Still not a large role in patients with well-differentiated neurotumors, but as we start to understand these tumors even better, I think this will only grow. So we're going to be doing more and more of this. We also know that the minority of patients with poorly differentiated neurocarcinomas have what we call actionable alterations. Maybe 10, 20% of them do. So it's really important that we do genetic testing on all of those. So let's move again to a different topic. So biomarkers. What are tumor markers? So, well, tumor markers are essentially tests that give us information on the clinical behavior of the malignancy, and they may even help us predict how a person will do over time. So, what would be like an ideal tumor marker? Well, it should be something that reflects the behavior and activity of the tumor. It should be abnormal when there is tumor present. So, what we call high sensitivity, and it should not be abnormal when there is no tumor. It should be easy to get and widely available, and it should be affordable, and it should have a fast turnaround time. A tumor marker that takes like 3 months to get the results of is really not helpful. But most importantly, it should add value. So ideally, it should improve outcomes and give us valuable information. Unfortunately, a lot of the markers we have don't do that. And it should not be a source of harm, such as financial toxicity, anxiety, or loss of quality of life, which it actually can't be. So, are they really useful in neuroendocrine? Yep, they can be if we use them appropriately. So, the non-specific biomarkers like chromogranin A are somewhat challenging to use. They tend to fluctuate quite a bit, but in certain scenarios, they might be helpful. An appropriate use of biomarkers, for example, would be detection and monitoring of serotonin production using 5-HIA in patients with carcinoid syndrome to monitor patients with functional pancreatic or lung neuroendocrine. But then we have a whole list of inappropriate use of biomarkers. So let's say a screening tool when the suspicion of an NET is low. A biomarker is not good for that. Biomarkers like chromogranin are often high, even in patients who don't have neurotumors. As a freestanding diagnostic method, no, you can't use them for that. They're just not good enough. And same thing as a replacement for imaging studies. They just don't work that way. They're just not reliable enough. And then we have some really exciting markers on the horizon. None of them have been, in my opinion, adequately validated for like routine use. So this would be like the NET test, circulating tumor DNA, circulating tumor cells. I think all of these just require much better studies, ideally within clinical trials. So we know where to apply them and how to use them to help our patients. So here are just a few potential uses of circulating tumor or biomarkers. So when we can measure all sorts of things in the blood. So we can measure like pieces of DNA, hormones, pieces of RNA, and even detect the floating tumor cells there. But like I said, very few of these are ready for routine use. Ultimately, I think we might use them for early diagnosis. They might be more reliable for monitoring response to treatment and even to detect tumors that come back after therapy, as well as predict responses to therapy and predict the risk of therapy. So I think we're going to see a whole lot of new and exciting biomarkers. But right now, most of these novel biomarkers simply don't have the information we need to apply them for routine use. So the bottom line for the use of biomarkers is that a NET marker should bring value to patient care. Treatment decisions should rarely, if ever, be made on marker results alone. And most markers currently bring limited value when routinely used. And so we have to use them really selectively. But I think that's going to change over time. So that brings me to the end of the presentation. Thank you very much.
Hello, we'll be discussing liver-directed therapy for neuroendocrine tumor and neuroendocrine carcinoma. I have no disclosures. So at presentation, 46 to 90% of patients with neuroendocrine tumor may contain liver metastasis. This is associated with a poor prognosis, 5-year survival rate ranging from 0 to 40%. 80 to 90% of these liver metastases are inoperable, and systemic therapies may have a moderate effect on liver metastasis. And so liver-directed therapy is an option for these patients. This can be performed in a variety of methods. These can be broken down into ablation and embolization. The indications for liver-directed therapy are primary for liver-dominant or liver-only disease, used to treat symptoms from functional disease or to treat tumor bulk, and principally halting the progression of disease. You can see many of these indications refer to progression of disease, or if there are only 1 or 2 lesions in the liver to treat. Ablation can be further broken down into thermal and non-thermal. Thermal refers to microwave ablation, or basically burning the tumor with a needle. We usually perform these for 1 to 3 lesions in the liver that are less than 3 centimeters, performed under general anesthesia. We basically advance a needle from the skin through the liver into the target area that needs to be ablated, perform the ablation. The ablation itself usually takes about 10 minutes, and then we remove the needle. Patient wakes up. We usually observe them overnight in the hospital, and then they leave. Non-thermal refers to histotripsy, which we already had a brief talk on. Once again, this is a non-invasive, non-ionizing energy form of ablation that uses microbubbles to mechanically disrupt tissue. It can be used as a definitive treatment and also can be used in combination therapy. Metastatic neuroendocrine tumors are hypervascular. 80 to 90% of them get their blood supply from hepatic artery. The liver itself gets its blood supply from the portal vein. And so we're able to take advantage of this by treating through the hepatic artery and preserving liver tissue. The way we do this is we deliver embolics intraarterial to interrupt the blood supply to tumors. And embolization is within the NCCN guidelines for liver metastasis. The simplest form of embolization is bland embolization or transarterial embolization. This is when we deliver small microspheres or beads that see deep into the blood vessels supplying the tumor. These block the blood supply to the tumor and eventually help kill them off. We usually use these in liver-dominant disease. There is some caution in using these in people who have had biliary intervention or biliary stents. A step up from this is chemoembolization, and this is basically mixing those beads in with chemotherapy, the most common being doxorubicin. Now, what's better, bland embolization or chemoembolization? There have been a few studies, including the RETNET trial, evaluating the difference between these two, and so far there hasn't been a significant difference. The last is radioembolization, or basically introducing radioactive beads into the liver to treat these lesions. These are usually reserved for bulky liver disease with rapid progression. This can be used in the setting of prior biliary intervention or biliary stents. It does cause fibrosis within the liver in the treated area. This can make resection of those tumors afterwards a little difficult. This is the decision process we use at the University of Chicago. You can see that for patients who have liver tumor burden, greater than 25 to 50% is when we perform liver-directed therapy. The protocol itself, me as an IR will review the PET-CT or MRI imaging, as well as get a basic set of labs. During the procedure, we may administer some octreotide and or histamine blockers to avoid any carcinoid crisis, which refers to flushing or wheezing that can come from release of vasoactive peptides. And then post-procedure, we keep people overnight. This is usually to treat any symptoms of post-embolization syndrome, which refers to abdominal pain, nausea, low-grade fever that usually lasts 24 to 48 hours post-procedure. Most people leave the first day after the procedure. So here are a couple examples. Here we have a patient that we perform bland embolization on. I want to focus your attention on this tumor here in the right side of the liver that shows some activity on the PET-CT and their MRI. We see the lesion well defined there. Here's our angiogram, and we actually can localize the blood vessel going to that tumor. We do a CT intra-procedure to once again visualize the tumor and its hypervascularity. Afterwards, we mix those beads with some contrast, and here we can see staining of that tumor after embolization, telling us those beads went exactly where we wanted them to go. And we have our post-treatment imaging. Here we can see PET-CT where there's no longer activity of that tumor or lesion, and in 9 months you can see significant decrease in size of that lesion. Here's a second example, one that we performed histotripsy and bland embolization as a combination therapy. This is our pre-procedure imaging, multiple lesions in the liver. Once again, I showed these images from histotripsy prior, and after we performed the histotripsy, we went after the rest of these hypervascular lesions with bland embolization or those microspheres. And those 6-week post shows decrease in that size of the lesion that we did histotripsy on, as well as decreased size and enhancement of those lesions that were treated with bland embolization. One final example I have is a patient with a single lesion treated with microwave ablation. Here we have MRI and PET-CT showing a single lesion in the liver posteriorly. This is an intraoperative procedure where we have an ultrasound where we can see that lesion very well. Here's our microwave needle advance into the lesion. As we burn, there's some gas bubbles that form at the lesion, and our immediate post-procedure CT shows post-treatment changes in that area corresponding with where the lesion was prior. This is our post-procedure imaging. You can see 1 month post, there's some post-treatment changes, 4 to 5 months post, evolution of those post-treatment changes, and 7 months post, that area where the lesion used to be now has no activity on the PET CT. And so these are a variety of ways to treat liver metastasis for neuroendocrine tumor and neuroendocrine carcinoma that we offer here at the University of Chicago.
Thank you, Dr. Hefdonerson. Since neuroendocrine tumors and carcinomas differ from person to person, deciding the right treatment at the right time for the right patient is the goal. Now we hear again from Dr. Koitkin and Dr. Khan on sequencing therapies for liver metastases and advanced disease.
Good morning. I'm Dr. Xavier Koitkin. I'm a surgeon at the University of Chicago, and I'm also the director of the University of Chicago Neuroendocrine Tumor Program. Today, I will be talking to you about sequencing therapies for liver metastasis and for advanced disease. So metastatic neuroendocrine tumors, as we all know, are quite common. In our clinic, a majority of patients that present with neuroendocrine tumors have metastatic disease, meaning disease that is spread outside of the vicinity of where the tumor started. One of the most common places for neuroendocrine tumors to metastasize is the liver. And if you look at this graph here, almost 50% of small intestinal and pancreatic neuroendocrine tumors present with liver metastases. And we know that liver metastases are also associated with diminished in survival, especially if liver metastases are bulky or large. So if there is a majority, greater than 50% of your liver that's replaced by metastases of neuroendocrine tumors, your survival is not as good as if you have less than 10%, as this graph shows. So liver failure due to overwhelming liver tumor burden is a concern that we try to address with systemic and local regional therapies. Now, if you look at the NCCN guidelines, which are guidelines that clinicians use to guide their treatment recommendations, you can see here that if complete resection of the neuroendocrine tumor and the metastasis is possible, it's generally recommended to do so. However, often complete resection of all metastatic disease is not possible. And so there are a lot of local, regional, and systemic therapies that then can be used. This is an older version of the guidelines, but as you can see here, there definitely isn't one recommendation that says you should do this or that first. It's all an or. You can do this or this or this or this. And so treatment sequencing really is challenging. At the University of Chicago, we have our own algorithm for treatment of certain neuroendocrine tumors. For example, this is a treatment algorithm for our pancreatic neuroendocrine tumor patients. And without going in details here with you, you could already tell that there are quite a bit of arrows pointing in all kinds of different directions. So again, treatment sequencing is very important, but it can also be very confusing. What is treatment sequencing? So treatment sequencing, in my mind, means that you could combine therapy, right? So for example, when do you use systemic therapy in combination with local regional therapies? It also means that you could treat according to certain biomarkers, meaning is there something that you can determine in the patient's tumor that would potentially tell you, well, you should do this therapy over this therapy. And treatment sequencing can also be related to patient preference because, of course, clinical expertise and trial data is important, but patient preferences as well. And sometimes we don't have any good data that says this is better over this. And so we discuss these options with our patients and we discuss the side effects as well. And we let our patients decide what they would like to do with us together. Why is it important to think about treatment sequencing? Because treatment sequencing, if you do it the right way, could improve therapeutic efficacy and patient outcome. It could also mean that you only treat patients when you actually need to. Very often, the journey of a neuroendocrine tumor patient is more like a marathon and not a sprint. So we don't treat you with all kinds of things right off the bat, but we try to treat you only when it's needed to treat you. And understanding which therapy goes first, which therapy goes second, or third or fourth may be very important in that journey. And then lastly, treatment sequencing also is meant to prevent cumulative toxicity and transformation of tumors. So if we know that we give a certain tumor one certain regimen followed by another one, and that the likelihood is that we will create enough damage to the cells that some could actually survive the damage and de-differentiate into a more aggressive clone, that wouldn't be a good outcome. So we got to pay attention to this. Also, for example, if we treat patients with different types of radiotherapies like PRT and like Y90 radioactive beads to the liver, we got to pay attention that we don't over-radiate the liver and that we don't cause any liver damage due to these different therapies. So choosing when to use what therapy and in what sequence is really important. But as I'll show you throughout this talk, there's a lot more that we need to learn about it. So treatment options for metastatic neuroendocrine tumors include systemic therapy like long-acting octreotide, which is first line, targeted therapy like everolimus, sunitinib, cabozantinib, chemotherapy like CAPTEM, and then PRT. But there are also liver-directed therapies, so surgical resection or debulking, liver-directed therapy with our IR colleagues, and one of them, Dr. Khan, will talk to you a little bit at the end of this talk a little bit more about this, and then rarely liver transplant. And the sequencing of these therapies depend on a lot of factors, including tumor burden, tumor distribution, patient wishes, symptoms, comorbidities, and also access to therapies. Switching gears a little bit and going to systemic therapies, and an example of sequencing with systemic therapies, PRT is something that many of you know about. It's a radioactive particle that's infused into the patient's vein and tracks down the cell surface on the tumor receptors and delivers a low-dose radiation to the tumor while limiting the toxicity to adjacent organs. And the NETR1 and NETR2 trial have shown that lutetium-177 dotatate, so PRT or Lutathera, is beneficial in patients with metastatic neuroendocrine tumors. But there are many questions that are unanswered when it comes to PRT. For example, how does PRT fit into the treatment algorithm of NETs? Should we use it early or should we use it late in the disease course? Should it be combined with other agents? And is PRT better than other therapy in certain patients? So I'll give you a couple of examples of things that we think of as clinicians. For example, PRT and tumor volume. So the question that we ask here is, can tumor volume reducing interventions such as surgery improve PRT efficacy? So that's important from a sequencing perspective, because if it can, then perhaps patients should undergo surgery prior to undergoing PRT therapy by reducing tumor volume. So there were a few initial hints in the NETR1 trial suggesting that patients that had tumors that were larger did not respond as well to PRT than when the lesions were smaller in the liver. There's been some other trials out of Europe that showed that removing primary tumor mass would actually improve the survival of patients receiving PRT. So we looked at this at the University of Chicago last year, and we included a little less than 90 patients, of which about 2/3 underwent surgery or surgical debulkings, and then 1/3 did not have any surgery. We used tumor volume measurements to measure tumor volume in our patients using dotatate. And when we compared the different surgical procedures that we did, we found some differences in the debulking versus no debulking part in terms of progression-free survival, as you can see on the right side. On the left side, there weren't really much differences when you resected only the primary tumor. So again, the more tumor volume you reduce by debulking, taking most of the tumor out, that actually had a beneficial improvement on patients that had debulking surgery versus those that didn't, in terms of progression-free survival after they received PRT. And we were able to determine a certain tumor volume in this particular paper, saying that if your tumor volume was less than 138.8 cubic milliliters, you would do significantly better after receiving PRT than when it was larger. And not surprisingly, as you can see here, those that had no surgery in this group had a higher tumor burden on the right side in gray than those that had only the primary tumor removed. And finally, those that had surgical debulking had the lowest tumor volume, as you can see here in blue. Now, example number 2 of PRT and sequencing and how we should think about it. So biomarkers. The question here is, can biomarkers predict which patient would most benefit from PRT? And here again, this is some data coming from my lab that we published a few years ago, where we essentially showed that if your tumor, and usually pancreatic neuroendocrine tumors, had an MEN1 mutation, you would be more likely, or at least the cells and the mice that we used in the lab, were more likely to respond better to radiation. And when we looked at our clinical data set, so again, this is patients that either have MEN1 or DAX mutation and underwent PRT, or those that did not have a MEN1 or DAX mutation and underwent PRT. You can see here again that those that had a MEN1 or DAX mutation had a significantly improved progression-free survival here in blue, which confirmed the data that we saw in the laboratory. Their overall survival was also improved after PRT. And when we compared it, for example, with CAPE-10, which is a chemotherapy regimen that we give to our patients with metastatic pancreatic neuroendocrine tumor patient, having a mutation in MEN1 or DAX did not make any difference in terms of progression-free survival. So it was really just for PRT. Example number 3 would be combination strategies. So the question here would be, should PRT be combined simultaneously or sequentially with other treatments to improve efficacy? And here again, my laboratory has determined that a certain drug that's used for breast cancer, it's not a chemotherapy regimen, but actually a hormone blocker, can radiosensitize neuroendocrine tumors. And here we have started a clinical trial that where we're enrolling patients with pancreatic neuroendocrine tumors at the University of Chicago. And this is a phase 1 trial where patients receive PRT with fulvestrant, which is this hormone blocking drug. It's worth noticing also that the preclinical data from the laboratory that was used to generate this data here was funded by NETRF. So a little shout out here to NETRF for that. We have enrolled already 5 patients. We're planning to enroll a total of 6 for the first phase and then an additional 13. And again, combining fulvestrant, which is essentially a shot that you get in your arm, with Lutathera, perhaps, we'll have to see for those results to come back, could be an interesting strategy to improve how PRT works. Now, there have been many combination trials that have either been explored or ongoing, combining PRT with other therapies. You can see here, of course, there was the NETR1 and the NETR2 trial, but then also there have been trials looking at combining Lutathera with everolimus, CAPE-10, etc., etc. Most of these trials are phase 1 or phase 2 and have either not progressed or are still into phase 3 or are still into their early research days. There are additional ongoing trials combining Lutathera with, for example, PARP1 inhibitors, which are DNA sensitizers. So many different ways to think about how to combine PRT with other therapies to make PRT work better and to help us understand when we need to use it in the sequencing realm. Now, this is an intriguing case I wanted to present. So this is a metastatic PNET patient that underwent surgical debulking in 2018, had 4 cycles of PRT in 2020, had bland embolization in 21 and 22, underwent CAPE-10 in 22, bland embo in 23 again, had some external beam radiation to the spine in 24, and underwent another 2 cycles of PRT in 2024. Obviously, he went through all these different therapies because of tumor progression. This is what his dotatate looked like. As you can see, all the dark spots are tumor in the liver. You can see here some bigger lesions, including some pretty central lesions in the liver that were, quite frankly, pretty nasty. So after his 2 cycles of PRT, however, he progressed within a few months again. And we then started him on cabozantinib, which is a new therapy that was approved by the Food and Drug Administration just recently. And his first scan after cabozantinib and after 6 cycles of PRT showed a complete response. So that is a very intriguing case. So all the tumor completely disappeared. It is intriguing because it raises a lot of question when it comes to treatment sequencing, right? So why did this patient have a complete response on cabozantinib? If you look at the New England Journal of Medicine data that looked at the objective response rates, they were about 19% in cabozantinib for pancreatic neuroendocrine tumors that underwent a partial response. A vast majority either had stable disease or progressive disease. Now, partial response does combine tumor shrinkage with complete tumor disappearance. But looking back through the paper, I could not find any mentioning of one patient that had a complete response where all the tumor disappeared after cabozantinib. Another question is, did the previous PRT induce changes within the tumor that perhaps primed the tumor to respond so well to PRT? And therefore, should patient receive PRT prior to cabozantinib? Obviously, that's a very provocative question, and I'm just throwing it out here. I'm not saying they should by any means, but it is definitely something that is really interesting and that needs to be studied because it comes really to the core of treatment sequencing. So how do we answer these questions? Well, we can't run a clinical trial with a million different combination strategies. This just doesn't work because it's too expensive to run clinical trials on all of these different combination strategies. And there are so many different drugs and so many different things that we can look at. And I just talked to you about PRT and combining this, but you could say the same with CAPTEM or with long-acting octreotide or with all kinds of other therapies that are on the horizon right now. So we need to study these combination strategies in a preclinical setting using laboratory and translational research. We need to study the timing of the drug administration. What needs to go first? Again, that's treatment sequencing. We need to study tumor variables that affect how these treatments work. So these are all things that we can study in the lab, and that even though they're not always translatable in clinic, they at least give us a basic idea of, is it important to try to put a trial together to study this in our patients. And sampling tumors with surgery, for examples, or with biopsies is just one of multiple examples where we can get tumor specimens, study microenvironments and changes in the tumor and genes, etc., to really understand what we need to do and what is worth studying. So in conclusion, understanding and researching treatment sequencing is of utmost importance for patient outcome. Treatment sequencing is complex, multifaceted, and might need to be individualized according to patients and neuroendocrine tumor subtype. When it comes to liver metastases, a combination of tumor-reducing intervention using surgery and IR in combination with systemic therapies such as PRT or CAPTEM is likely most efficacious for long-term tumor control. And after comparing treatment agents to placebo, newer studies are now studying combination strategies. So, like I mentioned before, there's technically an infinite amount of possibilities of what we can combine, but we need to study better with translational and basic research what combinations make sense and how to best define these different combinations to pursue them in clinic. And here, NETRF and basic research have a huge role to play because those funding mechanisms are the way for us to study these different treatment strategies. So I'd like to thank you for the opportunity to speak today to you about a very complex topic. I'm happy to take any questions later on in the Q&A session. If you'd like to email me directly, here's my email address. And thanks again for being part of this fantastic NETRF event today. Take care.
Continuing our theme of 20 years of progress, we looked at some long-term survivors of neuroendocrine cancer for their patient perspectives. After their thoughts on thrivership, we'll take a very short break. When we come back, we'll be talking about advancing care, treatment, teams, and new frontiers.
If I could go back and repeat my first surgery, I would tell myself to not have it done locally. We have a great hospital here in Santa Barbara, but it's just not equipped to take care of pheochromocytomas. So I had the first surgery here because they thought it was going to be my only one. Oh, it'll never come back. But it came back, of course. Go to a teaching hospital, which is what I wound up doing after when it recurred and I had to go to a bigger hospital that knew more about my condition.
I would like to think that I believe that there is a future, there is hope. When I first began, the initial diagnosis was very, very poor. That was 27 years ago, and I'm still here. And that is obviously with the support of the medical system, the physicians, the doctors, the specialists. And wherever we are in the spectrum, we've got to look forward. And there's being a lot done, and there's a lot of hope going forward.
Be patient.
When I started this, it was in 2005. All right. So I'm going to an oncologist that may or may not have heard about NETs at that time. She sent me over, got a diagnosis, lab work, and it was pancreatic cancer. But she had me back and she said, "You don't look like you've got pancreatic cancer." She sent me to MD Anderson. I spent 3 days down there working with them, taking every test, answering every question I could. When we started this, it was completely in the dark. So it took a very long time to come out of the wilderness and find oncologists who were familiar with NETs. Even back that far, I found several specialists who were familiar with the NETs.
I would get the best endocrinologist in the world that you can possibly get, and make sure that you're really, really comfortable with your doctors, because it's a journey. And I think it's really important to be a squeaky wheel as well. Don't just take the first bit of advice if you're not comfortable. Just research. And I am constantly on the internet looking for new stuff. And that's how I found out about you. So it was well worth the effort.
Well, once again, I would say to always remain positive. Do as much reading and research as you can, and don't be afraid to ask questions. I would suggest to anyone and everyone, if you can find an advocate to be in your court, I think that's most helpful.
Definitely to find other people who have been diagnosed before you, learn from their experiences, talk to as many as you can, go online, read their stories. That was so helpful to me. Maybe beyond some of the doctor's opinions I got. And the other thing I would say is get several opinions.
I would recommend to anybody that came down with this kind of diagnosis that is hard to specify, et cetera, like that, go educate yourself. Take a place like NETRF and that kind of thing, like they do, and put out podcasts and everything like that. Go educate yourself on the disease. That will probably offer you a better opportunity to communicate face to face with your oncologist, because you are going to be the person now who's got the information and the questions. So put yourself in that kind of position that, and I'm not going to say you're going to become an expert, but you're going to give yourself a base of understanding to hear and work with the oncologist to both your benefits. So starting here where I am right now and what I've gone through and what I'm doing right now is based on that 20 plus years of experience. And that came, 1 inch at a time.
If I look at what NETRF means to me, it is the ability to bring basic research together with clinicians to try to bring that bench to bedside and at the same time also provide bedside support for our patient community. It is one of those things that covers the range of the neuroendocrine tumor experience as a patient, from discovery to better treatments, but as a researcher and clinician, as a way to stay funded, stay in the game, and keep looking for those better opportunities and those better treatments with better quality of life.
What got me involved in wanting to help with neuroendocrine tumor research was actually my kids. I wanted to show them that I did everything I could to be around for them, to raise them, show them how much I loved them. And as a patient and someone who created the nonprofit, the CureNet Project, with my siblings to raise money for this research specifically. Being able to give that money to someone like NETRF, who has the resources as one of the largest funder of neuroendocrine tumor research, being able to be confident in knowing that the resources that we're giving them are going directly to these researchers that feel so passionately about neuroendocrine tumors, putting that effort into understanding the disease. They have a vested interest in seeing the person on the other side of that research. Seeing that happen in real life, like, it's actually making me tear up, because that gives us hope. NETRF it means a lot of hope for me, for my family, and for other people impacted by the disease.
Welcome back. A reminder to submit questions for our Q&A panel through Slido, which you can find on the conference page on netrf.org. Our next speaker is Dr. Yadira Del Rivero of the National Cancer Institute. She serves as the principal investigator of the Natural History Study for neuroendocrine tumor and adrenocortical cancer. Dr. Del Rivero leads neuroendocrine treatment trials at the NCI. She's going to talk today about tackling unusual NETs.
Hello, everyone. My name is Yadira Del Rivero. I am a medical oncologist and an endocrinologist at the National Cancer Institute of the National Institute of Health. Continuing with knowing your NETs, now we're going to discuss about tackling the unusual neuroendocrine tumors. Throughout the day, you have discussions about what neuroendocrine tumors are, where they are located, what means when they're well differentiated or more poorly differentiated. But now we're going to talk about those more unusual NETs that they're also very uncommon, but also can have many different clinical manifestations as well as complications. As we discussed earlier, and as you have learned throughout the day, neuroendocrine tumors can be anywhere in the body. The most common locations is the small intestine, pancreas, as well as the lung. But there are other locations that are more uncommon, but is still part of the neuroendocrine tumor family. For example, in the thyroid, we have a neuroendocrine tumor of the thyroid called medullary thyroid cancer. Medullary thyroid cancer has the capacity to produce hormone called calcitonin, and we're going to talk a little bit about that. We're also going to discuss about thymic neuroendocrine tumor. You have heard more about lung neuroendocrine tumors, but maybe not as much as thymic neuroendocrine tumors, and we'll discuss a little bit of how we manage thymic neuroendocrine tumors. Briefly, I'm going to discuss about another very uncommon neuroendocrine tumor of the adrenal gland called pheochromocytomas and paragangliomas, as well as discuss briefly of more uncommon and rare neuroendocrine tumors that is localized in the genitourinary tract. And we're going to talk what that means and where exactly located. It's important to understand that depending on where the neuroendocrine tumor is located, then patients and the tumor can't produce very specific hormone, and that hormone can lead to different clinical manifestations. Throughout the day, there was a discussion about what is the classification and grading of the neuroendocrine tumors. Well-differentiated neuroendocrine tumors can be anywhere from grade 1, 2, or 3, depending on the Ki-67. And where is the Ki-67 is a proliferation index. It tells me how the cells are able to be divided under the microscope. Neuroendocrine carcinomas are more rapidly growing tumors. The Ki-67 is more than 20%, but usually more than 55%. And this is an area where there is a need for more treatment options, but also to understand that neuroendocrine tumors and neuroendocrine carcinomas are completely different and are also treated differently. neuroendocrine tumors that I originally mentioned, like the thyroid neuroendocrine tumor, the adrenal neuroendocrine tumors, as well as other sites like the genitourinary tract, which affects the kidney, the urethra, etc. They can also have different differentiation. And it's important also to understand that, because depending on the differentiation, then there's going to be specific therapies associated with the neuroendocrine tumors, as well as different therapies depending on the location. In terms of the most uncommon neuroendocrine tumor, for example, medullary thyroid cancer. Medullary thyroid cancer can also be part of the multiple endocrine neoplasia type 2A and type 2B. MEN2A and 2B also has another neuroendocrine tumor as part of the clinical manifestation, which is pheochromocytomas and paragangliomas. Bronchial or thymic neuroendocrine tumors are also being associated with MEN1, as well as pancreas neuroendocrine tumors has been associated with other cancer predisposition syndromes such as MEN1, von Hippel-Lando, or NF1. Neuroendocrine tumors of the adrenal glands, such as pheochromocytoma and paraganglioma, also has been associated with other cancer predisposition syndromes like MEN2A, MEN2B, VHL, which is a von Hippel-Lando, as well as neurofibromatosis type 1, or the paraganglioma syndromes. And I know that I'm saying a lot here, but something to keep in mind, and it's important also to acknowledge that only 10 to 20% of patients that have neuroendocrine tumors may be associated with a cancer predisposition syndrome. And most of the time is the pancreas neuroendocrine tumors, not necessarily the small intestine neuroendocrine tumor. Another aspect is that usually in these cancer predisposition syndromes, there are other clinical manifestations that help us suspect that. Meaning that if you have a pancreas neuroendocrine tumors and no other clinical manifestation, it doesn't mean that you may have this cancer predisposition syndrome. But if there is other clinical manifestations known to be associated with different syndromes, that's when there is a suspicious and further testing is needed. Multiple endocrine neoplasia is a rare hereditary condition that is characterized for tumors of the parathyroid gland. So the tumors of the parathyroid glands are responsible for regulate the calcium in the body. The parathyroid glands are located in the thyroid. MEN1 also has tumors of the pituitary gland, and the pituitary gland can also produce certain hormones, and with those hormones can also produce certain symptoms, as well as pancreas neuroendocrine tumors. That said, there are other sites of neuroendocrine tumors associated with MEN1. We are learning now that despite the classic characteristics of MEN1, which is parathyroid, pituitary tumor, and pancreas neuroendocrine tumors, now we know that there is other neuroendocrine tumors also associated with MEN1, such as thymic neuroendocrine tumors, bronchial neuroendocrine tumors, stomach. There are other neuroendocrine tumors associated with MEN1. And is associated with a germline mutation in the MEN1 gene. And germline means that the mutation is everywhere in your body, and it has the capacity that that mutation can also be presented in your offsprings or in your kids and so forth. As we discussed, a very common clinical manifestation of MEN1 or multiple endocrine neoplasia type 1 is the pancreas gastrointestinal neuroendocrine tumors, and is the second most common manifestations in patients with MEN1. These pancreas neuroendocrine tumors can have functioning tumors, meaning that they can produce hormones, or non-functioning, meaning that they cannot produce hormones. And as we discussed earlier, depending on where the neuroendocrine tumor is located and depending on what hormone that neuroendocrine tumor produces, patient can present with a very specific clinical manifestations, and we're going to talk a little bit about that. Patients that have MEN1 with the associated Zollinger-Ellison. Zollinger-Ellison is a neuroendocrine tumor that produces excess of gastrin. We also call it gastrinomas, which can be found in the small intestine as well as in the pancreas. Gastrinomas, but the pancreas are super, super rare that they can't be present there. Most of the time is located in the small intestine. 25% of patients with Zollinger-Ellison are associated with MEN1. So if there is a patient that may have neuroendocrine tumor that produces excess of gastrin, it's indicated that patients need to be tested for this MEN1. Now, the thymic and bronchopulmonary neuroendocrine tumors are uncommon in MEN1, but it can happen. In MEN1, up to 8% of patients may present with a thymic neuroendocrine tumors, and patients in lung neuroendocrine tumors can also be present in less than 5% of patients. And most of the times are non-functional because throughout the day, and maybe for another podcast that the Neuroendocrine Tumor Research Foundation have, lung neuroendocrine tumors can also produce hormones, and those hormones can also produce a very specific clinical manifestation. These thymic or bronchial neuroendocrine tumors, when the hormone is produced, they can produce either excess of serotonin, causing a carcinoid syndrome, can produce excess of ACTH, and this hormone is responsible for stimulate the production of cortisol in the adrenal gland. And that condition is called Cushing's syndrome. And we'll talk a little bit about that and what does that mean. In terms of the treatment related to MEN1 related tumors, as we discussed, pancreas or small intestine neuroendocrine tumors can present as functional or non-functional. As we discussed, functional meaning that it can produce hormones, and depending on what hormones the tumor produces, then may be certain specific interventions needed or treatments needed for that. And in terms of the thymic neuroendocrine tumors, as we said, most of the time are non-functional. Usually when the thymic neuroendocrine tumor is located, those patients may require surgery and sometimes may require radiation. And patients with MEN1 can be quite rare, but they can also be serious. The same with lung neuroendocrine tumors. Sometimes when they're located, sometimes surgery may be indicated, but if not, there are other interventions. These lung and thymic neuroendocrine tumors in a patient with MEN1 can also spread out to other places. And in those situations, that's with more systemic therapy is indicated, as you've heard throughout the day. Stomach neuroendocrine tumors, that's the one that it produces excess of gastrin, the hormone that is responsible to regulate the acid in the stomach. If you have too much gastrin, then you have a lot of acid in the stomach, and that can also cause a lot of complications, including bleeding and ulcers, or what we call peptic ulcer disease. There are other rare places that patients with MEN1 can have neuroendocrine tumors, and those are such as a small bowel or the adrenal gland, as we discussed, but that's very rare. When this is present, there are treatments, and those treatments need to be discussed in a multidisciplinary team to determine what is the best for those patients. As we discussed, thymic neuroendocrine tumor, what is functional, can produce either serotonin, and this excess of serotonin can cause carcinoid syndrome. And throughout the day, you also heard that small bowel neuroendocrine tumors can produce excess of serotonin, and sometimes there are certain drugs needed to control not only the growth of tumors, but at the same time, the excess of hormone or the symptoms related to excess of hormones. But let's just talk a little bit about these hormones that I know is very unique hormone. Is called ACTH. It's a very long name, but the information for this hormone is that it can stimulate the production of cortisol in the adrenal gland, and because of that, it can cause syndrome called Cushing's syndrome. It can be present not only on the thymic and bronchopulmonary neuroendocrine tumors, but it can also be associated with the pancreas as well as adrenal, thyroid. So this condition called Cushing's syndrome is something that can happen, and sometimes it's occult. And that's something that when the excess of cortisol is present, the symptoms can be also quite obvious, but it's something that needs to be acknowledged and recognized. What are the symptoms of Cushing's syndrome? As we can see here, there are many clinical manifestations. Most common clinical manifestations that we see a patient with Cushing's syndrome is the purple stria. There is also an increase in fat of the abdomen as well as the back of the neck. Easy bruising as well is present, thin skin. There is also very clinical characteristics and fat called moon face. This excess of cortisol can increase blood pressure, can also cause hyperglycemia, can also cause some personality changes, depression, and those are a series of symptoms that related to Cushing's syndrome. And like I said, this happened because there is an excess of cortisol, and there are treatments that can be given for the excess of cortisol. If the neuroendocrine tumor is localized, like for example in the lung and thymic neuroendocrine tumors is localized, then surgery is indicated. Sometimes they require oral medications in order to control the excess of cortisol. One of them is ketoconazole, one of them is thiropon. So there are different oral medications needed to control the excess of cortisol. And that we see in patients that has more like widespread disease. In those situations, the removing the adrenal glands is indicated because you remove the stimulus of producing the excess of cortisol. Now let's discuss a little bit about medullary thyroid cancer and what medullary thyroid cancer is and what this type of neuroendocrine tumor do. Medullary thyroid cancer arises from a very specific cell in the thyroid gland called C cells. And this type of C cells is also responsible to produce a hormone called calcitonin. It helps regulate calcium levels in the body. When there is this excess of calcitonin, patients sometimes can also have a series of symptoms. Medullary thyroid cancer, in about 75% of the cases, is sporadic, meaning we don't know how it happened. But in 25% of cases, it can be familial or hereditary. And when that happened, the gene that is associated with this hereditary medullary thyroid cancer is called the RET gene. And this is important to know because if we have a patient that had clinical manifestations or present with medullary thyroid cancer, then it needs to be tested for this gene responsible for the syndrome called MEN2A or MEN2B. As we can see here, when it's hereditary, MEN2A can affect the parathyroid gland, can also cause medullary thyroid cancer, and it can also be associated with pheochromocytomas, which is another type of neuroendocrine tumors localized in the adrenal gland. MEN2B is a little different. The similarities is that they can have pheochromocytomas as well as medullary thyroid cancer, but they have very specific physical manifestations, tall and lengthy, that's called Marfanoid bodies, and sometimes they can present like a little neuromas in the mouth, for example, and that is characteristics of MEN2B. As I say, when it's hereditary, is because there is a tumor gene associated with this MTC, and this gene can also be present not only on the germline, causing hereditary MTC, but also in 50% of sporadic MTC can also be present in the tumor, which is different than in the germline. So RET gene plays a role in familial medullary thyroid cancer, but in patients that we don't know the cause, in sporadic MTC, half of those patients may have that mutation. And why I'm mentioning this, because there is specific medication, drug that specifically targets that RET mutation. And that's important to know. When it's localized, surgery is usually what is indicated. And sometimes in the thyroid, they also remove lymph nodes near the thyroid as well when the MTC is spread. So there are different medications. Selpercatinib and prasetinib, those are the medications that targets the RET gene. And again, it's important to recognize it can be hereditary, and most of the times are associated with familial syndrome called MEN2A or MEN2B, and that is a germline RET mutation. But also in 50% of patients that have MTC, that we don't know the cause, it can be only in the tumor, meaning it's not hereditary. That's why patients that have medullary thyroid cancer, it's important that they do genomic testing in the tumor to be able, if the patient is eligible for these specific therapies that target that specific mutations, which we know it works well for patients. Now, very briefly about genitourinary neuroendocrine tumors. What are the possible neuroendocrine tumors of the GU tract? It could be in female, it could be the cervix, the uterus, the ovaries, and male, it could be the prostate. But there's also neuroendocrine tumors that can affect the bladder, the kidney, the ureters. These are very rare type of neuroendocrine tumors. But also these genitourinary neuroendocrine tumors, some of them can be well differentiated, but a good number of these genitourinary neuroendocrine tumors may be more poorly differentiated. And as we discussed, there is a difference between neuroendocrine tumors as well as neuroendocrine carcinomas. It's important to diagnose earlier. There is different imaging and biopsy in order to determine the type of neuroendocrine tumors. There are different treatment options, such as surgery, chemotherapy, targeted therapy. But that said, it's important that when a neuroendocrine tumor is diagnosed, to have a discussion with a multidisciplinary team in order to understand what treatments may benefit the patient the most of the treatments that we have available. Now, here, very briefly, in terms of the management of neuroendocrine tumors, we have a variety of drugs. And throughout the day, there has been discussion of what drugs we can use or what kind of therapies we can use in patients with neuroendocrine tumors that is widespread. You have heard about PRT throughout the day and the monthly injections called octreotide lanreotide. These injections are important because not only help control the growth of tumors, but also help control the symptoms related to hormone excess. And in patients that neuroendocrine tumors is diagnosed and there is some growth, the question is, do we continue with these injections? And we continue as long as the tumor is functional, meaning it can produce hormones, because like I say, it can also help control the symptoms related to hormone excess. There are different targeted therapies, such as everolimus, sunitinib, cabozantinib, you have heard throughout the day, as well as when to use chemotherapy, and as well as when to use surgery or a very specific type of therapy in the liver. It's called ablation or embolization. I'm just mentioning this because, as we can see, we have treatment options for neuroendocrine tumors. When do we need to know what treatment is indicated for each patient is depending on the site of neuroendocrine tumors. So we discussed the more rare type of neuroendocrine tumors. We also need to know whether they are slow growing or rapidly growing, because treatments are different too in that aspect, or if they're well differentiated or poorly differentiated as well. We also need to understand whether the tumor expresses somatostatin receptor or not, so that way PRT can be an option. We also need to understand where in the body it's localized, whether it's only in the liver or if it's outside the liver. So that way it can help us guide what is the best therapy for a patient with neuroendocrine tumor. So we really need to account the clinical characteristic of each patient, because it's not a one size fits all. So the treatment is quite personalized from patient to patient. Now let's discuss a little bit about pheochromocytoma and paraganglioma. And this is a neuroendocrine tumor that is very close to my heart. That's how I started in the field of neuroendocrine tumors, by studying pheochromocytomas and paragangliomas. Pheochromocytoma is a very rare type of neuroendocrine tumors that forms in the adrenal gland. As we can see in the picture, are located on top of the kidney. If we cut the adrenal gland in half, it has two layers, as we can see in the picture, and the inner layer is what we call the adrenal medulla, and that's the part that is responsible to produce excess of adrenaline. And this excess of adrenaline is responsible for the flight and fight response. Paragangliomas are located in different nerves throughout the body, could be anywhere from the head, chest, abdomen, and pelvis. Depending on where they're located, they can be functional or they can be non-functional. Pheochromocytomas and paragangliomas, when we look at all together, most commonly we see pheochromocytomas, which are located in the adrenal gland. Most of the pheochromocytomas, like I say, functional, meaning that they can produce excess of hormone, but also paragangliomas located anywhere from the head, abdomen, and pelvis. It can also be located in the neck area. Most of the time, they are non-functional because they come from a different type of part of the nervous system. But when they're located anywhere from the chest, abdomen, and pelvis, often they're functional, meaning that they produce hormones. And this excess of hormones can certainly cause a very specific symptomatology. Now, every patient that has pheochromocytomas and paragangliomas needs to be evaluated by a genetic counselor. And the reason why is because up to 45% of patients that has pheochromocytomas and paragangliomas may have a germline pathogenic variant. And as I discussed earlier, the difference between germline and somatic, germline is everywhere in the cells and it has the capacity to pass to your kids, whether somatic is only in the tumor, and that's not hereditary. But every patient with pheochromocytoma and paraganglioma needs to have a genetic counselor. If we see a patient that have a paraganglioma of the head and neck, sometimes we think, well, there may be a mutation indicated with that, which we call succinate dehydrogenase mutation D. If we have a paraganglioma, that can be anywhere from the chest, abdomen, and pelvis. There is another mutation associated with that, which is called SDHB. The reason why I'm saying this is because patients that has more advanced disease and that has widespread, often we see an association with this mutation, especially SDHB. There are very specific symptoms related to paraganglioma. As I said, very rarely are non-functional, and that's usually when it's localized in the head and neck. But when they are functional, with this excess of hormones, can produce many different symptomatologies, such as flushing, palpitations, abdominal pain, blurry vision, tachycardia. The most classic symptoms that we see in those patients is high blood pressure, headaches, and sweating. And because of that, there are medications as well that can help us control the symptoms related to this hormone. We can see here there is different medication that is used, and it's important to recognize that there is treatment recommended to address the symptoms related to excess of hormones, but also there are treatments indicated whenever we need to control the growth of tumor or when the patient has a widespread disease, so there are different therapies for that. And this is my last slide that in terms of the treatment of pheochromocytomas and paragangliomas, very similarly to what I discussed for neuroendocrine tumors and the more uncommon size of neuroendocrine tumors, it's also personalized from patient to patient. Depending on the different clinical characteristics, similarly to other neuroendocrine tumors, we need to know whether the tumor expresses somatostatin receptor, whether they can rapidly growing or slow growing, to where it's located, whether it's on the head and neck, or whether it's in the abdomen. Sometimes surgery may be indicated in order to control some of the symptoms related to hormone excess, sometimes by resecting the tumor. Sometimes that can help also minimize some of the hormones, and that can also help decrease some of the symptoms related to hormone excess. But that say is not for everyone. And like I discussed earlier, treatment is personalized and needs to be discussed in a multidisciplinary team with surgeons, interventional radiologists, and endocrinologists, oncologists, so that way we can formulate a plan that we think it will be best for patients. And my conclusions: unusual NETs are rare, but they are treatable. They can appear in places like thyroid, thymus, the genitourinary tract, as well as the adrenals. Early diagnosis and close follow-up matters. We imaging studies as well as lab tests, including hormonal evaluations when it's indicated, and sometimes genetic testing to help guide care. There are many treatment available for neuroendocrine tumors, such as surgery, different oral medications, chemotherapy, as well as PRRT, as we discussed, which is a type of systemic radiation. More importantly is to recognize that you're not alone. Neuroendocrine tumor care involves a team of endocrinologists, oncologists, surgeons, nuclear medicines, gastroenterologists, radiologists, and also very important support groups. NETRF is a wonderful organization where there is a lot of material where you can refer to in terms of all the different type of neuroendocrine tumors, and also to understand more about how these tumors present and what are the treatment needed. And there is a lot of information where you can go back and understand when surgery may be indicated or when systemic therapy may be indicated. So I think it's important that rely on the support groups as well as the information out there from different support groups, as I say, like NETRF. And also ask questions, always ask questions, stay informed. Knowledge is power. Every neuroendocrine tumor is different, and understand your type help make the best decision in terms of your treatments. And with that, I would like to thank you for your attention.
Thank you very much, Dr. Del Rivero, for this great presentation. Now it's time to do our neuroendocrine tumor board. This is always a session I think that many of our patients enjoy, as they get to observe how clinicians interact in a multidisciplinary fashion when they discuss a neuroendocrine tumor patient's case. Today on our tumor board, we have Dr. Suarez from the University of Utah. We have Dr. Eads from the University of Pennsylvania, Dr. Hav Dannison from Mayo Clinic, Dr. Chandrasekaran from MD Anderson Cancer Center, and then our own Dr. Khan and Dr. Liao from the University of Chicago. We're very excited to present these two cases to you, and we hope that you'll enjoy it. So welcome all to the NETRF Neuroendocrine Tumor Board. We're really happy to have you here, and thank you for taking the time out of your busy schedule. So Andy, why don't you get us started with the first case?
Okay, so our first case is a 45-year woman. She presented with right upper quadrant abdominal pain and also back pain. She also had flushing and night sweats and watery diarrhea. And she says she has occasional abdominal cramping after eating. So she went to her primary care doctor, who did an abdominal ultrasound, and it showed multiple masses in the liver. That was followed by a CT abdomen pelvis, which showed a terminal ileum lesion, mesenteric lymph nodes, enlarged liver with liver lesions, and then portal hepatic lymph nodes. And I'll show you the images in the next slide. But she had a liver biopsy, and that showed a well-differentiated neuroendocrine tumor. It was grade 2 and KSE7 of 10%. Her labs showed normal liver function. Her serotonin was 1423, and she had an echocardiogram that was essentially normal. So if you look at her CT abdomen pelvis, so on the left-hand side, you see in the circled area, that's where the terminal ileal lesion is. It's like a 2 by 3 centimeter lesion. And then on the right-hand picture, you see one of the examples of the mesenteric lymph nodes that she has. And this is our MRI abdomen, and this was done with EOVIS contrast, so hepatobiliary phase contrast, which really produces clear pictures of the liver lesions, as you can see here. Just show you two representative cuts of her MRI abdomen with EOVIS. And then this is our dotatate PET scan. This was gallium dotatate, and so it showed a lot of uptake in all of these liver lesions, as well as the terminal ileum lesion and the mesenteric lymph nodes. So basically, we have the 45-year woman who was newly diagnosed with a metastatic, well-differentiated grade 2 small bowel neuroendocrine tumor, and she has liver metastases. So I'm going to open this for discussion. How do we best approach this case? So I'll start by asking Dr. Koiken, do you see a role for surgery here, either resection of the primary tumor or liver debulking surgery?
Thank you, Andy. So I think from a surgical perspective, there are two things that we look at, especially with small bowel neuroendocrine tumor. We look at the primary tumor, the size of the primary tumor, and if the primary tumor is causing any symptoms. You mentioned she had diarrhea. Was she complaining of any cramping or any pain after eating?
Yeah, she did say that after eating, she feels abdominal cramping, but she hasn't lost any weight and she's able to eat solid foods and keep everything down.
And then the second point is obviously from a liver debulking surgery, not all centers do that, but that's another question to ask. So one of the things that strikes me on the abdominal CT here on the left-hand side is that that lesion seems to be quite large. It seems to occupy a majority of the small bowel lumen. It's not that common actually that the primary tumors are that big. And certainly here you could see you have these white little streaks of contrast that fill the bowel lumen. And there really isn't much contrast that goes along the lesion here. So I would say that this is a near occlusive small bowel tumor. In addition to the story that she tells us with the cramping after she eats, I would suggest that this probably needs to be removed surgically, just in order to avoid a situation where she gets treated systemically and we end up having a bowel blockage that would interrupt this treatment and then potentially end up having to have an urgent or an emergent surgery, which are always more complicated and have higher rates of complications. From a liver debulking perspective, I think this is a little bit too enthusiastic for me. I think there are a lot of tumors here, and I don't think that this would be the first line of treatments, but I could certainly imagine that there might be a role for liver-directed therapy either now or at a later point.
Hey, thank you. So, Dr. Khan, liver-directed therapy-wise, would she be a good candidate for this? And if so, what would you use? Would you use embolization, either blend embo or chemoembolization or radioembolization or Y90? And what about histotripsy? Everyone asks about that in clinic nowadays.
Yeah, so certainly there's a significant amount of liver disease here. I think that, addressing the small bowel tumor initially would be something kind of focus on primarily, and then maybe subsequently looking at performing liver-directed therapy. This is sort of diffuse, a bulky tumor both sides. And so I think in this case, I'd sort of favor a blend embolization. Not too much of a significant difference between blend embolization and TACE, especially based on kind of initial results of a recent trial, a RETNET trial. And then TARE, I would sort of favor for like larger like single lesions. And so I think she's a good candidate for blend. We could do histotripsy as well. Once again, the histotripsy is a new technology, not a lot of data. We have performed it at our institution. And certainly some of those, if we go back to the MRI, there are a few of those that are pretty close to the front surface of the liver, which are look to be amenable to visualization with ultrasound. And so maybe treating one or two of those lesions and sort of hopefully stimulating a potential immune, getting some immunostimulation with PRRT is a possibility. I think blend embolization may do a little bit more here. And then certainly, Andy, if I kick it back to you for systemic treatment, that might be more of the road to go down.
You mentioned something interesting. Is there any data to support this scopal effect, like the histotripsy engendering an immune response in specifically for neuroendocrine tumor patients?
Not any in human data specifically. Certainly, there's been some basic science and some mice models that have shown some upregulation based on cytokine release and antigen release.
but nothing in human. And so
So
it's
we
being
still need to wait
studied.
for
Yeah.
clinical trial data. Okay, great. Thank you.
Yeah.
And then for the oncologists in the room, what would we do for systemic therapy? What would you give this patient? So I'll pick on Dr. Chandrasekaran.
Thanks, Andy. So, yeah, in this patient, she was also had a functional tumor based on her symptomatology, flushing, and diarrhea. So, I think the consideration of a somatostatin analog is definitely, one of the first things in terms of timing, whether the surgeon takes the primary tumor before, after. I think ideally I would get her started on somatostatin analogs for the syndrome presented to the surgeon for consideration of the primary tumor, given her symptomatology would be the way to go. I think the question of first-line PRRT is interesting. I can see the patient has a Ki-67 of 10%, which is kind of the cutoff for the NETRF trial, which looked at upfront PRRT as an option. These are patients within 6 months of diagnosis, and she probably meets the criteria. Personally, though, I think without a clear benefit on overall survival with upfront PRRT, I have not adopted it for the patients all upfront. Given the distribution of the disease and the symptomology, you could make an argument that PRRT has good data for symptom control, quality of life preservation, etc. But again, these are studied in the second line setting when I'm talking about the quality of life. So I think get the primary tumor out if symptomatic, start on SSA analog therapy first, and kind of reassess with imaging and symptoms later would be my choice.
Great. Would any of the oncologists here disagree and say this patient should, or you would start this patient on first-time PRRT?
So I wouldn't. So for a couple of reasons. So number one, we do not have data on overall survival with upfront PRRT. We know from NETR2 that progression-free survival was markedly longer with PRRT upfront. But it will also say that this patient would barely have made it onto the trial with the lowest possible KS7. And we have data, the somatostatin analog therapy works up front. So my take has been just to play that card first, the somatostatin analog card, and just see what mileage you get.
Great. Dr. Suarez, Eads, any other thoughts?
Yeah, I agree. I think that's someone by the book will certainly meet the criteria, but I haven't incorporated it really in the first line setting. I think one thing that probably many of us will do is to scan this patient a little bit more closely. I typically scan patients with small bowel neuroendocrine tumors every 6 months, the majority of them. This patient is someone that will probably do a repeat MRI in the 3 months mark or 4 months mark, just to have a sense. Because I didn't have a sense from the beginning of the presentation of for how long she has been living with the symptoms to sort of indirectly guide me if it is someone that the disease suggests that's really truly indolent, or this is one of these tumors that might behave a little bit more aggressive that you would expect. So for these reasons, I will scan her in a little bit of a shorter timeline than I normally do.
If I could just add to that, I agree that starting with a somatostatin analog makes the most sense and is what I would do in this situation for both anti-tumor control and for hormone-mediated symptoms. But I agree with Eloisa as well that wanting to take a look early would be wise, especially in someone who has a relatively large degree of tumor burden in the liver. And it is a patient with liver dominant disease. So oftentimes at our institution, we may consider doing somatostatin analog. And then if symptoms are either not optimally controlled, or if we're worried about the pace of disease in the liver, we'll layer on the embolization in addition to the somatostatin analog, just to try to make sure that we maintain good control over the liver, because in a patient with this distribution of disease, oftentimes the liver involvement is where we get into the most trouble.
Yeah, that's a great point. So this is the timeline. So she was diagnosed in September 2020. We started her on first-line lanreotide, and then because she was symptomatic from her primary tumor, she had surgical resection of the primary tumor, cholecystectomy, but also a liver wide resection that showed a grade 2 well-differentiated neuroendocrine tumor, Ki-67 6%. And then in April of 2021, so about 6 months later, there is mild increase in size of several of her liver mets, but her serotonin almost doubled, and she was having worsening flushing and diarrhea. And so you can see here the tumors, they're only mildly increased in size. So for reference here, this lesion here went from 32 millimeters to 36, so 4 millimeter increase, but it seems like her symptoms are clearly worse. So what would we do next in this situation? Dr. Khan?
Yeah, I mean, at this point, I'd be a little bit more stronger advocate. Liver therapy, still we have bilobar disease, so suggest treating with blend embolization, breaking treatment up to like each lobe, kind of 4 weeks apart.
And then Dr. Corgan already told us this was too much tumor for liver debulking. For the medical oncologist, would you change the systemic therapy at this juncture?
I would not necessarily do it, but I would obviously start prepping for it though. And so there is progression, there is an increase in the serotonin, and symptoms might be worsening. And we know that radioligand therapy with lutetium does help with symptoms. We have evidence from NETR1, we have retrospective data from the Netherlands. So I think this would be sort of the time where I would really start thinking of radioligand therapy. And personally, that's where I would go next.
So that's indeed what we did for this patient. So she had blind embolization, one lobe at a time. And then 9 months later, her MRI and dotative PET scan showed disease progressions. So you can see here on the dotative PET scan, there's progression in the liver, but also she seems to have developed new dotatate avid retrocrural lymph nodes and then bone metastases in the T3 area. So Dr. Halfdannerson said that you would do PRT. Does anyone else agree or any other thoughts?
I think ideally, of course, with every patient, every discussion involves all the treatment options. So even at the prior step, I would want to have a good discussion about all the options. At this time, technically, you could think about, quote, any systemic therapy, everolimus, cabozantinib with the approval, or PRRT or a clinical trial if you have. With that discussion, if probably yes, I agree with Dr. Hefnerson that I would be leaning towards PRRT. She's got definitely good receptor uptake, as one can see, kind of has also extrahepatic disease burden. But I'm not sure if at this progression, May of 2022, she had a symptom progression as well. But regardless, I think from a quality of life perspective / disease perspective, that may be a good next step. But
Great.
again, there are patients who would take another option as well. So a discussion and then proceeding towards my code recommendation.
Okay. And everyone asks about alpha PRT nowadays. So what do we know about alpha PRT, and is it better than conventional Lutathera?
So alpha particle therapy, just a quick introduction to that. So it is the same concept as with lutetium-177 or Lutathera. We're delivering a radioactive particle to the tumor cells. It's given IV. It's sort of glued to a octreotide or lanreotide-like drug. It floats around in the body. It latches onto the tumor cells like two pieces of Velcro and deliver its radiation charge to the tumor. So alpha particles have much higher energy. They travel much less in terms of distance. And they have never been compared to beta particle therapy like lutetium. Those trials are actually coming. What we do know is that the two trials that have looked at something called lead-212 or PB212, there are two different types of that. The initial results are actually very promising, but the question is really, will it hold up over time? And so yes, there seems to be a higher response rate. We shrink more tumors and we shrink them more than we do with lutetium, at least seemingly. But the question is really, how long does it hold up? So I'd say if you have an alpha study, by all means introduce it, talk to your patient about possibly participating in that, but we don't have any comparative studies yet.
Great summary. So let's move on to the next slide. So she indeed was treated with PRRT with standard Lutathera, and then 2.5 years later, her scan showed disease progression. So this is an example. She had mild progression of many of her liver lesions, but this one in particular in segment 3 got significantly larger. And then she also developed new bone mets. As you can see here, they're all very small, very subtle. So at this juncture, what will we do next?
So especially when I have a patient who has one rogue lesion kind of growing faster than the others, I would think about rebiopsying the patient at that juncture, specifically the lesion that is growing disproportionately to the others, to make sure that we're still dealing with the tumor biology that we think we are. Oftentimes over the course of having this disease for several years, we will see some grade creep. So the Ki-67 may increase over time and become maybe less likely to respond to things that well-differentiated tumors do. Provided that still showed a grade 2 tumor that didn't seem too particularly aggressive, I would think of a couple of options. So sometimes, especially for a liver lesion that's kind of growing disproportionately, we will do some targeted embolization just to that lesion and then treat the rest of the disease sort of a different way. It also looks like this patient responded quite well to PRRT, and so could be considered perhaps for either retreatment with the standard PRRT with lutetium-177, dotatate, or could be a good candidate for alpha therapy, ideally on study, to give it another go that way.
Great, thank you. Dr. Chandrasekaran or Suarez, any other systemic options you would consider here?
Yeah, if I may say, and I know that's not usually majority of standard of care, but this is when I see this disagreement between the grow. In addition to chasing the lesion, I like to sometimes, if possible, do a FTG PET, because that helps me to decide if I'm going to go on a more systemic approach that could potentially even include more traditional chemotherapy. And if I see that there are several lesions that are positive on the FDG PET, my leaning towards that rather than just chasing one or the two lesions in the liver. And it's not infrequent that we see these things. So that's one additional test or tool that could help, at least in my thought process, how to decide on next steps.
That's a great point. Dr. Chandrasekaran, any other systemic options you would consider?
Yeah, I think I would incorporate pretty much all the steps mentioned about if especially one or two lesions are growing, rebiopsy, FDG PET, which could also guide in choosing the lesion to biopsy. Ideally, you would go for an FDG ab lesion. I would probably also repeat a gallium PET just to see, because you may still have receptors retained in these patients. I think it's, again, even though she had a 2-year demonstrated stability post-PRRT, if there is this grade creep happening, we expect maybe even lesser from that PRRT if we repeat it. So again, I would still offer it as an option and discuss. We have very little data for everolimus in the grade creep setting or grade, higher grade. Cabozantinib technically has data in grade 3, but that's a very small subset of patients. So I think it's a little hard. So I guess technically, again, a discussion, but I would maybe, if still receptor positive, go for a PRRT type of option if receptors are present, or consider an embolization to that one lesion, which is receptor agnostic, get the cancer to declare itself better as to what's going to do, and then decide the next option.
Right. Dr. Koiken, any role for surgery here?
Surgery is a big biopsy, right? If you think about it, surgeons are just big biopsy people in the setting of metastatic disease. So it depends. So I would argue, having known this case actually, because this is our common patient, if I remember well, her symptoms got significantly worse again. Having learned from liver-directed therapy that the bland embo part, didn't really control symptoms very long, I would argue if it's just a few lesions that are rogue, that rather than just doing a biopsy, if she had a good response to PRT, and because she's symptomatic and her symptoms are getting worse and her serotonin is going up, if there's a role for debulking. And I would say it again depends on the overall liver tumor burden, but she hasn't been debulked yet. So certainly you can debulk after PRT. And interestingly, we see it more and more, that patients get PRT kind of not first line, but, second line after progression on long-acting octreotide, and now have had some response to it, the liver tumor burden decreased, but now they're slowly progressing again. So that doesn't really take them out of contention for debulking, especially in those cases, I would say, that have a high serotonin level and with worsening symptoms. So it might be an option in her, depending on what the scan looks like.
So we consider all these points that everyone brought up. This was shared decision making with the patient. So she decided to go through surgery. So she actually had liver debulking surgery in January. And so the pathology is very interesting. So still show a well-differentiated neuroendocrine tumor. But if you look at the different liver lesions that were taken out, so the segment 1 lesion, Ki67, was 20%. Segment 3 was 45% with 40 mitoses. Segment 4B was only 1%. Segment 5 was 12.4%. And then segment 8 was 1.4%. And then we did next generation sequencing on this segment 3 lesion because the Ki67 was highest. And so that showed RB1 LAT4 loss, low tumor mutation burden, and microsatellite stable disease. So, like several of you were already alluding, there seems to be this grade creep phenomenon going on. So, Dr. East, how often do we see this in small bowel neuroendocrine tumor, and why do you think that causes this?
We actually see it quite a bit. Our group at Penn had looked at this actually and shown that with the grade creep phenomenon that the Ki-67 generally increases about 1% per year. This is a little bit more beyond that, but it's not uncommon for these tumors to actually be very heterogeneous, not just within cross tumors, but also within one tumor. So I think it's actually not too surprising that there are several different Ki-67s represented across all of these different segments. And I don't know if we necessarily have a great understanding of why one necessarily takes off. Certainly, the next generation sequencing showing the RB1 loss is something that we do see in the higher grade tumors. Oftentimes, it's more in the poorly differentiated setting as opposed to the still well differentiated histologies, but it's definitely demonstrating features that are suggesting that it's kind of transitioning into a more aggressive tumor biology.
Yeah, great points. So at this juncture, so she just had her liver debulking surgery and she's still on lanreotide. Will anyone offer additional or change in systemic therapy given this surgical pathology?
I would probably wait and see what happens. Technically, this is the rogue lesion, which is bad biology, but it's done for now. Hopefully, she has symptom relief from this. And you didn't tell me if she still had receptors prior to this. I think she, per the Gallium PET, probably did. So I would kind of wait it out and see what happens and treat based on that, and not necessarily give something right away. I
Great.
think this grade
So
creep is
let's,
very interesting for all of us, as we know.
yeah, so let's go to the next slide. So that's indeed what we did. So we waited and then let her recover from the surgery, continue the lanreotide, and then 6 months later, her scans unfortunately showed disease progression. So this is the MRI comparison between April and July. You can see there's a significant increase in her liver metastases. And this is a dotted PET. So in addition to the worsening liver metastases, there's also now diffuse bone metastases. So what will we do in terms of treatment at this juncture? So Dr. Suarez?
Yeah, I think I will do a two-step approach. Something that you can get it right away. I'll start her on full Fox and prep her, do up to 4 months or of full Fox, hopefully get a little bit more control, and then set it up for potentially, if possible, repeated PRT, which probably have to be off label. I don't know if she would necessarily qualify for that trial. But unfortunately, this is a situation that the biology of disease is not being kind to us and to the patient, and you already have to start like really setting up boom, 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 all the steps because you're not outside of the initial PRT. Disease control is not being held for too long. And it takes a little bit of time to get PRT in place, right? So especially
Yeah,
if it's off label, so I will do full Fox personally. But we'll love to see
great.
what my colleagues will do.
Yeah, Dr. Halpdanderson, what would you do?
So one option you have is cabozantinib. So keep in mind cabozantinib will not control the syndrome, but refractory small bowel or non-pancreatic NETs may control the disease for about 8 to 9 months. Probably a bit shorter in this high grade. So that this is all based on data from the cabinet trial. There was not a whole lot of grade 3 patients there. So that probably would be what I would do next. So would be cabozantinib, continue the somatostatin analog. If the syndrome is uncontrolled, you have two options. You can increase the dose of the somatostatin analog, even shorter the cycle, and you can add telotristat to control the serotonin production, keeping in mind that the cabozantinib is not going to do that. Or at least not the symptoms reliably. And then you have everolimus, but we have no data on everolimus, but we have, or not at least prospective data, but we have some retrospective studies, and we've all seen everolimus work in this situation. So we have, and
Great.
repeat PRT, an option too.
Okay, Dr. Chandrasekaran, what would you do in this situation?
I'll first say this is probably the most interesting part of the tumor board because you
Yeah,
get this different discussion and I guess maybe differing opinions, but still the same. But I'm gonna probably start by something that's probably everybody does, actually counsel the patient because I think a lot of times patients have this perception, I've been told I'm not gonna die from this cancer. This is a 45-year-old was diagnosed with a grade 2A indolent small bowel neuroendocrine tumor. Now, I think it's important to emphasize to the patient first this is not maybe quote the same disease they've been dealing with in the past few years. I think that is important because no matter what we do, probably in this situation, the benefit and the time it's going to have is going to be lesser than any other conventional therapy. With such a liver burden in such a short time, the threat of a impending liver failure when this disease takes off is very real. I think we should counsel all our patients. We all do. I think this is a little bit more urgent situation. So I'll start there. I think I may lean towards what Dr. Suarez was alluding to. Just based on the April to July scan that you showed, there was quite a bit of progression, RB loss, even though it was a well-differentiated neuroendocrine, but very high. It's kind of behaving like, to me, clinically a poorly differentiated. I have probably a little bit more faith in oxaliplatin or platinum-based regimen, but I'm glad to see she still has receptors, so I would not exclude PRRT. Certainly, I would have a discussion about cabozantinib, but maybe not my first choice in this situation. So,
Great, thank you. And then last question, Dr. Eads, what would you do? And would this patient be a candidate for CAR T therapy?
So, yeah, that's an interesting question. So, I'm inclined to agree with Dr. Suarez and Dr. Chandrasekaran in the sense that I am uncomfortable with the pace of disease. The rate of progression has been quite fast, and we're really going to want to be able to get good control, or ideally good control, in a short period of time. I probably would do an FDG PET to see, again, like how much of this disease looks FDG avid versus dotatate avid, and would favor some FOLFOX, perhaps then followed by consolidation with PRRT. The other thing to remember about PRRT is that it does not work quickly, and it's a treatment that we administer over several months. So when you need a rapid response, it just isn't maybe the thing to be looking toward. As for the question about CAR T therapy, so certainly a very interesting area that we are investigating at Penn in this particular patient population. It's something only available through clinical trials at this time. It's not something that would be standard of care. I think that I would be a bit nervous about it in a patient with rapidly progressive disease like this. It takes time to go through the CAR T process. We have to harvest T cells from the patient, manufacture them to be targeted toward the cancer, and then give them back to the patient. And all of that takes some time. Additionally, I think we're still not quite certain about how safe it is in patients who have a large degree of liver burden. So in this particular instance, I might be cautious that way as well. But as we learn more about it and hopefully get faster at manufacturing the cells as well, it may be an option, but why we participate in trials.
Yeah, definitely. Thank you. Dr. Chandrasekaran, you had a
and
question,
then I know
comment?
we are short on time, but I just wanted to throw a question out. I know we just had a big surgical biopsy that Dr. Quagan gave us, but I'm wondering if even within that information, again, at quite a bit of progression, would anybody rebiopsy? What if the tumor mutation burden has increased or something? I know the phenomena has been described more in temozolomide exposed patients, but I just kind of wanted to throw that thing out there. I may consider biopsying again.
Great point. Great point. Well, thank you for bringing that up.
Thanks to all of you. It's not easy to get you all out here and doing this. So thank you very much.
Thank you to all the participants in the Tumor Board. The discussion is a great example of the value of a multidisciplinary team. Now we hear from some of our thrivers with their perspective. After a very short break, we'll be back with a focus on thrivership through knowledge, wellness, and advocacy.
Well, I had a long period between my very first surgery and the next one. It was 12 years, and they didn't believe that it had come back. I mean, they were just shocked. So I had test after test after test after MRI after PET scans. So that's when my doctor here said, "You've got to go to a teaching hospital." So that's where I wound up going. And the last surgery was partially robotic. So it's changed that much over the years, from very invasive, long recovery, robotic surgery on my lung, and I was out of the hospital in 3 days instead of 2 weeks, and a much shorter recovery.
I think from the very beginning, pretty well the only treatment that I had experience with was debulking or resections. Removing the tumor was there, But over the years, there has been many, many options added, new treatments added, obviously, over and above the surgery. And we're very hopeful for new procedures coming down the pipeline.
I've seen treatments that were only available in Europe come to the United States, be on trial, and then be approved. I've seen the injections that had to be done on a daily basis become long acting. And I've heard of many new treatments in all of these years. And that's just wonderful, watching all of this. So many more opportunities for the people who are being diagnosed right now.
Well, you understand that having been diagnosed with pancreatic cancer at that time, I got dropped into, no kidding, real chemo. There weren't any analogs. There wasn't anything else we talked about. I've been through chemotherapy. I've been through surgeries. I've been through clinical trials. I've been on drugs that worked like Afinitor. That was my phase 3 clinical trial when I found it, or when I was directed over there. So there have been all kinds of changes, just education on the disease that have come by all these years. And luckily, I've gotten to be a part of it because I was the golden child. I mean, I was the one that had survived all these years. So they looked at me, I think, as somebody who was treatable, survivable. Every time we moved or went to a new location, I went to the hospital that was known for neuroendocrine cancers.
That I can live long enough to see the improvements in the care that people with neuroendocrine tumors get. It's just, I mean, when I first had it in 2006, doctors were coming up to me saying, do you know what you have? Do you know how rare this is? We've never seen one of these. And now it's still very rare, but you can tell they're getting used to the routine. They know more about it and know how to treat it. So I hope it just continues.
Well, once again, I would say to always remain positive, do as much reading and research as you can, and don't be afraid to ask questions. I would suggest to anyone and everyone, if you can find an advocate to be in your court, I think that's most helpful.
Well, all of the new treatments, number one, to know if I should need another treatment in the future. So much is happening. I've also seen so many new doctors become specialists, so much more information, doctors, the availability is wonderful now.
Continuing research, whatever research hospitals, organizations, clinics are going through, nobody has stopped that. It's only gotten better month after month, day after day, and that kind of stuff in the treatments because of looking forward, learning from the old nets, and placing yourself forward for the new drugs and treatments. That's what I see still in my future.
In late 2003, my wife Caroline was diagnosed with pancreatic neuroendocrine tumor. And I could see a number of organizations that were trying to help patients, but I couldn't find an organization that was actually funding the research other than the government, which, as a rare disease, wasn't funding much. As I was going through this process, I got introduced to what was called Caring for Carcinoid Foundation at the time, now NETRF. And I thought, this is perfect for me. I wanted to be generous financially, but of course I wanted the money to go to the absolute best science available. And When I look back over the 20 years of being a board member and when I see what this foundation has been able to do, like, yes, we have so much further to go, but we are so much further than we were 20 years ago in terms of our understanding of the disease, our understanding of the pathways that make this happen. We funded a number of research projects that have now turned into not only trials, but treatments that are available, things that my wife never had access to. And I'm personally very proud of that. I'm proud of everyone that has been associated with NETRF because the work has turned into something of value for patients. And as a businessman, I like to invest in things that I see working. Of course, I'm impatient too. Like, I want it all to work faster, but I feel fortunate to be a small part of the opportunity to solve this problem, and we can see our understanding growing. And there's not going to be a cure unless you have that understanding, and now we can see a cure coming down the road.
I have the pleasure of working with a very distinguished and talented scientist at the University of Pennsylvania, Dr. Shanshin Hua. who has received funding from NETRF for the past decade in an effort to advance his interest in identifying a target for CAR T therapy in neuroendocrine tumors. I work with him as his clinical research collaborator and have been very fortunate to initiate a clinical trial in patients with neuroendocrine tumors that is evaluating a CAR T therapy directed at CDH17. This is the first CAR T trial in neuroendocrine tumors, and we're incredibly excited to have that opportunity to offer this option to our patients in the hopes of identifying potentially a new treatment option. I think I speak for myself and Dr. Wah when I say that without the funding from NETRF, this work absolutely would not have been possible, and we would not have been able to get to the point where we are today.
Managing the symptoms of neuroendocrine cancer is key to living well. Our next speaker, Dr. Heloisa Suarez, will discuss managing symptoms and enhancing daily life. Dr. Suarez is a medical oncologist with a focus in GI and neuroendocrine cancers. She is an associate professor at the Huntsman Cancer Institute at University of Utah, where she leads the University of Utah NET Destination Care Program.
Hello, everyone. My name is Heloisa Soares. I'm a medical oncologist here at the University of Utah at the Huntsman Cancer Institute. And I'm here to talk to you about managing symptoms and enhancing daily life in patients living with neuroendocrine tumors. Thank you for having me. So first of all, as my disclosures, I do some consulting for these companies that are listed here, but they are within the rules of conflict of interest with my university. So what are we going to cover today? We are going to cover common symptoms that patients living with neuroendocrine tumors experience, some nutritional strategies, how to manage GI symptoms, issues related to pain management, why patients might have pain, and some daily wellness tips. So let's start with symptoms. So there's a lot of symptoms that patients with neuroendocrine tumors can have. The most common ones that we see are diarrhea, stomach pain or cramps, flushing, that's the face turning red, feeling super tired, changes in the weight or the appetite, that you're losing weight and you don't have appetite. There's also occasionally some patients might gain weight related to some of the hormonal secretion that some of the tumors might have, and pain. And you can see here, I just put a table that was published with some of the symptoms that patients experience, and that was done, collected this information through the Income Alliance. And you can see there's a lot of symptoms, and many of them we already talked about it, and you might have experienced or are experiencing. So you're not alone if you're having these symptoms. There is also a lot of misunderstanding on the symptoms that patients with neuroendocrine tumors might experience. How many times patients were to their doctors and healthcare professions teams and say, you know, I'm having some weird diarrhea, and then the healthcare professional probably said, oh, you have IBS or IBD, or, oh, I'm having flushing. And they say, oh, you are a woman in your 50s, this is perimenopausal. Or palpitations, you know, you're experiencing palpitations, and they say, well, this is just anxiety, right? And this could be also, a lot of this could be related to your neuroendocrine tumor. And there's a lot of misunderstanding because it's a rare disease. Not everybody takes care of this disease until the diagnosis is done. And then you finally have some answers for the symptoms that you have been experienced for years. So it's not uncommon that patients feel frustrated that they don't have answers for their symptoms. Why do the symptoms happen? There are different reasons why, and that's super important to understand why a symptom is happening, because then you can treat properly, right? And hopefully decrease the amount of the symptoms. For example, tumors can cause hormones, and if the tumors are secreting hormones, then you will have symptoms related to that, and we will talk a little bit about in a minute. There's also issues related to the treatments or surgeries that can affect your digestion. Tumors can press in organs and cause pain. There are medications that can cause side effects. So let's start with the mechanical issues that can happen because a lot of tumors might be present. So, for example, in the bigger picture that you have with the liver, you can see some of the white spots that are actually metastases or tumors in the liver that are pressing next to the edge of the liver, and that can cause pain. Which is capsule pain. So that we can treat with medications, but sometimes with liver embolizations, because that could decrease the size of the tumor that's pressing the capsule of the liver and therefore improve pain. There is also, you can see some pictures of a bowel. There's a picture that shows that a tumor is growing in the bowel and is causing obstruction. So patients who have a lot of symptoms related to feeling if they eat something different that might irritate more, they'll have nausea, occasionally watery diarrhea, and can even vomit with cramping, and that can go on and off, having episodes like that through the course of years before finally the diagnosis of a tumor that's causing partial bowel obstructions is made. There is also, if someone has a mesenteric mass or that is in the middle of the belly, and you can see here with the arrows in yellow, that can cause a lot of issues as well. It can trigger some partial bowel obstructions as the symptoms that I already mentioned, but can also cause some ischemia of the bowel. And then every time that you eat, you will have really a lot of abdominal pain with eating and some diarrhea as well. So these are some of the symptoms that the tumors per se can cause. Then we have the issues related to symptoms associated with hormonal production. Not every single neuroendocrine tumor is going to produce hormones, but there's a subgroup of them that will. And if they produce serotonin, patients who have carcinoid syndrome can be flushing, abdominal cramping, and diarrhea. If associated with that, they also develop carcinoid heart disease, then they'll have low extremity edema. But there's many different hormones that neuroendocrine tumors can produce, and they're not going to produce all of them at once. They typically just produce one or another, and occasion, particularly with pancreatic neuroendocrine tumors, sometimes they switch the type of hormone that they will produce. So if a pancreatic neuroendocrine tumor or a duodenal neuroendocrine tumor is producing gastrin, then patients will have a lot of heartburn, ulcers in the stomach and the duodenal, and diarrhea. If the pancreatic neuroendocrine tumors are producing insulin, then the patients will have significant episodes with low blood sugars that they will really feel extremely bad and sick. If the tumors are producing ACTH, then the patients will gain weight, will have issues with a lot of electrolyte imbalances with, for example, the levels of potassium being very high, sugars will be affected, they'll have a very swollen type of face as well. So different tumors can produce different hormones, and that's why it's so important to really discuss with your healthcare team all the symptoms that you're experiencing, because then your healthcare providers or clinicians will do the appropriate workup to try to identify which hormone could be associated with your symptoms. But there's also side effects of the treatment, particularly with medications. So diarrhea, there are many of the medications that can cause diarrhea for different reasons. The hormonal shots, the somatostatin known as somatostatin or lanreotide, they can cause pancreatic enzyme deficiency, which will translate in mushy stools and bloatness. Decreasing the appetite. Many of these treatments will make you lose your appetite or feel like the food doesn't have any taste. Chemotherapy, when patients are taking chemotherapy, is a very known side effect from it. Fatigue can be from medications, but can also be from the disease rash. Some of these treatments can cause rash. Infections, if you're receiving a treatment that can decrease your blood counts, then you are potentially more susceptible to infections. hand and foot syndrome for some of the pills, such as cabozantinib, or chemotherapy pills, such as capecitabine, can cause the redness and the feeling of the blistering in the hands. We talked already about the low blood counts and nausea and vomiting, but most of this tends to be manageable as long as you really keep an open line of communication with your clinician and let them know that you're experiencing X, Y, and Z side effects. There are tricks that your physician can use to navigate the side effects and hopefully make less difficult to tolerate and hopefully very manageable. So it's important to really report all your side effects or any new symptoms that you are experiencing to your team, and then they will do the troubleshooting with you. Headaches is another one, especially we see a lot of this with some of the somatostatin analogs. So managing the diarrhea. Since diarrhea is such a big topic and symptom for patients with neuroendocrine tumors, there are two things that your healthcare team should think about it. One is treating the symptom in general, which is starting typically with taking anti-diarrhea medications such as loperamide, which is Imodium. There's other medications that can also be used. And obviously stay hydrated and replace electrolytes. But then that you also have to treat the cause. So if your diarrhea is because your tumors are producing serotonin, therefore you have to treat that. And then one of the ways to treat that is using the hormonal shots or the somatostatin analogs. Every time that you try to control the disease, hopefully they will help also to control the functional symptom in this case. But there are times that because you resect a part of your small bowel, you might develop diarrhea from that, or you remove your gallbladder, then there might be diarrhea from that. And there are medications such as the bile-acid binders that can help with treating that. So there's just the plain treating the symptom with anti-diarrhea medication, but there's also then try to understand what is the cause behind that symptom and treating that cause. You have to feel comfortable talking about your poop. And I sometimes ask a lot of questions about poop to my patients, and they look at me like I don't like this conversation. But it's super important because depending on what you tell me about your poop, I'm going to treat you differently. Are you having watery diarrhea or is more mushy? And why is that? Because if you're having a lot of watery diarrhea, particularly in the middle of the night or the mornings, I say, okay, this is probably more like related to hormonal production, and then I need to try to decrease the levels of serotonin or 5-HT that your tumor is producing. But if you tell me that no, actually my diarrhea is actually more of this mushy stool, oily, yellow, I see it floating, I'll say, I think this is actually because of pancreatic enzyme deficiency, either because you had surgery from your pancreas, so your pancreas is not producing enough pancreatic enzymes to digest the food, or because you're receiving a somatostatin analog, which we know that could be one side effect. And the treatment would be different. If I think this is related to pancreatic enzyme deficiency, we're going to give you enzymes to replace it, which the one that we commercially use and is known is called Creon. And depending of the conversation about the poop, there are different strategies that we'll do. And I know that this is a busy slide, but just to give you an idea of what your healthcare team is thinking about when they're talking to you about diarrhea. And please be patient with them and answer their questions. And if you don't feel comfortable talking about poop in front of your family and friends because they might be in the room, it's perfectly okay to ask them to leave. And I don't think anyone will be hurt about that. Bloating, gas, and nausea is all super common. So some of the tricks is eat slowly and chew well, avoid soda and frizzy drinks, try to do some walks after the meals. If there's a lot of nausea involved, talk to your team to get some anti-nausea medications. Eating well can be hard because of different issues, but we should try. And we always tell patients, eat small and frequent meals, really try to chew the food well to be able to, for your body to digest. Use a little bit of water when you sip water to, again, be easier on your body. Avoid greasy, spicy, or any trigger foods that you have. And listen to your body. There are some well-known foods that might trigger side effects or reactions. In terms of carcinoid syndrome, we know that alcohol and cheese, particularly aged cheese, can trigger a lot of the flushing. So pay attention to your body. And if you identified a food that is triggering symptoms, try to not eat them. And then talk and consult with a dietitian. Many of the cancer places that we we have in institutes and cancer centers, they typically will have a dietitian that you can consult with. Fatigue is a super hard symptom that everybody experiences to different levels. And it can be from the treatments, from the cancers, from stress. And it's hard, right? Because people say it's an invisible symptom and it's hard for others to understand that you are tired. But it's important to try to navigate that. And what are the ways that I try to help my patients with that? I know they might be counterintuitive, but you actually have to exercise. You have to take small walks every day, and they don't have to be 2-hour long walks. You can do 5 to 10 minutes. You should try to stretch or do yoga chair or Pilates, whatever type of exercise that you can do. You can try to keep some of the activities in the house, like house chores. You can try to do some of that. And then I always ask my patients, are you doing the yard? Are you doing the dishes? Try to continue to do some of that, because that you're physically moving. You have to move even if you are tired, and just do a little bit every day. And when you exercise, you feel better and you're going to feel less tired because of some of the hormones that we produce when we are active. I know that's super hard to start. Typically, I say we have to start slowly and just be consistent. You probably can try to see a strategy that makes sense for you, either by finding a buddy that you're going to exercise every day, or putting an alarm on your watch to go do things. But if you do not create the routine, you're not going to do it. So please see how your life is and decide what's the best strategy for you. For me, I know that I have to do my exercises early in the morning, because later my day goes by, and then when I get home, I am too tired to do anything at 9 or 10 o'clock. Plus, if I exercise at 10 o'clock at night, I cannot sleep, and sleeping is super important. So figure out with your lifestyle what makes sense for you. But create a routine. And again, you have to be consistent. And in the beginning, you just do small portions, but you have to do it. Even if a day you're just going to do it for like 2 minutes, that's better than nothing. So consistency, and trying to get yourself moving. Don't forget your sleep and your spirit. Sleep is super important, and keeping your mind healthy is also super important. And don't forget about your caregivers. Please be thankful that they are there for you, and allow them to also take care of themselves. And perhaps they can be your buddies to get you a healthy routine. So I just want to end with my take-home points, which are: do not assume that your symptoms are caused by a particular reason. Sometimes there are many reasons, so you just have to talk to your clinicians. Discuss in detail with your healthcare team. Take the time to talk about your symptoms. Write notes, make points, and ask questions. Be patient. Sometimes we are not going to solve the issue right away. There might be a lot of conversations and adjustments, particularly if the reasons for your symptoms are multifactorial. They can be several things that are causing one symptom, such as the fatigue. Encourage the addition of a supportive care expert in your healthcare team, like palliative care or supportive oncologists. They can be with you in any timing of your journey with neuroendocrine tumors. We can live well with this disease. It's just we have to be patient, we have to respect our bodies, and we have to have open communication with the healthcare teams. But it's possible to have a good life even when we are living with neuroendocrine tumors for most of the time. And don't forget you're not alone, and seek support, and find a group of people around you that understand you and support you. We know that keeping a good, positive community around us is super impactful and can make a difference on our mindness as well. So keep good people and supportive people around you. And I think that's what I have. Thank you so much for having me, and I hope you can take some tips from this talk and start living well with NETs.
Thank you, Dr. Suarez. Dr. Chandrika Chandrasekharan is our next speaker. She's a clinical associate professor at MD Anderson Cancer Center, where she's focused on neuroendocrine tumors and pancreatic cancer. She is a dual board-certified physician in medical oncology and palliative care. She's going to talk today about genetics, risk of other cancers, and survivorship beyond diagnosis.
Hi, everybody. My name is Chandrika Chandrasekharan. I am a clinical associate professor at MD Anderson Cancer Center in Houston. I've been asked to present on this topic of genetics, risk factors, and survivorship in neuroendocrine neoplasm. It's beyond diagnosis. It's multiple topics to cover. I'm going to try to touch upon briefly some of these as we go along. So when we talk about neuroendocrine neoplasms, I wanted to make sure we're not just covering like the gastroenteropancreatic neuroendocrine tumors, which is the more common pancreatic or the stomach or small bowel origin neuroendocrine tumors. As you can see in this slide, there's a whole bunch of cancers that can arise in different organs in the body that all come under that neuroendocrine cell origin. So for example, medullary thyroid carcinomas, which is a specific type of cancer, the thyroid gland is also a neuroendocrine neoplasm. Pheochromocytomas, which are gland arising in the adrenal medulla, that is a special gland in your body, or paragangliomas, those are also neuroendocrine neoplasms. And then in this purple color box, you see a whole bunch of other organ sites and other types of neuroendocrine neoplasms. So when you talk about neuroendocrine neoplasms, especially the risk factors and genetics, as you can see, there's a whole bunch of things here, and it may be hard to find a commonality or like unifying factors. So the discussion may go back and forth in some specific types of neuroendocrine tumors. So when we look at the incidence, this is an often displayed slide pretty much in every talk by Dr. Desari at MD Anderson that looked at SEER incidence, which is like this large registry of different type of cancers registered over the decades. So the incidence of neuroendocrine tumors published in 2017 when compared to 1973 versus 2012, at which time this analysis was completed, showed almost like a 7-fold increase in number of patients diagnosed with neuroendocrine tumors. Now, if we look at the actual types of neuroendocrine tumors in this next slide, the steep increase is primarily for not all locations. It was mostly lung in that reddish curve, and then the high incidence in rectal neuroendocrine tumors, as you can see in the black curve. So that's two neuroendocrine tumor types that significantly has increased incidence in this time period. And then again, fortunately, when we look at the type of neuroendocrine stages, majority of this early detection has been in the localized neuroendocrine tumors, those that are still confined to the organ. If you look at the distant or spread neuroendocrine tumors, it's not as steep of a curve, it's more relatively flat. So we've been diagnosing more, but more lung and rectal and also appendix, and also mostly localized neuroendocrine tumors. When we look at more recent data published just recently as June 2025, which also looked at the same SEER database, which is United States, from 1975 to a more updated time of 2021. The age and adjusted incidence rate is still going up, almost increased 5.2-fold. And if you look on the left, the blue curve is multiple other cancers. And then the yellow curve that you can see here is actually the neuroendocrine tumors, which you can see has got a steep increase in the incidence. Now, this increase is across all size, stages, and grades. But the largest increase is actually in the appendix neuroendocrine tumor, which is this faint green curve that has gone almost astronomically high. Again, this is raising a lot of questions about this increased incidence. Is it actually a true increase, or is it a case of overdiagnosis of early stage disease? And I'm bringing this up because when you're talking about survivorship, there's a lot of focus you see on other cancers like breast cancer survivorship, colon cancer survivorship, because there are also more patients diagnosed with that cancer numerically still. But neuroendocrine tumor is not very far behind. The number of patients living with this cancer will increase likely. And then the whole concept of survivorship after you're diagnosed, living with this cancer, that's an important topic that we have to focus on. So when we look at this increasing incidence of neuroendocrine tumor, the question that comes up is it a true increase, or is it an increase because of actually more techniques of diagnosis, better registries, or some of these factors that are discussed here? Because what we have seen is this increase in incidences more to the specific types of neuroendocrine tumors as well as early stage. The increase in the metastatic stages, basically the advanced stage, is relatively stable. The incidence has been stable. So this diagram here kind of talks about potential factors that has maybe led to this increase in incidence. One of the factors potentially for the increase in incidence could be improved diagnostics, whether this be more endoscopies and colonoscopies or other imaging studies like CT scans and MRIs that we are doing for more reasons. Another potential reason, as you can see, is the advances in data reporting. Across the world, we're doing a better job of classifying these tumors, naming them, and maintaining tumor registries. That has led to a better capture of data. And there are also some comorbid conditions or risk factor associations that we will discuss later. For example, there's definitely been an increased incidence of gastric neuroendocrine tumors associated with increasing use of proton pump inhibitors like pantoprazole, omeprazole type of drugs. Whether there's a true increase in other risk factors and neuroendocrine tumors is unclear or less clear. The genetic factors, we have probably gotten better at diagnosing and also capturing this better over time, but their relative incidence is probably the same as it has been, less likely to have led to this increase in incidence we are seeing. The next slide will talk about some of the other non-genetic risk factors. Like I said, majority of the neuroendocrine tumors are still felt to be sporadic. They are not inherited. So then that brings the question, if there's an increase, maybe because of lifestyle factors. But if you look at what's being studied, this is actually one area of unmet little research done in neuroendocrine tumors, because these lifestyle factors are not very well defined in the context of neuroendocrine tumors. So there's a review article that I've listed here brings together the diabetes, smoking, alcohol, family history of cancer, and the OR mean the odds ratio. So having diabetes, the increased odds of having a neuroendocrine tumor is 2.74, especially if it's recent onset diabetes. Now, whether this is an association, because if you have a pancreatic neuroendocrine tumor, which affects the function of the pancreas and the insulin secretion, that can lead to diabetes being diagnosed around the time of the cancer, not just neuroendocrine, also adenocarcinoma, the other kind of pancreas cancer. So whether this is causative, meaning it causes, or is it associative, it is just an association, probably more at this time, the association. So these are the factors that are unclear. Now, there's family history of cancer is definitely important, not just of neuroendocrine tumor. There are studies that have shown that other cancers like pancreatic adenocarcinoma in the family can increase the odds of a patient or person being diagnosed with neuroendocrine tumors, or hepatobiliary. These are a couple of the ones. There's also some associations reported with renal cell carcinomas. Now, is it because there's actually a genetic factor that we haven't identified, or is it because families that live together in a shared environmental exposure get exposed to the same risks, again, leading to this cancer? That's also unclear at this time. Now, smoking and alcohol, there are equal number of studies, even though the studies are very limited, of both associating a higher number with neuroendocrine and absolutely not associating with neuroendocrine tumor. So I think we cannot really conclude much with the studies we have. Obesity, again, or increased body mass index has been studied in only one or two papers that I could find. And again, there's not a very clear association. So really, from a lifestyle perspective so far, whether this causes neuroendocrine tumor or associated with neuroendocrine tumor, those are unclear factors, but something I'm hoping that we will be able to find out more with more studies in the future. Now, patients come in and they say, I've had testing done, genetic testing done, but then if we go and ask questions, a little bit confusing whether they had inherited or germline testing or tumor testing done. There are multiple platforms out there, so I think it's important to try to know what exactly was done. Was it the tumor that was tested? Was the tumor and the genetic or inherited mutation that was tested? Now, there are platforms that can do both in the same test, basically get the tumor and your blood sample and do both. So again, as more and more platforms are available, I think it's important for the patient also to be aware of what was done. So when you're talking about a germline mutation, this is essentially present in every cell of the body, and this was something that was passed down through generations, parent to offspring. It can increase the susceptibility of the cancer, and it can also usually, based on the gene that's affected, cluster to a specific type of cancer groups. And usually it's tested in a blood or saliva sample. When you talk about a somatic mutation, this is essentially referring to the mutation that's found in the tumor cell. So something went wrong as the cells were dividing in the cell, and that led to proliferation and a cancer. So this is not present in every part of your body or every cell of your body. This is typically also not passed down through generation. And this is often tested in the cancer tissue, but there are also testings available now to do it in the circulating tumor DNA or blood test as well. So this is important difference when you're talking about mutations. So I'm going to focus on the germline or genetic mutations and go by specific ones as well as the specific tumors. When you look at pancreatic neuroendocrine tumors, approximately 10 to 15% of pancreatic neuroendocrine tumors are associated with a genetic syndrome. I've listed the four most common ones or more well-defined syndromes. Everybody's probably familiar with the multiple endocrine neoplasia, the MEN syndrome as it's referred to, which is based on this mutation in this gene, menin, which can often lead to gastroenteropancreatic neuroendocrine tumors, parathyroid adenomas, and pituitary problems. Majority of them are non-functional, but a lot of times they're associated with what we call the Zollinger-Ellison syndrome, which is the hypersecretion of the gastrin hormone in pancreatic neuroendocrine tumors. The other common associated pancreatic neuroendocrine tumor is 1-hippolindo, and this is actually, again, not as common, but you also see a cluster of findings, usually pheochromocytoma, pancreatic neuroendocrine tumors, kidney cancers, and retinal hemangioblastomas. These are basically some dilated blood vessels that can be picked up, one of the first presentations of this syndrome. Neurofibromatosis 1 is another such complex associated with neuroendocrine tumors, as well as tuberous sclerosis complex. These are the ones associated with pancreatic neuroendocrine tumors. When you look at small intestine neuroendocrine tumors, actually the vast majority are sporadic. However, there have been studies going back to 1950s in the Nordic population, which is one of the large databases in the country, that show that a 9 to 11-fold relative risk in first-degree relatives representing a shared genetics and environment. Again, it could be genetic inherited risk through families as well as the shared environment, but yes, there is definitely association with high risk in the family. Now, if at all you see a genetic association, it's often MEN1 associated, the first syndrome that we talked about in the pancreatic as well. Lung neuroendocrine tumors, again, the vast majority are sporadic. In MEN1 syndrome, 2 to 8% may have lung neuroendocrine tumors. The majority of them are, again, the well-differentiated typical carcinoid, the less aggressive kind with good prognosis and a very indolent course. In fact, there's data just like the pancreatic neuroendocrine tumors that some lung neuroendocrine tumors associated with the MEN1 may be also observed for long term safely. Now, thymic neuroendocrine tumor, a lot of people ask, what is a thymus? So thymus is this gland that you see kind of tucked in behind your breastbone or behind the lung. Normally, your thymus tissue, which is involved in your immune system, involutes or kind of regresses as you age or grow, but sometimes they may persist, the thymic tissue persists, and neuroendocrine tumors can develop. This is definitely a rare subset within the neuroendocrine, but nearly 25% of the thymic neuroendocrine tumors are associated with MEN1 type. And they can be functional, a little bit more aggressive course, more likely to metastasize as well. And because of the location, surgical resection sometimes becomes difficult or challenging in this group of patients. Looking at medullary thyroid cancers, I don't treat medullary thyroid cancers, but just important to know because I do see patients with MEN syndrome that also have medullary thyroid cancers. Typically, we're talking about type 2A, type 2B, and 25% of medullary thyroid cancers have a hereditary cause. And the gene that's implicated is RET gene. So if you have a MEN2A inherited mutation, there's a 90% chance of getting a medullary thyroid cancer. On MEN2B, it's almost 100% at a young age. Next, we'll move on to pheochromocytomas and paragangliomas. These are neuroendocrine tumors that arise in the adrenal medulla. So adrenal glands are little tiny pea-sized glands on top of the kidney. The medulla is referring to the center of it. This is kind of an extended part of your nervous system, sympathetic and parasympathetic system. So they kind of secrete some hormones. We refer to it as the flight-fight hormones. So when the tumors arise in the adrenal gland itself, in the medulla, these are pheochromocytomas. When they're arising in these ganglion, which is basically like structures containing some nerve cell bodies scattered throughout your body, then they are the paragangliomas. These are at least 40% of them are associated with some kind of a hereditary syndrome. And the big ones are VHL, MEN2, like we talked about, neurofibromatosis, and also this cluster of syndrome we call hereditary paraganglioma pheochromocytoma syndromes, implicated genes like SDHA, BC, and then there's a whole bunch of other rare mutations that I have not mentioned here that are now discovered and can be tested. So any patient with pheochromocytoma or paraganglioma or medullary thyroid cancer needs genetic or germline testing to be performed. So a little detail about the MEN type 1, type 2A, and then the VHL, because these are a little bit more common. And then I'll move on to the survivorship topic. So MEN type 1 is characterized by what we call the easy to remember tumors of 3 Ps: parathyroid glands, pituitary adenomas, and pancreatic islet tumor cells. The prevalence is approximately 2 per 100,000. Now, though the 3 Ps are defining tumors, as you can see in this picture here, there are multiple other benign spectrum tumors that are also associated with MEN type 1. The lipomas, which is basically fatty tissue. Again, the vast majority I want to emphasize are not inherited, just that these can be found in MEN type 1 as well. So just having a lipoma and a neuroendocrine tumor does not automatically mean you have an MEN type 1. There's a cluster of things that come together when you have a gene mutation to need the testing. So then the MEN type 2A and 2B again has a few variants to it. The mutated gene here is RET or RET. Again, within the type 2A, there's a classical type 2A, which is basically the thyroid cancers, medullary thyroid specifically, pheochromocytomas, 40 to 50%, and primary hyperparathyroidism, which is again the parathyroid gland causing hypercalcemia and other problems. There are some skin manifestations in the men 2A with the cutaneous, lichen amyloidosis. These are some skin changes that you can see with darkening pigmentation. Hirschsprung disease with some colon disorders, and there's also the ones that have without the pheo and the parathyroidism, just the medullary thyroid cancers. And then there's type 2B, which is defined by medullary thyroid cancers and the pheochromocytoma, and also some non-cancerous other type of tumors like these that are rare. So again, these are rare syndromes still, but definitely there's a classic family history that prompts you to test patients. The other common one that's important to know also, because this is one of the genetic syndrome now actually has a drug, 1-hippolindo. This is a VHL gene. The prevalence is about 1 in 36,000. It's a little bit more common. About 10 to 20% of patients with VHL will develop a pheochromocytoma. Median age is about 30. Pancreatic neuroendocrine tumors, about 9 to 17% of them will develop, and majority of these are non-functional, low-grade, well-differentiated, can be unifocal, meaning like a single tumor, or multifocal, and oftentimes have good prognosis. Like I said, there's other things that are associated with the VHL mutation. The drug that has been approved, belzutifan, this is a drug that is an oral pill, which is a small molecular inhibitor of this HIF2 alpha, like a particular pathway that is apparent in this VHL gene mutation. It's approved for all tumors related to this VHL gene, including neuroendocrine tumors. And the results are very impressive, even sometimes complete response in some of these neuroendocrine tumors if the gene is present and is the driving force of that mutation. So I want to move on to survivorship, and kind of that's the last part of the topic. So when you're talking about the increased incidence or the increased prevalence with or without the genetic factors, there's whole question of survivorship comes up. Now, every patient, every person, every healthcare professional defines survivorship or a cancer survivor very differently. But I think this is the definition used by the Cancer Survivorship Institute of Medicine, NCI. It's very comprehensive. An individual is considered a cancer survivor from the time of diagnosis through the balance of life. There are many types of survivors, those that live with the cancer, those that are free of the cancer. So this is to capture a population of those with a history, basically anybody who's been touched by cancer personally at any point, not the patient. And it's not really meant to provide a label that may or may not resonate with individuals. This is a definition so we can capture these patients, provide them the resources, include them in research, and do a good job of serving them. So this is by no means the definition of what you consider as a cancer survivor. And I respect everybody's definition of how they identify themselves in this journey. But this is just to capture, like I said, data, and also to make sure we have resources available for this group of population. So when you look at the survivorship aspects, there's multiple aspects of cancer survivorship. It is a state of being that includes the perspectives, the needs, and the health, and the physical, psychological, social, and economic challenges. I think a lot of times healthcare physicians, providers kind of end up with the physical challenges and maybe sometimes with the psychosocial challenges, but we definitely do a very poor job of addressing the social challenges or the economic challenges that cancer diagnosis brings to the patient. When you look at the care spectrum, comprising all of those needs that we talked about or discussed in the previous slide, you have to go beyond just treating the patient in that moment. We have to look at monitoring and recurring for new cancers or other primary cancers. You just don't have to talk about treating the cancer. You have to talk about how can we promote healthy behavior. We have to coordinate care between multiple disciplines. We have to manage the non-cancer problems like diabetes or hypertension effectively so we can do a good job of treating the cancer itself. We have to discuss the goals of care, the individual preferences of the patient or the caregiver and the family as a unit. And we have to remember it's not a single person's job, so offering support services. And as we talked about already, genetic risk assessment. So we are also addressing the next generation and hoping to be more vigilant. And then the social and the financial impact. Now, these are, again, like I said, aspects that are not very well addressed in multiple situations and in multiple aspects of the care. I want to really talk about what's unique in neuroendocrine tumors with that framework. This is my impression of what are unique challenges in neuroendocrine tumors. I think a lot of patients will agree that, it's the delay in diagnosis, even though the survivorship here is defined as when you're diagnosed with a cancer. In a neuroendocrine tumor situation, a lot of patients have symptoms for years. So maybe the survivorship has started actually from that time, not after you've had an official label of cancer diagnosis. What is also unique in neuroendocrine tumors is this indolent nature that also means there's longer survival, which is great, but then there's a cumulative burden of cancer that the patients deal with that is very different from some other types of cancers. When you look at then the unique burden of a functional neuroendocrine tumor, like the diarrhea and the flushing that comes with it, this is an additional burden that we have to help the patients with just by having a tumor, nothing to do with the treatment we give, but we have to remember this is different about neuroendocrine tumors. Then we look at also toxicities of therapies, but because it's an indolent cancer, we have to look at both long-term and short-term toxicities. And then there are a lot of uncertainties in prognosis. I think this is one of the hardest questions for me to answer in clinic. What is the prognosis with my tumor? There's also uncertainties in the therapeutic algorithms. In many other cancers, we have a little bit more guidance on first-line therapy, second-line therapy, and third-line therapy, like the order in which we go. But neuroendocrine tumors, there's no good algorithm, so it's confusing for the patients as to what to do next. And again, I think even physicians, for these reasons, sometimes don't get involved in neuroendocrine tumor research or practice for similar reasons. And then, just like any other cancer, but more so in neuroendocrine tumors, there's multiple disciplines involved. And then there's also multiple health systems. There's a primary oncologist maybe involved with your regular care. There's a neuroendocrine specialist that's involved. There's maybe a surgeon in another institution that's involved. There's could be an interventional radiologist involved, or tissue may be sent out for pathology to a different system. So multiple health systems as well as multiple disciplines. With the indolent nature, long survivals, it's also clearly known that there's a secondary cancer risk in patients with neuroendocrine tumor. So we have to be aware of the screening and other things that we need to continue in patients with neuroendocrine tumors. Again, the financial impact, when you're talking about long-term longitudinal burden this cancer carries, whether it's a functional or non-functional, number of visits, number of CT scans, the distance traveled to a neuroendocrine tumor center, the flight tickets, or the miles spent on the road for the patient, caregiver, the family member, there's a huge financial impact that's not captured with this type of an indolent cancer. And then when you talk about even patients who've had a curative intent surgery, you're not talking about 3 years surveillance or 5 years surveillance. You're talking about at least 10 years per guidelines. And that's longer than most other cancers, and then technically even beyond. So this surveillance, even in those that are quote cured, goes beyond the usual cancer. So these are unique challenges to neuroendocrine tumor. There are multiple studies that looked at unmet needs in neuroendocrine tumors. This is one of a global survey. Now, what's interesting in this particular slide is on the black color here is the patient's reply, and the gray is the patient advocates, and then the other bar is here the healthcare team members. Clearly, as healthcare team members, we don't perceive the unmet need very well. We are, it almost seems like tone deaf to the unmet need of the patient or the patient advocates here. So there's a high amount of unmet need in the information spectrum in psychological care, the research, availability of clinical trials, management, pretty much in every aspect that was quizzed, there was a very high unmet information need. When you look at the care needs, this is actually where is the gap in receiving care. Again, healthcare advocates / the patient advocates, maybe the patients don't like to speak up more. Again, a good reason to have a caregiver with you in these appointments. They perceived a high unmet care need in multiple spheres here. So this is being replicated in multiple studies in multiple countries. It's a study out of Australia that looked at 69% not understanding even when information was given what was given. Most accessed online, but 2/3 do not find it useful. And even after 6 months, even though the anxiety of a diagnosis seemed to have decreased a little bit, majority of the other psychosocial outcomes, care experiences were similar to what was at baseline. And there was definitely worsening financial problems like we discussed compared to the baseline. Another big study out of Canada, similar results. Even after 5-year follow-up, like you can see longitudinally of multiple symptoms, anxiety, which seemed to have slight improvement after settling down with a treatment plan maybe, but then there's persistent tiredness, fatigue, and then a sense of low well-being and depression, even after 5 years of living with a neuroendocrine tumor. So this is a very nice first guideline that was presented in 2005. Certainly we've come a long ways, but there's a lot left to do. To conclude, 2 things. What can we do, we as in the healthcare team members? I think we should make sure we provide a treatment summary and a care plan to every patient, every survivor, and then take time to know the person, not just the patient, not just the neuroendocrine tumor. I think we have to develop these relationships in any cancer, but it's more so important in neuroendocrine tumors where you're going to know patients for years. Let patients not be the messengers between the teams. I think this is often a practical thing that happens where, well, we'll send the notes, great. If the notes are reaching your primary oncologist or another team member, great. But if not, if necessary, pick up the phone, communicate with other team members when something important is being done, like a treatment change or treatment recommendation is made. But let patients not be the ones carrying this message between the teams. Address the psychosocial needs. Again, you cannot address it all as a single oncologist or a surgeon. Involve other team members appropriately, offer these services to the patient. Comprehensive care. So it's not just medications, mind, body, and soul healing. Prevention, surveillance, and detection of new and recurrent cancers. Try to tell patients just because you have neuroendocrine tumors, don't forget your other health issues. Don't forget your colon cancer screening, your mammograms, whatever they need, depending on where they are in their neuroendocrine tumor journey. And then also, like I said, we have to make sure we're addressing the well-being of the patient and including their non-cancer medical conditions. But it's perfectly appropriate to tell the patient, this is something that I'm not comfortable because I'm not the expert. You should discuss with the primary care, but it's important to your neuroendocrine care as well. So the patients can take this back to their primary care as well. Assessment of their lifestyle behaviors. Again, one clinic visit is not possible to cover all these topics, but along the multiple visits we have over the years, hopefully we can address some of these topics with the patients depending on the priority that the patients present with. Advanced care planning, sensitive topic discussions. Now, sensitive topic discussions could involve end-of-life topic discussions, financial matters, how the neuroendocrine tumor affects your social functioning or sexual functioning. These are topics that we often don't bring up, but it's, I think, okay and important for the patients to hear from us that it's okay to talk about it as well. Involve the caregivers, and get to know the caregivers, and always emphasize shared decision making. Now, also, I wanted to think about a few things that the patients can do in their survivorship. Ask for a clear plan. Make a follow-up appointment if it's not clear so you can clarify the plan. As you know, visits can be rushed sometimes, and if it's not clear, it's okay to make that follow-up appointment if needed, if it's not urgent. Verbalize your needs and priorities. Sometimes if we don't bring it up, you can also bring it up. What is important to you in that moment, in that decision, in that clinic visit, you have to bring it up. Also, use the time wisely. Prepare for your visit. I think it's important because you also want to make sure you use my charts and other methods of communication wisely and appropriately. If there are things that can be held and saved for the next visit in person, that's a great way of doing things if it's not urgent and pertaining to your immediate care needs. I think as healthcare providers, we are also burdened by multiple messages, and this is something that the patients can help us so we can provide better care when we see you in the clinic. Prepare for your visit. Again, communicate. We may not have all the answers, but we should listen. We can listen. And then the biggest thing that most patients have with the cancer is the lack of control. But control what you can. Control nutrition, activity levels, adherence to care recommendations, anything that you can control, it's yours. Remember, it's teamwork, not just your healthcare, but also within your family, caregiving, whether spouse, friend, whoever it is, you have to find your team. You have to find your team in the healthcare spectrum as well as in outside of the hospital, outside of the clinic, at home, at work, and that's helpful. To conclude, I think for neuroendocrine tumor, this is a very apt summary of how every stripe of a zebra represents a step in the story of survival. And all these words that come up when you talk about survivorship that are also applicable to neuroendocrine tumor: courage, persistence, survival, fiber, hope, healing. Thank you.
Today, we have been celebrating 20 years of progress in neuroendocrine cancer research and treatment. NETRF is here to ensure this progress continues. We need more treatments and ultimately cures. It is now my pleasure to introduce Dr. Anna Green, NETRF's Director of Research. Dr. Green leads our research program, works with our board of scientific advisors, and reports impact and outcomes to our community. Dr. Green will talk about new frontiers in advancing and strengthening research and NETRF's roadmap for the future.
Hi everyone, my name is Anna Green and I am the Director of Research at the Neuroendocrine Tumor Research Foundation. And today I'm going to talk about advancing and strengthening research and what it means for the neuroendocrine cancer community. So NETRF has a two-part mission. We support patients, families, and caregivers affected by neuroendocrine cancer by providing very credible and trustworthy education materials. We also fund research to discover cures and more effective treatments for neuroendocrine cancers, because we're trying to work toward a world where neuroendocrine cancers are both understood and curable. And so NETRF has been having a global impact since 2005. This is our 20th year anniversary, and we're proud to say that we are the largest nonprofit funder of neuroendocrine cancer research globally. We've invested nearly $40 million in research across 76 institutions in 17 countries. And we've also supported patients over those 20 years with trustworthy education materials. And so we drive research forward by funding cutting-edge basic and translational science with the goal of advancing our understanding and the treatment of neuroendocrine neoplasms, called NENs, or neuroendocrine cancer. Both of these are umbrella terms for neuroendocrine tumors, NETs, and neuroendocrine carcinomas, NECs. And so we have funded research across different primary sites over our 20 years as well, such as the pancreas, the gastrointestinal tract, the lungs, etc. And this broad approach is intentional. So learning something in one type of NET can inform how we approach it in others. And sometimes it even has ripple effects beyond NETs. So a good example of this is PRRT. This was developed and approved for use in NETs, but now it's being used in prostate cancer. And so we know it's important to continue research in neuroendocrine cancer because this disease is very complex and heterogeneous. It's a diverse group of cancers that remain under-researched. We know that there are limited effective treatments, so current therapeutic approaches have limitations, and this creates an urgent need for novel targeted therapies. There are also funding disparities, so even though neuroendocrine cancers have a rising incidence rate, they receive disproportionately less research funding compared to other cancer types. And so NETRF steps in to help fill this gap. And further, we know that there is an urgency now for more research funding. So the National Institutes of Health is the largest biomedical research funder in the world, such as for cancer research, but they've faced funding cuts this year, and there are more funding cuts proposed for next year. And so the urgency for funding is clear, and NETRF is a lifeline for researchers so that the discoveries don't stall. And so we've talked a little bit about the research that we fund, basic and translational research. But why does this matter? How do we know that it works? And so we can look at a very simple metric, the 3-year overall survival of patients, and look at that over time to see how it's changed. And so if we look at the overall survival from the years 2000 to 2004, we see that the overall survival was about 50% of patients. But if you look at 2015 to 2018, we can see that the overall survival rose to 85%, and that's a significant increase in overall survival. And so if we look at the treatments on the right, these are treatments that have been approved for NETs. You can see that most of them were approved after 2010, and so this correlates quite well with the increase in overall survival. But treatments don't just happen. They happen because of decades of research. And so we know it's very important to keep research going so that we can discover the next group of treatments for neuroendocrine cancer. And so if we take a look at our grant program, we fund basic and translational research at about 92% of our portfolio. And you can see this in the pie chart on the left. About 8% of our portfolio is focused on clinical research. If you look at the pie chart on the right, you can see the number of grants funded per primary site. And so you can see a range of colors here representing the different primary sites that we've funded over the years. Because as I stated before, it's very important to fund research that focuses on multiple types of neuroendocrine cancer, but it's also really important to fund research on specific types of primary sites. And so when I say that NETRF funds basic and translational research, what does that mean? So basic research is the building blocks of our knowledge. This discovers biological fundamentals of disease. So what causes neuroendocrine cancer to start? What's causing it to progress or metastasize? And what are some pathways that we can target to better treat it? Translational research then aims to move those discoveries from basic research toward the clinic. So this is where a treatment might be optimized. It might be tested in laboratory and animal models so that you can evaluate dosing and side effects before moving it toward clinical trials. And so clinical trials are the last phase of this biomedical research spectrum, and it occurs over phase 1, phase 2, and phase 3 trials. And these trials look at the safety and efficacy of these new therapies because we want drugs to be both safe for patients, but they also need to be effective. And so that's the purpose of these trials. And at the end, if a drug is safe and effective, it could be approved for use in humans. And so just like NETRF funds research across different primary sites, we also fund research across different grant categories. And this is because we recognize that researchers have different needs for their research funding. And so we have 5 different categories that we fund in. So we have an Accelerator Award, which is our largest award, that's really trying to pull together multi-investigators across different institutions for collaborative work that tackles very large neuroendocrine cancer problems. We also have an Investigator Award, which provides individual or maybe 2 researchers funding to pursue promising studies in neuroendocrine cancer. We have a Pilot Award, which is designed for high risk and high reward projects. And so this is for ideas that may not have a lot of preliminary data yet, but they're really promising ideas. And so this award really helps to fill that gap. We have a Mentored Research Award because it's really important to us to build the pipeline of neuroendocrine cancer researchers because we need a very stable workforce to pursue these challenging problems in neuroendocrine cancer research. And so this award supports postdocs and clinical fellows that are just getting started in neuroendocrine cancer research. And we also have a couple of different collaborative awards where we fund early career scientists. And so when we fund research, we're not writing a blank check to an institution or a researcher. We have a very rigorous process for selecting grant recipients. And so this process starts by issuing what is called a request for applications. You can see this on the left. So we issue this RFA that lets scientists know that we have grant funding, and it tells them what we're looking for and how to apply. We then receive applications and we send them out for review with a very expert group of scientific reviewers because it's really important that we have a process that is rigorous and that allows for the selection of the best science possible. And so after these applications are peer reviewed, we meet on a review call with the scientists who discuss the applications. They provide scores and comments. And then we're able to select the grants we want to fund. And this is based on, again, these scores, the comments, and also NETRF's programmatic needs. And so from there, they have to go to our full board of directors for approval. And so once we award the funding, our work doesn't end there. So we have a process where we monitor the grants. And so this involves receiving reports every 6 months on the research progress. We also have outcomes reports after the grant ends. So we continue to ask for updates for 5 years after a grant ends. And we also have an annual research symposium where we ask our researchers to present their results. So we closely monitor these grants to make sure they're doing the work that they're supposed to do, as well as to see what exciting outcomes come from it. And then we're able to share that with our community. Our RFA process has traditionally been what we call a wide net approach. And this means we don't tell scientists specifically what we're looking for in terms of science. So we bring in all kinds of ideas to select the best science possible. But we've realized that to really move the needle for patients with neuroendocrine cancer, we needed to create a more strategic research roadmap, which is a focused plan to address the most urgent and unmet needs in neuroendocrine cancer research. And so as part of this effort, we identified 3 core areas where progress is most needed and where research can have a real impact. And that's early detection, better treatments, and precision medicine. And so for early detection, one of the largest challenges for NETs is how long it takes to get a diagnosis. So on average, patients see about 12 healthcare providers over 4 years before getting the correct diagnosis. About 50% of patients are misdiagnosed initially, and by that point, about half have already metastasized. And so that's a major problem, but also a major opportunity. So if we can detect NETs earlier, we can intervene sooner and ideally cure them surgically to improve outcomes for patients. For better treatments, we're grateful that we have an arsenal of treatments for neuroendocrine cancer that have come about in the last 15 years or so. But current treatments don't cure the disease, they stabilize the disease. And so many patients can live with NETs as a chronic condition, which makes effective and tolerable treatments critically important. And so our roadmap prioritizes the development of new therapies that go beyond disease control, pushing toward better options for patients. And finally, the third pillar of our research roadmap is precision medicine. And so we know that NET patients are not all the same. They respond differently to the same treatments and experience different side effects and outcomes. Research has discovered biological subtypes that may one day guide treatment decisions. So our goal is to advance research that helps tailor care to each patient based on the tumor's biology and their individual characteristics. And so the goal of our research roadmap is to guide our funding strategy so that we can catalyze the breakthroughs that patients need. And so we've talked about our wide net approach to funding research. We've talked about our research roadmap. And so that really guides the future of neuroendocrine cancer research at NETRF. But I want to take a moment and really talk about the progress we've made over the last 2 decades. So research that we've funded have discovered for the first time new mutations in NETs, such as DAX and ATRX in pancreatic NETs, or CDKN1B in small intestinal NETs. Our research has funded work that has discovered new lung NET subtypes, and one in particular called supracarcinoids. We funded work on next generation radioligand therapies with actinium and terbium. We funded work that has developed new NET models, which are really important for scientists to study neuroendocrine cancer in the laboratory. And so we've funded work that have discovered new NET models, such as low-grade lung NET organoid models. The research we funded has validated new targets. So for tumors that don't express somatostatin, there is an unmet need to find new targets. And so one of those is UPAR, and it's heading to clinical trial. We funded work on PRRT radiosensitizers. So these are therapies that aim to improve PRRT for patients, and this has now gone to clinical trial as well. And we've also funded all the preclinical work in the first CAR T-cell therapy that's now in clinical trial in the US. And so we're very excited about the work we funded, but we're also excited about the future and what those next generation therapies look like. And so NETRF is committed to funding research until this disease is eradicated. And so just a few of those areas, this isn't all inclusive, but a few areas we're excited about are next generation radioligand therapies. So alpha emitters such as actinium or lead to improve PRRT. There's a new terbium radioligand therapy and also improvements to lutetium dotatate or PRRT as we know it today. There are targeted treatments in the pipeline. So new tyrosine kinase inhibitors, for example, cabozantinib is one that was just approved this year. There are other inhibitors such as RET, NTRK, FGFR for molecularly selected patients. And then there are other targets such as DLL3, UPAR, FAP, FA2, and others under investigation that we're really excited about. And finally, we're really excited to see what happens with immunotherapies. So checkpoint inhibition for neuroendocrine carcinomas, CDH17 CAR T for gastrointestinal NETs, and other therapies such as TILs, BiTEs, and antibody drug conjugates. So research doesn't exist in a vacuum at NETRF. There are ways for you, for patients, care partners to get involved in research. And here are just a few ideas. So every year we send out a Know Your Net survey where we ask for the community to contribute valuable data on what you're interested in. And we do read through all of this information to help develop our patient education programs. It also helps inform our research programs in terms of the problems that patients are most interested in solving. There are ways to join patient registries and biobanks for biospecimen donations. You can enroll in clinical trials to test new treatments, but these things, of course, should be discussed with your medical team. There are ways to share your voice, so you can speak at events to raise awareness about neuroendocrine cancer. You can create personal content through blogs and videos and social media about the disease to raise awareness. You can also take leadership. You can join nonprofit boards or grant review panels, engage in legislative advocacy for research funding. You can organize fundraising events like awareness walks or local gatherings. And if you have any questions about how to get involved, you can always reach out to us. And finally, our commitment to you is to have a focused investment in neuroendocrine cancer. Our strategic research roadmap ensures that every research dollar addresses the most critical gaps in neuroendocrine cancer understanding and treatment. Second, we have a patient-centered approach, so we have ongoing education and support for patients, and this is integral to our mission and complements our research initiatives. You can also join our mission, and together we can accelerate progress toward better treatments, improved quality of life, and ultimately a cure for neuroendocrine cancer. And I want to thank you for your attention and support today. And finally, I want to leave you with my contact information, Anna Green, anna.green@netrf.org, and feel free to reach out if you have any questions. Thank you.
Thank you, Dr. Green. Now it's my pleasure to introduce someone you may recognize. Jessica Thomas is NETRF's Director of Patient Education. She is the voice of our NetWise podcast and the creator of the thrivership program and thrivership Thursdays. She is a licensed clinical social worker and passionate about thrivership and empowerment. Jessica is also the driving force behind Know Your Nets. After Jessica's talk on living fully with neuroendocrine cancer, we'll take a short break and then we will be back with our live Q&A.
Hi, I'm Jessica Thomas, Director of Patient Education at NETRF. I'm so thankful to be here today to talk with you about net thrivership. We're going to talk about living fully with neuroendocrine cancer and how we can build our thrivership community and our thrivership resources. Below you see some icons, and each of those icons are programs that NETRF offers that have more in-depth information on each of the topics and categories that I'm sharing today. So please be sure to check out all of the different patient education resources that we offer, so that way you can continue to learn more. But we're going to go ahead and get started. Have you ever felt like your diagnosis of neuroendocrine cancer isolated you from others? I want to change that today. Let's talk about building a thrivership community and a thrivership system for yourself. So we're going to do this a little bit differently. We are going to do it through flowers. And I will be honest, one of the things that in the past couple years since I've been working with NETRF is I've learned to stop and look at the flowers and look at the small things that bring me joy. And so we're going to do something around the area of flowers for thrivership today. So we're going to start off. I got this branch from out in my garden. And to me, this branch represented neuroendocrine cancer. And the reason being is that it's a tree that kind of grows in, around my house that I normally wouldn't see in a flower arrangement, but see it at my neighbors' houses. But it's just sort of a part of the landscape here. And we're going to see how thrivership and other things that we can add in can help this be a more beautiful experience. So, what is thrivership? Thrivership is about giving space, acceptance, but it's not about giving up. It's about living fully. And thriving might look different for you versus another person. And so what we're going to do is we are going to talk about some main components for thrivership. Remember that you may or may not have all these components. You may decide to add some in, but we're going to start with some basic examples. So for thrivership, one of the most important things is to have really good medical care. You have heard about this all day so long in the program. So really good medical care makes a really big difference. And so on your thrivership team, your medical specialists may look very different, but they are a part of your team. Also, understanding your physical landscape. How are you doing? How are your tests? Making sure that you're keeping up with your scans and your annual appointments, etc. But your medical team is an important part. The next part of your thrivership plan is going to be coping with uncertainty. This is a tough one because neuroendocrine cancer is full of uncertainty. And finding ways to manage uncertainty is really important. And there's not going to be a part of this journey that is free of uncertainty, but learning how to manage and cope with it is a part of the thrivership journey. We have a lot of resources, especially in our thrivership series, that address this. Mental health matters. I was speaking with someone just today, and we were talking about how cancer is a physical thing, but it creates a lot of emotional challenges too. And so we're going to talk a little bit about mental health. So for mental health, I am going to pick a couple, just a bunch of these right here, because there's a lot of aspects of mental health. So there are mental health resources that you could have that are through like a counselor, through a support group, and active things that you do, like behavioral activation, making sure that you're exercising, making sure that you're journaling, etc. But knowing that if you are dealing with neuroendocrine cancer, it is not uncommon to experience anxiety or depression and or mood changes, and making sure that you're talking with your doctor about those, because we can also, if there's mental health challenges, also do things to improve emotional wellness, and that's a part of thrivership as well, emotional wellness and resilience. So for emotional wellness and resilience, see what I want to pick here. Okay, I'll do this really, really pretty purple hydrangea. Is for emotional wellness and resilience, these are the things that you can actively do, that you have control over to feel better. So this might be practicing mindfulness. This is definitely practicing gratitude. These are things that you are making an effort every single day to do. And we have a lot of emotional wellness strategies that are highlighted in our Thrivership series. And we even have a NetWise podcast that covers joy and happiness. So emotional wellness is a big part. So mental health support, what does that look like? So that could be, again, therapy or counseling. It could be peer-led support groups. It could be journaling or learning to participate in the expressive arts, spiritual care or meditation, and sometimes medication, psychotherapy, and more advanced intervention may be needed. Please talk to your doctor if you're noticing that you're having changes in your sleep, your appetite, and your overall quality of life. It could be related to mental health challenges. So let's talk about another thing we could add to this thrivership community. How about finding your community? So earlier I mentioned not doing this alone and changing that. Well, finding your community is a really important part. And so your community might exist in a support group. It may exist in a online support group. It may exist in having friends that you meet up with that have other chronic diseases or other cancers, or finding connections. Community also can be not cancer related. All of your thrivership should not be 100% cancer related. There should be parts of you that are not about cancer in here. And so maybe some of your community, some of your things that you do for joy and that you would like is outside of the cancer experience. But finding who your community is, who are the people, because you need social support and that matters. So another part of thrivership is going to be good rest, good sleep, and nutrition and exercise. That was a lot of things, but we're going to go ahead and put those in. So for, let's see, we'll put this really big, beautiful hydrangea back there. So this is good rest and sleep, eating well, and exercise, movement, things that you can do. All of these components really help your mental health. They also help your physical well-being, and they are things that you can control in your journey. If you have not exercised before your cancer diagnosis, or it's something that you're wanting to do right now, what I would advise for you to do is to talk with your doctor, possibly get a referral to see a physical therapist to set up an exercise program, or go to your cancer center and see if there's any recommendations. Exercise has been proven, and there's a lot of research right now of how beneficial it is for neuroendocrine cancer and cancer in general. I know eating is something that is very challenging. There's a lot of resources for nutrition and eating on our Net Knowledge Center and embedded in all the resources that we have as well. And so I encourage you to research more on how you can increase your nutrition and eat well as a part of your thrivership journey. And we are going to move to, let's see. This is kind of an important thing. I'm going to choose a sunflower for this. Research. Did you know that research is a part of your thrivership journey? And the reason why is that research really is a part of your lifeline. And the reason why is that with research, this is how we make progress. And so learning about clinical trials, registries, how you can participate in research, or how you can support research, or even how you can have a voice, a patient voice about how research impacts you or how you can participate. And how can you get engaged in research? Participate in patient surveys about research. You can do symptom tracking. Take a look at the Net Clinical Trial Finder and find out about clinical trials in your area. And then, of course, always go to NETRF and see what we're doing in terms of our funding our research projects. I know that Anna had spoken earlier and shared a lot of things about the pillars of our research program, and they're all here for you. And so knowing that research is a very big part of thrivership, and while you may be able to participate some in it, but it's always going to be there too as a support for you. The next thing we're going to talk about is the power of peer support. So we talked about connection and community and how important that is. Are you involved with a support group? If you're not, I highly encourage you to be involved. There are support groups that are online. There are some that meet in person, but more than anything, to help reduce that feeling of isolation and help to eliminate that sense of loneliness with this cancer. The next thing we're going to talk about is how relationships matter in the thrivership journey and communicating your needs. So relationships are an important part of a cancer journey and of a thrivership journey. And so making sure that we are communicating and cultivating strong relationships with the people that care about us and love us. And at the same time, making sure that we're communicating. We have, NETRF has some programs on in our thrivership program on communicating and talking to people that you love and communicating your needs. This can be a really hard thing to do. And if you're a caregiver today listening, it's hard for you too sometimes. So learning how to find ways to communicate your needs, because that's a sign of strength, not a weakness at all. And then we are going to talk a little bit about integrative therapies. So integrative therapies are a part of a thrivership journey. And they, are in many ways as important as other therapies and treatments that you get. But integrative therapies are things that you can do, like going to counseling, practicing mindfulness, they're hiking, participating in the arts. There might be things that you're doing that you can do that are complementary to the medical treatments that you're receiving, and don't hurt or cause any damage or conflict in that way, but actually help support your emotional wellness and well-being. So complementary therapies may be a part of your thrivership journey. And now I said therapies, and I think we need to talk a little bit more about other therapies, because
treatment changes are always going to be a part of neuroendocrine cancer. And so as we've seen in the last 20 years that NETRF has been around, we have had a lot of treatment changes. And that's incredible. And as there's more treatment options and more understanding about toxicities and also stratification of treatments, or what precision medicine, what is going to be the best treatment for you. Treatment changes are going to be a part of the thrivership journey. So allowing space for that opportunity that you may experience treatment changes too. So what are some other things, that we can think about that are a part of your thrivership journey? It may be unique to you. I want you to think about it. So I've named a couple of things already, but there might be some things that are already a part of your journey that are important to you. We're going to talk a little bit about gratitude. So I'm going to put this right here. Gratitude is a really big part of emotional wellness, and it can help with resilience, and it can help to rewrite how you look at things. Earlier in the beginning of this program, I talked about how I look at I look at flowers more now since I've been working with neuroendocrine cancer for the past 3 years. And one of the things I think that I do is that I've trained myself to look at beautiful things. So I'm going to ask you to consider, when you're having a stressful day, when it's been a hard day, or you are having maybe even a blah day, go on a walk, or go sit outside, or sit in your living room. Look around and try to find the little things that make you smile, that make you happy, and that you might be thankful for. The reason being is that when we do this, we get a little surge of dopamine and serotonin. It helps us to feel better, and then it ultimately helps us to move forward. It doesn't change that some things were hard, but it definitely can make things a lot better. So the next thing we're going to talk about is finding meaning and purpose. This is hard because disease can change what working is like sometimes. Disease can change, and often we identify our purpose with our occupation. Disease can change a lot of things, and cancer, in the face of cancer, it can make you rethink kind of, what is my purpose? And why we don't have to have a strong answer of exactly what our purpose is. I think knowing that redefining purpose is a part of a thrivership journey. So we're going to add a couple flowers in for this too. And the purpose is, things that you do, things that are unique to you. And they don't justify having cancer, by the way, because there's no justification for cancer. It's not that you have cancer, so this is the reason why. No, that's not, I think, fair or just. But it's a part of your thrivership journey. Kind of, my purpose has shifted a little bit, or what is my purpose going to be? And it might not have anything to do with cancer, and that is okay. But it is important to acknowledge that sometimes the sense of purpose changes, and that's a part of your thrivership journey as well. So we have a couple of flowers here left, and I want to think that there's a couple things that will be unique to all of us, and in our own journeys. But I think we can add in things like support from our care partner, your spouse, your friend, your child, your loved one, your neighbor, your coworker, whoever that is. They're a part of your journey as well. And we can also think about the beautiful people you meet along the way. When you go to get treatment, there might be a beautiful person in terms of how lovely and kind they are when you go and see them, and when you're going to get treatment, or you go to your doctor's office. That becomes kind of a part of a routine or your community. So your thrivership essentially can be what you make of it. Now, like any beautiful flower, and I'm going to set these down, we have to pay attention to how we take care of ourselves. We have to pay attention to our thrivership journey. I want you, as you're building your thrivership, how you live fully, to kind of look back and assess on it. How are things doing? Does my thrivership bouquet look full? Does it look like I need to add a little bit more self-care in? Or is it that I'm feeling lonely and I need to add more connection in? Or is it that, this treatment changes happened and I feel like I need to add a little bit more support and resources in? Part of being a part of the neuroendocrine cancer community, you are really surrounded by a lot of organizations that care big, including NETRF. And we have a lot of resources, a lot of support programs in terms of education. And we are here and we want to help you. NETRF is funding research for your tomorrow, but our patient education, our resources, and all that we do for your thrivership is here for your today. We want to help you in your areas of emotional wellness. We want to help you with as much education because we know that knowledge is power. And we're here as a resource for you. So in closing today, there are 5 things I want you to think about. Some actions that you possibly can take to help your thrivership journey. One is that I want you to map out your support circle. Know who's on your team, where you get your support, and where those gaps exist. Because we want to make sure that our thrivership together is complete with support. I encourage you to make sure that you are up to date on all of your medical appointments and managing your symptoms and really just possibly making one wellness check or one plan for wellness. What is something that you can do to add in for your self-care or wellness going forward? If you're not a part of a support group, I encourage you to attend an online support group or go to visit a support group. Make a connection. And I encourage you to create one small daily routine. One thing that you can do that's easy enough every day, a walk, a stretch, writing a sentence of something you're thankful for, or connecting with someone. One small thing that will make your day a little bit brighter and allow you to take care of yourself. And lastly, I encourage you to speak up about your needs. Whether it's a referral, information, or rest, whatever it is, to know that your needs matter. And these small changes, small little steps can make really big changes for you in the future. Thrivership is something that doesn't always feel beautiful, like a bouquet of flowers. I understand this. But what I want to encourage you is to know that there are things that you can put into your life every single day that balances out neuroendocrine cancer, that can give you little senses of joy, support, comfort, resources. And those are all in your control. My information is here. Please feel free to reach out to me if anything that I said you want more details about. And I encourage you to look at our Net Patient Guide, to access our Thrivership series that we do monthly, or to look at our Net Knowledge Center. And of course, to listen to our NetWise podcast. We have Thrivership materials embedded into all of these resources, and we're here for you every step of the way through your neuroendocrine cancer journey. Thank you.
Welcome everybody for our live Q&A. I'd like to thank you for being part of this magnificent conference today. And thanks, of course, to all our speakers, some of which are here today. And again, thank you very much for taking the time on your Saturday to join us. So we have Dr. Del Rivero, who's here, Dr. Paris, Dr. Liao, and Dr. Khan. We also have Anna Green from NETRF. So thanks again for all being here today. And what we are going to do is we're going to spend the next 35 to 40 minutes discussing some of the questions that either patients or care providers have sent us throughout the meeting. So I got a long list of questions, over 50. So thanks very much for sending all of these questions. Unfortunately, we can't answer all of them. We just don't have enough time. But I did pick up some of the questions that I thought were particularly relevant, and this will range from pretty sort of one-on-one basic net questions to more complicated and complex treatment sequencing questions. So let's dive right into this, and let's start with the first question. So the first question that one of our patients has asked is, what is the actual difference between grade, Ki-67, and stage? Perhaps we can have Dr. Del Rivero start with the first answer.
Yes, well, thank you so much for the invitation to be here today. So, a stage refers to the extent of cancer spread. Usually, that also includes where they're located, what is the size, as well as understand if they're spread in other places where also located. So that's usually a stage. It tells us in terms of if the patient is stage 1, if it's localized, to stage 4, which is called is metastatic spread. Now, gray, on the other hand, is describes more about how the cancers are looked under the microscope, and that can also indicate how aggressive they can be. And as you can hear earlier, between grade 1, grade 2, and grade 3, we know that grade 1 is also correlate with the Ki-67. And the Ki-67 is a method that the pathologists use in order to also understand differentiation and how the cells are able to divide under the microscope. And when I say grade 1 is based on the Ki-67 number, if it is less than 3%, we know it's grade 1, it's well differentiated. Grade 2 is between 3 and 20%, and grade 3 is greater than 20%. But that's I hope that explained the difference between grade and stage, unless anybody would like to add something. Thank you.
Absolutely. Thank you very much. Dr. Perez, how do you determine whether my neuroendocrine tumor is indolent or whether it is an aggressive tumor, and can that change over time?
Thanks for the question. So, indolent mean the definition really is slow growth, and more aggressive would be faster growth. And when we talk about it, commonly is just the rate or the progression over time. So we're looking at scans and the change in dimension, change in the areas of the body that the tumor cells are spreading to. So if we're seeing something take years to grow in dimensions of measured in millimeters, we would consider that indolent. If we're seeing something grow, millimeters or centimeters over 3 to 6 months, we would consider that more aggressive in nature.
So one of our patients has asked also about grade creep, and perhaps Dr. Liao can take that question. What is grade creep? How common is it? And how do you detect it?
Yeah, good question. So grade creep is this phenomena where, maybe your tumor started off with as a low-grade tumor, so, well differentiated grade 1, KSE7 or 2%. And then over the course of treatment, the tumor kind of evolves. And I should say that, these tumors are made out of different clones of cells. And so these different clones evolve, and maybe one clone emerges throughout the course of treatment. So for example, let's say, if you have a pancreatic neuroendocrine tumor, at diagnosis it was grade 1, KSE7 or 2%. And then after, let's say, PRT or CAPE-TEM, and 5 years later, we see the tumor is growing again, and then you do a repeat biopsy, and now it's a well-differentiated grade 3 tumor with a KSE7 30%. So very different than the original diagnosis. And this is due to probably the evolution of the different clones of cells that make up a tumor. And as it gets exposed to different treatments, these clones kind of evolve. And we do see this quite a lot in our clinical practice, and also has been described in the literature as well.
Is it more common in one particular tumor type than another? And how do you realize that your tumor is undergoing grade creep?
Yeah, good question. In my experience, I see it more in pancreatic neuroendocrine tumors than small bowel. I don't know if the other oncologists here have a different experience. And usually the telltale sign is if the tumor is behaving differently than before. So for example, if it used to be very slow growing, and then you see this like one particular tumor, say in the liver, double in size within 3 months, then that's a sign that there's something different about that tumor that it's doing compared to before.
Dr. Perez, any other insight in grade creep?
I think sometimes though, with grade creep, we're sometimes fortunate to see that change when we look at, we perform a second biopsy. But I think also probably more commonly, we see the change on imaging and clinically, but we do the biopsy and we don't always see that change. And I think it's sometimes difficult for patients to kind of put together when we're saying that the Ki-67 is the same as their disease was 3 or 4 years ago, but the disease itself is acting very differently.
Okay, now I'll ask you a follow-up question that the patients did not answer, but what you've told me, if I would be a layman or laywoman, would sound like, it sounds like certain therapies can induce grade creep. So should we avoid these therapies, or is this just part of the game? And is there any particular sequencing of therapy that is more likely to induce grade creep? So should we give the chemo maybe before PRT or PRT after chemo, or does it matter? Has this been studied, Dr. De Rivera?
Yeah, it's an excellent question, and it's a research question as well. We're trying to understand whether there is any factors that had, make the tumor from being less aggressive to more aggressive. What I can say is a lot of the therapies, different therapies tend to also disorganize some of the cells in a way as having their killing effect. And thus we would say that that's when the tumors may acquire more mutations. As we get older as well, and it's part of life in a way, we do acquire mutations over time because there is external factors that can also cause that. And as you know, Dr. Hagen, you also study a little bit of epigenetics and understand those factors as well. What we know is that there are certain therapies that can't increase this burden of mutations. In that situation, can sometimes disorganize the cells in a way that there may be a clone of cells that they may be more aggressive compared to others. There is also an idea that sometimes when a patient may have treatment with PRT, and maybe I would like to know the thoughts of Dr. Perez or even Dr. Hoyen as well, since you do research in that aspect as well, Dr. Lyle, is that sometimes, when there is a type of treatment that can't has an effect on the bone marrow function, and then you have another therapy like temozolomide, which is an alkylating agent that can also has an effect as well on the bone marrow function and have a further increase the risk. So sometimes we see an increase of MDS, but at the same time, we have seen that the clonality of cells, so how the cells that are able to differentiate, may also change. That said, it still is a research question. I think we're still trying to understand that aspect. And when you say about sequencing, we also said that there is not a one size fits all for neuroendocrine tumors. The treatment is personalized from patient to patient, understanding also the clinical characteristics of the patients, understanding what is the volume of tumors or how much tumors is seen in the body, whether it's in the liver or not in the liver, whether it expresses somatostatin receptor or not. I think there is a lot of clinical characteristics that help us guide the specific therapies or the therapies that we think in terms of sequencing for patients. But now we are understanding as well as the many side effects that we over time we have learned. And in that situation, we also make the recommendation and the explanations of what we see in the different therapies.
No, I agree. I think it's a really important question, and we have a lot more to learn, right? The next question is an interesting one, which goes a little bit into this. It's a treatment sequencing question, since we're talking about this. And perhaps like Dr. Paris can help us answer this question. Are there molecular markers or tumor profiling results that could influence treatment choices? And I would add to that a second question: should everybody that has a neuroendocrine tumor that is metastasized undergo genetic sequencing or at least molecular profiling if there are certain markers that would change our treatment choices?
Yeah, I think that's a great question. I think what's unique to neuroendocrine tumors is the fact that traditionally it had been considered somewhat molecularly bland when we looked at it. And so, unlike some other cancers where there have been targeted therapies based on a genetic profile, neuroendocrine tumors have not always had that. But I think as more novel therapies arise and as the technologies have become more accessible in profiling the tumor DNA, I think it's just so much more important to consider having tumors be profiled because of the newer targeted therapies that are available. And I would say that pancreatic neuroendocrine tumors tend to be the one amongst the neuroendocrine tumors that seem to share some of the mutations that we can see in kind of the unrelated pancreatic cancers, like the pancreatic adenocarcinoma, where we may see things like KRAS mutations, we may see things like BRAF mutations. And I think that's where we have in oncology in general have come up with impressive targeted therapies that patients can safely receive if their tumors have that profile. But I would say we're still kind of compared to other more common cancers, probably not where we need to be in regards to targets and genetic profiles for the tumors themselves.
If I can summarize your answer, useful in certain situation, probably not commonly, but certainly more research needed, and hopefully we'll get one day where we have real reliable biomarkers, right? Can we
You
agree
caught
on
me on
that?
that. I talked instead of just saying
No,
we're working on it.
No, that's perfect. I just wanted to summarize because this is exactly how I see this too, to be honest with you. I mean, certainly all on this call have done different research about different biomarkers and prediction to certain therapies. We have researched how, for example, in peanuts, MEN1 mutation, could potentially increase progression-free survival after PRT, but it doesn't necessarily mean that anybody with a MEN1 mutation should first get PRT before they get like CAPE-10, right? So these are all questions that I think we still need to research. I'm very happy to see that Dr. Chandrasekaran has joined. So, Dr. Del Rivero, you had a comment.
Yeah, I was just wondering if I could add just a small comment because
Sure, of course.
Perez said, in terms of, when and the indication of doing molecular testing. But sometimes when I hear some of the patients saying, well, I want my tumor to be tested because I wanted to know whether I have something that may affect my children's, right? So, and I think it's important to differentiate, when they do genetic testing, because that's kind of within the umbrella of genetic testings, that there is testing that is done in the tumor, which that's called, we call molecular testing, a molecular panel, which is only done in the tumor. And there is also germline testing, which is done, and it's usually a saliva or a blood test. And that's kind of like tells me whether there is any risk of a familial predisposition syndrome. If it's positive, it will appear at every cell in the body compared to the somatic, which is only in the tumor. Now, when I say germline testing, if there is a question about what is the risk that I may have a familial syndrome related to neuroendocrine tumors, as I mentioned earlier, is usually 10%. But the ones that we have seen in more association with the familial syndromes is the pancreas neuroendocrine tumors. But usually, in order for us to determine there may be a familial syndrome, there is other clinical manifestations that help us suspect that. So the neuroendocrine tumor by itself, it doesn't mean that that will be associated with a germline or familial syndrome.
Very important to
Can I add
make sure that everybody
something?
understands. Yes, of course.
Yeah, so there could also be a role for testing for neuroendocrine carcinomas. So just wanted to kind of put a pin in that. And then for unknown primaries. So if you, profile the metastasis, it might give you some indication of where the unknown primary is.
That's also a great point. For example, somebody comes to you with metastatic disease, you can't see anything in terms of primary tumor, but you sequence the tumor, it shows you a MEN1 and a DAX mutation. That's going to be a pancreatic neuroendocrine tumor, which again may influence your treatment, because if first line or second line is going to be chemotherapy like CAPE-10, we know that tends to work better in PNETs than in small bowel nets, right? So that's one of the example where this could certainly play an important role for treatment choice. Thank you very much. Very important point. Let's go to Dr. Khan so he doesn't fall asleep on the call here. So there was a liver-directed question specifically about insights about when to use histotripsy as the right treatment for a liver metastasis. So the histotripsy is something that we've talked about a lot, I think, over the past few years. Can you tell us, to you in your mind, what is the ideal candidate for liver histotripsy?
Yeah, I would say that one, it's a very new technology, and we're still figuring out the appropriate clinical setting, the appropriate ethical setting to use it. Certainly, it's one that shows promise, but treat every potential tumor that can be visualized on imaging. There's a lot of questions that go into it. So the initial evaluation to see if the lesion is even amenable to histotripsy is to visualize it under ultrasound. Most of the tumors that we can treat with the curative intent are usually 3 centimeters or less. And so those are sort of the primary considerations. Whether or not that's a single lesion that's been progressing, some of the trials have done like 1 to 3 lesions that are less than 3 centimeters. So multiple lesions that can be treated with curative intent, those are the ones that I would consider as ideal candidates. Certainly, there's some wiggle room in terms of can we combine treatments with histotripsy and blend embolization. That's sort of what been looking into with some of the patients that Xavier sent over to me. But whether or not those yield significant results in terms of treating one area and other areas the tumor is decreasing, those are all things that are under research consideration.
Is location important? So, for example, I'm assuming you have to see the liver tumor on ultrasound, right? So,
Yes.
tumors, for example, that are at the dome, at the very superior part of the liver, right under the rib cage, is that generally an issue?
Yeah, typically ones that are located up at the dome are difficult because there's adjacent or superimposed lung, and histotrypsy requires sound waves traveling through a medium. They don't travel through air. And of course, your lung is filled with lots of air. And so those are not ideal locations for histotrypsy. Usually, the ideal location is the anterior lower part of the liver. Some of the central lesions are better suited for histotrypsy. Comparing it to ablation, the closer they are to central structures, there is sort of a benefit there because thermal ablation or microwaving a tumor that's close to arteries or veins or the bile ducts can be a little intimidating, and then histotrypsy offers the potential since it doesn't injure those structures. So those are all things under consideration for histotrypsy.
Great. Thank you very much. Let's move a little bit into the PRT category. So it's a broad question, but I think it's an important one, which is how do you know when to initiate PRT? How much tumor growth do you need to have? How much spread do you need to have? What if there is spread and growth in multiple locations, but the tumors are very small? So what in your mind is an ideal candidate for PRT, and should we start it early or should we wait later in the treatment course?
The one easy answer to the question is who is a candidate for PRRT, since the peptide receptor therapy is hinging upon the presence of these octreotide receptors. The first answer is only patients who have adequate octreotide receptor expression on the tumor surface are the candidates to be considered. And that's important when you look at certain subtypes like lung neuroendocrine tumor patients, or even within rarely you see even small bowel neuroendocrine tumor or pancreatic neuroendocrine tumors not have enough octreotide receptors, or the higher grade tumors. In interpreting the results of the PET CT, I think that's important because a lot of times we see these PET CTs reported as positive, but when you actually have it reviewed in a high volume neuroendocrine tumor center, the degree of octreotide receptor expression is not very high. So key thing for the patients to recognize, if the doctor says it's positive, it could mean still nothing until it's truly positive, which means the tumor cells are lighting up as good as the spleen or better than the background liver. So that's key thing. So if you don't have receptors, not a candidate for PRT. The second part of the question that is asking about when is a good time, I think that's a question that is not just relevant to PRT, it's in general a question that's relevant to pretty much any therapy option. We have patients where we just say, hey, let's just wait and watch, you're doing fine, you don't have symptoms, and then the tumor is slowly growing or every scan shows something, and then the question comes up, when do we start treatment? So that is an answer I would say not restricted to PRT, but in general. I think we do have some data, definitely clinical trials like NETRF specifically, which is a trial that looked at PRT upfront in specific subset of patients. So those that have high grade, the proliferation rate we call as Ki67 greater than 10%, and looking at it upfront. So no doubt PRT is an effective treatment, maybe even more effective in pancreatic neuroendocrine tumors or some of the higher grade with more response rates. But this time we don't have data that the overall survival has improved by doing it earlier. So I don't think these trials answer the question to me about everybody needs it upfront just because you met the criteria of high grade tumor. Now, if a patient is very symptomatic with high volume and we are thinking about an option that would give them a good chance of shrinkage and improvement of symptoms or volume of disease, certainly this is a good option to consider. Now, speaking of patients who have a very slow, indolent type of growth, gradually growing every single time, I think it's a very hard decision to make as to when do you treat and jump to the next treatment. I think this is really where we spend most of our time. I wish we had like metrics. I'm curious to hear about all our other colleagues on the call as to are there decision factors that help. To me, what I practically use in clinic is still rely upon the sense of growth or the pace of the growth of the tumor. If there is growth like of 1 centimeter over 2 years in a grade 1 small bowel neuroendocrine tumor, that would still necessarily not push me to say, let's just do PRRT. So if it is a consistent growth in the sense there is definitely like more than 1 or 2 scans consistently showing a trend of increase, or the increase in such a way that I'm worried about if it continues to increase, there's going to be trouble. There's going to be some kind of a symptom. Those would be the factors I consider when recommending a treatment or a PRRT. I mean, that's not just PRRT, like I said, any type of treatment. And the second factor is, of course, the patient's preference. I think it's not the second factor, probably the primary factor as well, right? There are patients who would be hesitant to go forward with treatment in that situation, in that particular year of their life. They could have other things. And honestly, if there's no urgency, I would say, well, maybe not this year. That's fine. It's not going to change your treatment in the overall longer run. So wait it out. Let's see what happens to the tumor. Let's do it next year if it's a school holiday, summer holiday for you, or something like that. So there is no good answer and no biomarker, no amount of a certain tumor percentage growth. A lot of the clinical trials do use the index of growth over the past 1 year or 6 months by a certain percentage, what we refer to as RECIST criteria. So sometimes I do use that in clinical practice as well.
Great, thank you for this very comprehensive answer. This is fantastic. Dr. Liao, I'll follow up on this with you. So, because I have done many clinics with you, and many times I see you take decisions on when to use PRT. So, two questions. Does the location of the tumor matter, or the distribution, I should say, throughout the whole body, right? So let's say you have somebody that progressed on long-acting octreotide, right? But the majority of this disease is, let's say, in the bone versus in the abdomen or the liver. Does that matter in your treatment choice, number one? And then what about volume in general? Are you somebody that thinks that the larger the volume, or particularly if you have a very large tumor in addition to many other tumors, that tumor should be maybe targeted separately in addition to PRT with something else? How do you see those two factors?
These are great questions. So location definitely matters, or the, pattern of spread of the disease. That's yet another factor, in addition to everything that Dr. Chandrasekaran mentioned, that factors into our decision of whether or not to pull the trigger for PRT. So if you have, disease that's all over the body, bones, lymph nodes, liver, etc., then it may make sense to choose a treatment that will treat the entire body at the same time. But on the other hand, let's say if only the liver tumors are growing, or most of the disease is in the liver, then there are other options. There are liver-directed therapy, and we're also a center that does liver debulking, and so we sometimes do surgery. So I think the location of the disease, the pattern of spread, and the pattern of growth, what's growing, I think those are all important considerations for us to decide whether it's PRT or whether it's local regional therapy. And then the second question is also a good one. So the volume of disease. So if someone has a lot of liver metastases versus someone who have small tumors in the liver. And, there's data from the NETRF study originally showing that people whose liver tumors are smaller actually benefit better from the PRT. If you think about it, PRT is kind of one size fit all. Everyone gets the same dose. And, there are new ways of trying to kind of improve upon standard PRT. One of them is called dosimetry. So like calculating the dose based on the distribution of the tumor and the uptake and things like that. And so I do think that the volume does play a role as well. And the NETRF study already showed us that the patients who have smaller liver tumors do better with PRT versus people who have bigger tumors.
Thank you very much. Okay, let's go to more diagnostic question, but related to PRTs to a certain type. And, this is a question I think every clinician gets quite often after patients have read the reports of the PET scan and show up in clinic. And the question is, what is more important on the PET scan? Is it growth or is it avidity? I think that's an excellent question, because many patients, I think, get scared when they see, oh, my SUV max went from 24 to 43. What does that actually mean? Dr. Paris.
Oh, I was going to put my finger on my nose as like a not it. Just kidding. So I think what I explain to patients is that we have two different PET scans that are available to us, and one has been around for a much longer period of time. So when we talk about something lighting up in the SUV, that patients will see numbers in parentheses next to a description of a finding. The older PET scan that's used more commonly for other types of cancers, there has been a tremendous amount of work correlating the changes in that value with the activity of the tumor, where for neuroendocrine and with the PET dotatate scans, I think we're still very much trying to figure out how to correlate that number with the activity. And then the size, when we're looking at PET scans, becomes a little bit, even a bit more tricky. And I definitely, this is where patients get a little bit more confused because they'll say, I just had a CAT scan or an MRI and my tumor was this size, and now the PET scan says it's that size. And what I try to remind patients is, one, it truly could be representing that there's a change or a growth, but it also is that the functionality of the PET scan is one in which it's kind of like a sparkler on the end of, attaching to a protein or, something anchoring it into the tumor cell. So you're going to get, if you think of a sparkler, since it was just the July 4th holiday, you have this really small stick, but you have a very big spray of color. And that's really the problem when it comes to measuring the tumors with the PET scan. So always take the size with a grain of salt and just know that we are all working on trying to figure out what that number means and how relevant it is for your care and for your treatment options.
That's a great answer. I completely agree with you. You call it a sparkler, I call it the light bulb effect, the halo, where sometimes, something just appears bigger as you get closer to it because of the light halo, but it doesn't necessarily mean that the size is actually like that. Does anybody on this call look at SUV max and change in SUV max? So let's say we have a patient that has had a gallium-dotatate PET a year ago, has another one now. The disease distribution looks exactly the same. The size, like you mentioned, is hard to measure, but comparing side by side looks pretty much the same. But the tumors look much more intense, so they have more SUV max values or higher values. Does that matter at all to any one of you, or would you say it really doesn't at this point?
Do we look at it? I think yes, out of curiosity to learn more, as Dr. Perez mentioned. Do we ever use that to necessarily decide on things? Not less likely. There are some studies that have looked at a certain level of threshold of SUV, not the change from time, but rather the actual cutoff of if your SUV max. There are some literature studies that say that a 16 number and over may indicate more receptors or those that are candidates for PRRT. Again, there's a lot, that's not clear in that kind of these studies. So for that reason, I do look at the SUV, but not necessarily look at the change in the SUV from a treatment decision perspective.
Thank you for that. So an interesting question that is a more general question as well, but I think a really important question. And I'm sure all of us being a multidisciplinary high volume center, we get asked this question. When should palliative care or integrative oncology teams be involved in my care? I think that is a really important question. Dr. Del Rivero.
Thank you so much. Very important questions. And usually in terms of somebody seeing a palliative care physician, I usually recommend from the very beginning on the journey. Sometimes that is a scary word for a lot of patients because they feel that when it's palliative is the end of their disease course, end of life. But that's not necessarily the case. So usually what I tell the patients is that palliative care is important because it helps patients to then live their best life possible while also understanding the journey of the disease and also have appropriate measurements and also appropriate support in order to understand and live with the disease as well. But I will say I will definitely want to ask Dr. Chandrika, since that's one of her area of expertise.
Yes, if I can ask another question for you, Dr. Chandrasekaran, what can palliative care offer, or what does palliative care discuss that perhaps the medical oncology team does not?
I think that second part is also a very interesting question. And I think it's a little bit different from other cancers in terms of, specifically neuroendocrine or any other cancer that has a more indolent course. There's lots of base literature about early integration of palliative care, for example, in lung cancer, maybe even improving survival. So Dr. Del Rivero summed it up very nicely. It's about living your best life, right? Enabling that. So the first thing is to remove the stigma of palliative care being like a negative connotation. Think of it as a supportive care. Anything that helps you live with a cancer, with a life-limiting illness, which definitely neuroendocrine tumor is. And that support for different patients can come from different ways, whether it's a symptom management question or what do we call anticipatory grief in the setting of cancer that may be life-limiting or life prognosis, or for some patients, patients, even some diarrhea management, though we do have some traditional tools of diarrhea management, which is a common symptom, fatigue, which is a number one symptom reported by neuroendocrine tumor patients with neuroendocrine tumor, sometimes shortness of breath. So a whole bunch of symptom management, interventional with medications or non-interventional, supportive care therapy, psychiatric counseling or a therapist. It's a whole bunch of services that they can offer. And again, every patient has different needs. And so it's I think many times the medical oncologist or surgical oncologist or whoever is your primary netologist is kind of your person, and they have to definitely include palliative care depending on the need of the patient at some point in this journey. What do they offer that a medical oncologist does not offer? I don't think we should single out medical oncologists thinking that everybody is a palliative care necessarily comfortable with it, right? It's any oncologist or any surgeon or any specialist, let's say. Why would it still be helpful to be seeing a palliative care team dedicated to that versus just folding it into your regular oncology care? Now, some of this may not be literature supported, but there are issues that the patients may hesitate to discuss with an oncology team or surgical team, that maybe this is a different platform for them to voice those concerns. For example, there are some studies in palliative care that have shown that patients who's felt, if I talked about this, my doctor is not going to recommend a therapy for me because I'm mentioning the symptom. They're going to worry I can't handle this treatment, right? So they may hold back on that. So just an example of how a separate dedicated team is still helpful. And in the practicality, I'm palliative care trained and I'm oncologist. I try to wear two hats in one clinic, and we can't. We have a certain amount of time and we can spend a certain amount of time. I want to focus on the disease at sometimes. I want to focus on the symptom. So sometimes having this dedicated team, especially in patients who could potentially benefit with high symptom burden or any sphere, physical, psychological, would be helpful. They are just a wonderful team to have on your team when you need them. So I don't know if that answered the question generically, but the timing of when to introduce, is there like any literature to say at diagnosis, midpoint, later point? I think that's really no literature.
Thank you very much. Very comprehensive answer, and I think a very important question. Now, you mentioned diarrhea. Nobody wants to talk about diarrhea, but it's a nice segue to the next question that I have for Dr. Liao, which is, how do somatostatin analogs control symptoms from small bowel neuroendocrine tumors such as diarrhea when that is also considered a side effect of the drug? How do you know the difference, Dr. Liao?
That's a great question. So there's often many different reasons for diarrhea, and sometimes we really have to tease it out from the patient's history to figure out what's the predominant reason. So, carcinoid syndrome, serotonin, that can cause diarrhea. So that's the hormone that's secreted by the tumor. Somatostatin analog in itself can cause diarrhea as a side effect. It can also cause pancreatic insufficiency, which can present with not just diarrhea, but bloating, flatulence, foul-smelling stools, greasy stools, oily stools, and things like that. A lot of our patients have had surgery, so having had their terminal ileum removed, they get into issues like bile acid reabsorption. And then typically the history is, I wasn't having diarrhea before surgery, and suddenly after surgery, I'm having like nonstop diarrhea. And that's treated with like things like cholestyramine. And then some patients have lots of small bowel removed and they get some kind of malabsorption diarrhea. So there's often a lot of different reasons, and sometimes there's many reasons going on at the same time. And so really have to take a careful history. So for example, if the patient's saying the 4th week after the lanreotide shot, the diarrhea is coming back, the flushing is coming back, well, maybe then primarily then it's the issue of the serotonin of the carcinoid syndrome. And so I think taking a very careful history is key to differentiate the different causes.
Thank you very much. Going back into the PRT category, Dr. Perez, what is the best alternative to PRT if I have renal insufficiency? So can those patients still get PRT, or is this an absolute no?
I'd say there's no absolute in any of the treatment options that we have. And I think for patients who have a diagnosis of renal insufficiency, working with a nephrologist to really characterize the chronicity of it, the stability of their kidney function, optimizing if chronic, addressing any acute issues or medications that may alter their kidneys' tolerance of it. I think what we have found, though, with longer term follow up and more patients receiving PRRT, that the radiation impact on the kidneys is real, and we need to consider it. And I think as we're looking at new radioligand therapies, it's still on the forefront of our concerns for toxicity. But I think with the protein fluids that we give immediately after the PRRT, we're actually seeing that the protective benefits of that has really limited the concerns that we had initially.
Would you adjust BRT dose in some patients? So give them, let's say, half a dose if their renal function is below a certain threshold. Is that something to practice, or
It
everybody
has
gets the
been.
same dose regardless?
No, I think that has been the benefit of practicing during a time that this is becoming more and more available, and there's more and more patients that are receiving it, that we can come at this in the same way that we're coming to the table with medicine or chemotherapy-based options. It's really what's going on with the patient, what's their blood counts doing, what are the kidney function, all of that during the time that they're receiving PRRT from the get-go, adjust and readjust as they continue on treatment. So I think that we're getting there, and I think with dosimetry, that's also going to influence it. So I think that there's not going to be a set exclusion necessarily as we fine-tune how much we give it, and really allow it to be more patient or individual based.
Perfect. Thank you very much. One question that is close to my heart, because I think it's a controversial question and finally relates to surgery a little bit, is a question that one of our patients asked, which is how important is it to locate and remove the primary tumor with all these treatment options that are available? Who wants to take a jab at this?
I'm volunteering you.
Okay, well, I thank you very much. So I would say it depends. So there are certainly studies that are all retrospective and probably all biased, and that I've written myself in part, that says that removing of the primary tumor might improve overall survival. I think it's a very controversial topic. And I would say that there are certain situations when, in my mind, it's a slam dunk. So if a patient has a small bowel neuroendocrine tumor and is symptomatic from the primary tumor, such as cramping or difficulty eating, weight loss related to that, I think that patient needs to have the primary tumor removed, even if there's too much metastatic disease to do something surgically. I think this is something that is really going to help in the long term. On the other hand, when we talk about pancreatic neuroendocrine tumors, they're rarely symptomatic. I mean, some can obviously, depending on where they are located, if it's in the head of the pancreas, cause biliary obstruction, for example, but that generally gets treated very well with stents nowadays. When they're in the body or the tail of the pancreas, they rarely cause any unless they're very large and like compress the stomach. But I think when it comes to removal of primary tumor, it comes really down to quality of life is number one. Is this tumor symptomatic or not? And if it is, and it can be reasonably removed without delaying therapy too long, systemic therapy, I think that that's something that we should consider. I'm sure you've all seen and heard of patients that have had, for example, peritoneal disease or even a lot of mesenteric disease or multiple small bowel primary tumor that receive PRT and get into small bowel blockages. That's a potential side effect of PRT. So again, I think carefully studying what and how this could be helpful for our patients is certainly something that we still need to do. And I would say it makes sense in certain situations. Sometimes we can't find the primary tumor, right? I'm sure we all have patients where we cannot find the primary tumor. And does it matter? Well, again, we talked about this with Anna before. It can sometimes matter for treatment sequencing perspective to try to figure out where the primary tumor is. But even if it tells you it's a PNET, on molecular testing, you may never see a PNET. So that certainly plays a role as well. And I've also had patients that had limited liver disease. I've debulked, and the primary tumor even 5 years later has never shown up. So, these are all possible scenarios. And again, I think what you probably all learned throughout this conference, and I think we can all agree on that, is that every patient is unique. And yes, we have great treatment options and choices. And yes, we have done tremendous progress over the last 10 years, and we will continue to do that in terms of treatment. But the truth is every patient is different. Every tumor will behave differently. And so this is why it's so important to continue the research, number one, and to also be seen in a multidisciplinary center where there's a tumor board and where clinicians really have the experience to try to choose what's the best therapy for you. And sometimes there isn't the best therapy, and it's really up to the patients as well. So this is it. So I got to talk the last 3 minutes. Thank you, Kim, for letting me do this. And thank you to all of you for spending your Saturday afternoon with us. I really, really appreciate you taking the time off to answer these questions. I would like to commend all of you for tremendous conference. I'll also like to thank Josh, who is on this call here. He's helped with gathering all the questions and posting them. And of course, I'd like to thank NETRF for, again, organizing a fantastic conference. And we hope to see you next year. So thank you very much to everybody.
Great, thank
Take
you.
care.
Thank you.
Thank you for attending Know Your Nets and spending this time with us. We hope you have increased your knowledge of neuroendocrine cancer. I want to recognize Dr. Xavier Koitkin, my co-chair, for his leadership. We are grateful to all our speakers who shared their time and expertise, and to our thrivers who offered perspectives and hope. This has been a NETRF team effort, with special thanks to Jessica Thomas, Jennifer Long, and Anne-Marie Green for the tremendous work to bring you Know Your Nets. Rich Tamayo is our video producer, and Josh Mailman, a member of our NETRF board, helped to manage the Q&A. Know Your Nets is possible because of support from our co-sponsor, University of Chicago Medicine, and all our sponsors, Exelixis, Curium, Crinetics, ITM, and RaiseBio. Above all, thanks to you, the neuroendocrine cancer community. If you missed any parts of this program or want to watch it again, we will be posting the conference video on our YouTube channel. You'll also be receiving a survey in the next few days. We love feedback, so let us know what you learned and what we should include in future programs. If this program has been helpful to you, please support NETRF. We depend on community support to advance research so people with neuroendocrine cancer will have more treatment options. You can visit our website to learn more about our Breakthroughs Today, Cures Tomorrow campaign. That's netrf.org. Remember, NETRF is here for you. You are not alone.